So, a very good morning to everyone. Myself, Dr. Swam Prabhasal, on behalf of Scientific Committee 19th PG Convention, uh, uh, which is being held on this virtual platform. So, hope you all are doing well in this pandemic. So, let's begin our first session of paper presentation. Here, our chairpersons are Dr. M.D. Jalaluddin, professor from Department of Periodontology, Kalinka Institute of Dental Science, Bhubaneswar, and Dr. Hika Singh, sir, reader, Department of Periodontology, Institute of Dental Science, Borelli. Sir, please, I would like to request to chair this session. Then I would like to call our presenter, Dr. G. Lakshmi Sri Divya.
Morning, Jalaluddin, sir.
Good morning, everyone. Myself is Dr. Divya. I'm from JSL Dental College. Here, I'm going to present a paper regarding the oral hygiene practice and awareness among the first year students of the UG professional courses, which was the study done in the Rajahmundry, and it was a comparative study. Coming to the introduction, oral hygiene maintenance is a key factor for the good oral health. Assimilation of the knowledge over the oral health is important to adopt the self-care practices that improve the oral health. As we all know, dentists and the medical practitioners play a vital role in raising the awareness of the oral disease prevention. And early screening and the proper referral by these professionals is necessary for the providing to access of the oral hygiene problems. The knowledge and awareness of they are going to acquire at present will be reflected in the future during their practice. Coming to the main aim of a study, the main aim includes that is to compare the oral hygiene awareness of the first year dental, first year engineering, and the first year medical students in the Rajahmundry, and the objective is to evaluate the basic oral hygiene knowledge and awareness using a pre-validated closure-ended questions, which includes the 15 questions. And here only the first year students were included because the second year students will have the knowledge while they enter into the preclinical labs, which will cause the chaos of the study. Coming to the methods, it is a prospective study and a cross-sectional study which includes the comparison of the oral health awareness among the students of the first years regarding the BDS, BTech, and the medical students. And the sample size is calculated by using the following formula, whereas the N includes the population size and E is an allowable areas. And this study includes the 50 students from the each group, and medical, engineering, and the dental students. The students were asked to fill a questionnaire pertaining to the oral practice awareness on the oral health, and this pre-evaluated 15-item questionnaire questions were given to each student, and data was collected and subjected to statistical analysis in the form of the numbers in the person. The questionnaire includes based on the knowledge and pertaining to the oral health and regarding the how they perceive the oral health state and how often they visit the dentist and do they prefer the method of using the teeth and what brushes they use and how much time they use for the brushing of the teeth, method of toothbrushing, and how many times they use the brush and frequency of cleaning their tooth, changing their toothbrush, and whether they habit of using the tongue cleaner, do they have any other oral health needs, and do they use any of the following aids like mouthwash or interdental brushes, and do they know where to use the interdental aids and what are the and what they where and when to use the mouthwashes and the effect of the using the mouthwashes and where the dental brushes to use. And coming to the results, these results were calculated on the statistical analysis was calculated by the SPSS software version 20.0 on the Microsoft Excel 2007. This descriptive data was presented as a mean statistical deviation plus or minus percentages, and chi-square test was done by for the to know the association between the inter-group questionnaire, and the p-value was considered as in statistically significant if it is less than 0.04. And the statistically significant results were seen for the question 2, 4, 6, 7, 9, 12, and 13. And these were the results of the questionnaire, and this was the statistical analysis. And this was the questionnaire for the this was the p-value for the each questionnaire, and this was calculated by the SPSS software 20.0 in 2000 by using the Microsoft Excel 2007. And coming to the discussion of the study, from the past few years, we all know that the dental diseases significantly increasing the adaptation of the healthy lifestyle, which is established as effective oral preventive healthy program. Information of regarding informing the patients about the correct oral hygiene habits and raising their awareness how to prevent the oral diseases is the responsibility of an oral healthcare providers. Coming to the question one, which was asked, what do you know the perceive the status of the oral hygiene? And second question was included to know how often they visit the dentist. In the first question, the MBBS students, which about 42% students told that it excellent compared to the BDS students. Whereas the second question included regarding the which was how often they visit the dentist. Medical and the engineering students were more often visiting the dentist compared to the dental students. This is might be due to the as they have the better knowledge of the health diseases compared to the other counterparts. They visit only the dentist when they have any problem. According to the study given by the Chatterjee et al., it was reported that only 10% of the dentists and 27% of the physicians had undergone regular oral health checkups. And there is another study which was given by the Swati. In this study, Swati Patel et al. In this study, 25% of students were going to the dentist, and another 84% of the dental students were visiting the dentist, which was study given by the Harish Kumar et al. Coming to the NR study, 46% of the dental students tend to visit the dentist only if they have any oral hygiene problem. And in the question 3rd, 4th, 5, 6, and 8, 9, which were based on the mechanical plaque control practices by the students, so that the results will be give us the information regarding their oral hygiene performance. In this study, 43.6% of BTech students and brush twice daily, and 27 BDS students tend to do that, which is in contradiction with the study, which was given by the Nepeja et al. And the BTech students prefer the use of a medium bristle toothbrush, whereas dental students prefer a soft bristle toothbrush, as they know the lack of the knowledge regarding this. And coming to the question number 10, 11, 12, 13, 14, based on the knowledge and uses of an interdental cleansing aids and mouthwashes, by these questions we assess the students' knowledge on dental cleansing aids and the mouthwashes and its uses. The use of an interdental cleansing aids and mouthwashes is higher in BTech students compared to the medical and the dental students. This correlates with the study done by the Maitri et al. In which the 18% of the dental students practiced interdental aid study. The use of the mouthwash was less in the dental students because they might know the effects of the, and in our study the percentage of BTS students using the floss and interdental brush was low, but they know the how and where to use the interdental aids compared to the other groups. This finding is of the present study highlights even the dental students rather than the low oral hygiene awareness in initial years in dental education, which is in accordance with the study given by the Daya. The main object of the dental education is to train the students, motivate the patients to adopt the good oral hygiene. The knowledge and practice of the interdental aids can be improved with the increasing levels of the education. Coming to the oral hygiene measures such as brushing, interdental aids, and mopping, these aids in maintaining the oral health. So in our questionnaire, we included the questions mostly regarding the oral hygiene aids and the instructions. There are some limitations of the study, which includes, as it is a type of a questionnaire, the study, this is limited to that only, and this study also features in self-reported information, and such information is often influenced by the shorter acceptability. To the research effect of the education, cross-sectional longitudinal comparisons would be more useful. Clinical examination research questionnaire would be probably assess the result. Coming to the conclusion of our study, in our study we found that the oral hygiene awareness of the first year students of the dental was only marginally high compared to the other group. Further emphasis, oral health is necessary for the undergraduate training to improve the oral health knowledge, attitude, and the practice. It is advisable to conduct a workshop, camps, and the programs to demonstrate the oral hygiene practice as early as possible in these professional colleges. The students are further dental medical care providers who will act as a role models for the oral health education among the individuals at large scale. High awareness regarding the oral self-care among the oral health care providers enables them to assess the patient's oral health condition and to motivate these patients. It may also help them to spread oral awareness in the general population. Regarding the oral hygiene awareness, initial days only, they will by the further on they can improve the oral hygiene awareness, which will spread through the knowledge. These are my inferences. Thank you.
Sir, you may start with question answer session, and ma'am also.
Dr. Lakshmi.
Sir, good morning, sir.
Good morning. Just I want to know that before this study, commencement of the study, did you have any oral hygiene awareness class for this participants?
No, sir, I didn't took any class for these people, sir.
Okay. They were directly given the questionnaire.
Yes, sir, they were directly given the questionnaire. Sir. I told regarding these oral hygiene practices and what were the included in the questionnaire, sir. That's it. I have
Okay.
gave brief introduction to that, sir.
Because MBBS, BDS, they must be doing some mechanical plaque control, but you have also included the first BTech,
Yes,
and
sir.
that's why okay, fine, thank you, ma'am.
Yes, sir. Dr. Divya, in your study, you told us that the use of interdental oral hygiene aids was like slightly better amongst BTech students,
Yes,
right?
ma'am.
Uh,
Yes, ma'am.
can you give any reason for that? What can be the possible reason for this, like BTech students? Because interdental oral hygiene aids are not being used commonly.
As commonly in my study, what I saw was patient in this study. These are the people who have undergone orthodontic treatment. Then might be know regarding the orthodontic treatment, ma'am. In this, these BTech students, they don't know where to use and in what conditions they don't know using these interdental aids, ma'am. Only in some people they have the idea of having the interdental aids. It might be influenced by the by the other people we were thinking.
Mm, okay. Can you tell something about the method of toothbrushing? What was the answer given to the method of toothbrushing? Whatever was being told.
And in coming to the question of the method of toothbrushing, we have given the options as a vertical, horizontal, both, and a circular motion, ma'am. Whereas many people has given the answer for the both vertical and the horizontal type of brushing, ma'am.
Okay. Thank you.
Okay, ma'am.
Thank you, Dr. Divya. Next, we'll move to next presentation by Dr. Palak Dwivedi.
Morning, one and all. The topic of my paper presentation is evaluation of knowledge, awareness, and attitude of general dentists in Navi Mumbai towards periodontal disease caused by iatrogenic factors. A questionnaire-based survey. To err is human, but in reality, there are no mistakes. There are only lessons which help us improve, and a chance to improve is something humanity should normalize. Coming to introduction, for a natural dentition to function optimally, the supporting tissues must be in a state of health. In this picture of a healthy gum, we can appreciate the light pink color of the gingiva, scalloping, stippling, and knife edge margins. Periodontal disease results from extension of inflammatory process initiated in gingiva to the periodontal tissue. Manipulation of periodontium during dental procedures and careless or injudicious therapeutic procedures may result in injuries to periodontium. Are we aware of the term iatrogenic? So, this can be closer than you think. Iatrogenic is derived from a Greek word, prefix itros meaning physician and suffix genen meaning to produce. Hence, inadequate dental procedures that contribute to the deterioration of the periodontal tissues are referred to as iatrogenic factors. Iatrogenic factors in dental procedures are as follows. Restorative issues are violation of biologic with restorative materials and injury to the periodontium. Endodontic includes over-contoured restorations, root perforations, and vertical root fractures. Prosthodontics include pointed design, RPD, and acrylic partial denture. Orthodontic issues are the injudicious use of bands, occlusal considerations, and root resorption. Exodontia includes injudicious tooth removal, post-extraction debridement, wound closure, and periodontal issues include inadequate scaling, polishing cups, brush, and post-flap surgery. Overhanging restorations can be appreciated in the first picture, which causes disturbance in the ecological balance. That is, the gram-positive microorganisms are converted into the gram-negative microorganism, inhibiting the access to remove the accumulated plaque. In the second picture, open interproximal contacts or uneven marginal resolution may predispose to the food impaction, which can lead to gingival inflammation and bone loss. In the third picture, we can appreciate the concept of the biologic width, which is the connective tissue attachment and the epithelial attachment averaging 2.04 mm in most of the patients. If biologic width is violated, it leads to inflammation of the gums and bone loss. In the fourth picture, plaque retention, gingival inflammation are associated with the orthodontic appliances. And in the fifth picture, the design of the RPD leads to gingival inflammation and dental stomatitis. Need for research. Currently, there is a lack of guideline in overcoming the injuries caused by iatrogenic factors in dentistry. The establishment of ethical guidelines will require a survey of practicing dentists to seek data about their attitudes towards iatrogenic injuries caused during the treatment. Treating the complications of encountered during the dental treatment and ensuring patients about the benefit from the procedure without any unsolicited side effects after the treatment should be cultivated in clinicians, as this would be beneficial to them. Need for research. The role of iatrogenic injuries, when assessed properly and treated, can lead to better dental treatment outcomes and will increase the confidence of the future dentist. Hence, there is a need to assess the knowledge, attitude, and practice among dentists about iatrogenic injuries in order to minimize them for successful outcome of any dental therapy. Review of literature, Blumhoff and Linskov reviewed that phosphoric acid used as a etching material and as a root surface modifier, if not used judicially, has necrotizing effect on periodontal tissues. Karasua in a study reviewed that lacerations and trauma to the gingiva and oral mucosa often occurs during the course of orthodontic treatment, especially where long unsupported stretches of wire rest against the lips. The aim of the study is to evaluate the knowledge, awareness, and attitude of the general dentist in Navi Mumbai towards periodontal disease caused by the iatrogenic factors. Materials and methods. This survey study was conducted among consenting dentists from private practice in both major and smaller clinics, hospitals, and dental colleges in Navi Mumbai. Methodology. A self-structured 15 questionnaire was prepared. The questionnaire was validated, and after due removal from the Institutional Scientific Review and Ethical Committee, it was distributed among the general dentists of Navi Mumbai. The questionnaire was divided into 3 sections, and all the data was collected and analyzed. The questionnaire format was sectioned into 3 parts. First was demographics, which contained name, age, and qualification. Second was general questions, which included specialty, duration of practice, frequency of reading journals, and source of information. And third section was of opinion and awareness, which contained opinion on iatrogenic injuries, respondents on iatrogenic injuries, and most common cause of iatrogenic injury. According to the results based on qualification indicated that majority of the participants were MDs. So amongst all the specialties, the results indicated that periodontist was most aware of the iatrogenic injuries. 63% of the general dentists had information on iatrogenic factors in dental practice, while 37% had no such information. So when assessed about the term iatrogenic factor in dentistry, the results showed that majority of the general dentists were aware of the term iatrogenic factor, but they do not know exactly its consequences on periodontium. When assessed about the concept of biologic width, the results showed that the majority of the general dentists were aware of the term biologic width. So according to the dentist's opinion, the most common cause of food impaction are the open contact and the plunger cusps. Maximum percentage of the dentists, that is 73.7%, felt that the orthodontic band and brackets lead to the plaque retention and gingival inflammation. When the comparison was made between the general dentists and specialties based on the awareness and opinions, the specialties were much more aware of the term iatrogenic factor and concept of the biologic width as compared to the general dentists. Discussion. The study mainly focused on awareness of the iatrogenic factors, and maximum number of general dentists and MDs who participated in the study gave correct answer about the term iatrogenic, which in accordance with the study done by Madhavan, in which 82% of the practitioners gave the correct answer. As the duration of practice and experience of the dentist increases, the chances of iatrogenic injury decreases as they are more well versed with the dental anatomy and morphology. Compared to the specialist, maximum general dentists had violated the biologic width, which led to the inflammation of gingiva and bone loss. However, even contradictory results were seen in a similar study done by Mirza, which reported that violation rarely caused inflammation and bone loss. According to the frequency of reading scientific journals, it was found that the specialists were much more aware of the iatrogenic injuries than the general dentists, as the specialists were abreast with the latest scientific journal, as they read scientific journals routinely and attended CDs and seminars. The limitations of the study were more number of practitioners could have been involved and larger geographical area could have been covered. To conclude, the awareness, knowledge regarding sources, application uses, and clinical research guidelines regarding iatrogenic factors leading to periodontal disease are lacking among the dentists participating in the survey. There should be more incorporation of the lecture CD programs, and it should be added in both undergraduate and postgraduate curriculum. Based on the specialty, awareness about the iatrogenic injuries were in accordance. Highest were the periodontists and least were the oral surgeons. According to them, the procedures likely to cause iatrogenic injuries are endodontics were highest and periodontics were least, which could be avoided by taking preventive measures, but that is only possible if clinicians are aware of the iatrogenic injuries. To summarize, inadequate dental treatments can have an adverse effect on periodontium, which can be reduced by highlighting the periodontal issues caused due to the particular treatment. So these are my references. Thank you.
Sir and ma'am, you may start with question and answer session.
Okay, Palak.
Yeah, good morning, ma'am.
Good morning. Presentation wise, you went too fast. It was a little difficult to understand certain things.
Ma'am, actually, there were a lot of matter which, like,
you would have concise the matter. Yes, that's what you would have concise the matter, and you would have presented it a little slow. Then we could have understood the study better. Second is, what was the sample size of your study?
Ma'am, it was actually based on the convenience sampling. So, like, what maximum number of participants were, the responses which I got was total of 120 participants. So the result is basically on the number of the respondents, that is 120 participants.
Okay. Don't you think for
Yes,
an epidemiological study, 120 participants is a little less of a number? Okay.
Yes, ma'am.
Can you tell the percentage of periodontal disease which is being caused by iatrogenic factors? Do you have any data related to this?
Ma'am, basically, ma'am, there is one study, one evidence. It was in the Journal of the Dental and the Medical Sciences. So in that, there was it was mentioned that only 63% of the periodontists were aware of the term iatrogenic factors in dentistry. So this was given, ma'am. This was as evidence which I
percentage of periodontal disease which occurs due to iatrogenic factors. My question was like this. Anyways, what is a plunger cusp? Last question. What is a plunger cusp?
Ma'am, the plunger, ma'am, in this cusp, there is the food tends to get wedged forcibly between the interproximal areas. That is known as a plunger cusp.
Sir,
sir. Okay, thank you, ma'am. Dr. Palak.
Yes, sir.
Why you have not included trauma from occlusion in your questionnaire?
Yes, sir.
Why you have not included trauma from occlusion? Because this is a very vital factor that every general dentist should know.
Yes, sir. Sir, actually,
should be aware of it.
Sir, trauma, sir, in my questionnaire, the results which gave the significant statistical value, that I have included in my results, sir. Trauma from occlusion was included in my question, sir. It was included.
It doesn't give any significance?
Sir, no, sir. According to my result which I got, sir, doesn't give any significant value, sir. So that's why I didn't include in my results.
How you correlate that there is less significance in the general dentist's attitude?
Sir, sir, if talking about the significant value, that is, so the p value was 0.0 less than 0.05.
No.
So
no.
that
just I will tell you, they must not
yes,
be
sir.
aware of this. They may not be knowing how to check trauma from occlusion and all that. That's why they must not have answered.
Yes, sir.
Right? This should be your answer. Okay.
Yes,
thank
sir.
you, Palak.
Okay. Thank you, sir.
Thank you, Dr. Palak. Our next presentation by Dr. Antara Parikh.
Good morning, everyone. The topic for my presentation is evaluation of knowledge, awareness, and practice among dentists and gynecologists in Mumbai regarding association between PCOS and periodontal health, a questionnaire study. Have you ever wondered if hormones affect the gingiva? No, we aren't just talking about pregnancy. Hormones affect more than just menstrual cycle or skin. And when do we see such changes? In PCOS. But what is PCOS? Ovaries have little cysts on them, and ovaries appearing polycystic have more of these little cysts. Polycystic ovarian syndrome, that is PCOS, is the most common endocrine disorder among women of reproductive age, which negatively affects various health systems. The exact cause of PCOS is unknown, but is thought to be hormonal imbalance, which could be a result of insulin resistance or genetics. Talking about periodontal health problems, we use our teeth and mouth a lot. So it isn't surprising how many things can go wrong with it over time, especially if you don't take proper care. However, most of the dental and oral problems are preventable. When we talk about PCOS and periodontal health, there exists a catenated relationship. There is ample of literature regarding various forms of periodontal problems and its association to various systemic diseases. But there is lack of literature associating PCOS and periodontal health. The mechanism that links the two involves various aspects of inflammation. The three main factors of PCOS are obesity, insulin resistance, and an imbalance of estrogen levels, all of which increase the susceptibility to periodontal disease. Coming to the need for research, periodontal diseases are inflammatory disorders that trigger innate inflammatory and adaptive immune responses. Also, PCOS is very common, affecting approximately 5 to 10% of the female population and approximately 40% of the female population in the mid-20s. Gynecologists assess and treat women across the lifespan and especially during the periods of hormonal changes. Thus, it is important that they understand the influence of hormonal fluctuation on women's periodontal health. Since PCOS and periodontal disease are both associated with systemic inflammation and insulin resistance, referral of patients with suspected PCOS to the gynac will also have a positive treatment outcome for periodontal problems. Sai Darshan and Iyer et al. In 2017 concluded that prevalence of periodontal disease was higher in women with PCOS. Sri Chandana T. et al. In 2018 concluded that referral of patients with PCOS to dentists helps in preventing periodontal implications as PCOS can worsen the vulnerability of plaque-induced periodontal disease. The aim of the present study is to evaluate knowledge, awareness, and practice among dentists and gynecologists regarding the association between PCOS and periodontal health. The questionnaire-based study was conducted among the consenting dentists and gynecologists in Mumbai. A self-structured questionnaire consisting of 25 questions covering 8 sections was prepared and validated by experts. All the data was collected and analyzed. General questions were based on demographic data. Awareness-based questions consisted of opinion on signs and symptoms of PCOS and periodontal disease. Knowledge-based questions covered opinion on etiology of periodontal and disease and PCOS. Also, opinion on association of oral health to pregnancy as well as PCOS. Lastly, practice-based questions covered opinion on reported cases and whether or not the dentist and gynecologist refer their patient to the respective specialties. And lastly, the source of information. From the total data collected, 38% of the respondents were gynecologists, 28% were general dentists, and the remaining were specialists. Also, the majority of the respondents, that is 47%, were into institutional type of practice, and 54% of the respondents had a clinical experience of less than 5 years. From all of the data collected, a significant positive response was seen in terms of awareness regarding the signs and symptoms of PCOS and periodontal disease. Also, majority of the respondents stated that periodontal disease is preventable. The graph on the left shows that people were more aware, that is, they had more knowledge about the association of oral health with pregnancy as compared to the association of oral health with PCOS. Also, only 34% of the respondents stated that there could be a possible association between PCOS and oral health. Also, it was observed that on an average, 43% of the dentists and 43% of the gynacs would take history of their patients regarding hormonal problems and oral problems respectively. A lack of interdisciplinary approach was also seen as only 12% of gynacs and 14% of dentists would refer the patient to the specialist. Majority of the source of information was clinical experience. From the previously conducted studies, it was stated that the hypoandrogenism status in patients with PCOS not only results in menstrual abnormalities and infertility, but may also pose an increased risk of periodontal disease to these patients. There is a higher prevalence of periodontal disease parameters in women with PCOS when compared to the controls with a similar age and BMI. The increased vulnerability of PCOS patients to periodontal disease can be explained regarding the influence of altered circulating hormones in and on the periodontal tissues. And lastly, enhanced oxidative stress in affected periodontal tissues is suggested as a pathology for PCOS. Limitations of the present study are that more number of practitioners could have been involved in this study covering a larger geographical area. Also, endocrinologists could have been involved in this study as they too treat women with PCOS. To conclude, this study shows that both dentists and gynecologists are aware about signs and symptoms of PCOS and periodontal disease. However, there is lack of knowledge regarding association of the two. The results have also shown that majority of gynacs, that is 65%, and dentists, that is 68%, do not refer their patients to the respective specialists. Thus, healthcare professionals should be motivated to follow an interdisciplinary approach which could help provide better quality healthcare services to the community. These are my references. Thank you.
Okay, Dr. Antara.
Yes, ma'am. Good morning, ma'am.
Good morning. Can you quote any study which can correlate the effect of periodontal health on PCOS?
Ma'am, there is a meta-analysis.
Just one second.
Yes,
or the effect of periodontal treatment on PCOS.
Okay, ma'am. Ma'am, there is a meta-analysis by Vanessa et al., which is conducted in 2020, which stated that PCOS, as in the patients with PCOS, have 28% chances of acquiring periodontal disease, and the patients with periodontal disease have a 46% chance of acquiring PCOS. Also, regarding the treatment, there's a study by Deepti et al. In 2017, which states that scaling and root planing along with myo-inositol helps in prevention of, as in gives a better treatment outcome with respect to the gingival inflammation as well as the PCOS levels.
Okay. Okay, fine. Over to you, sir. General disease.
Okay. Dr. Antara,
Yes, sir. Good morning, sir.
Good morning. Can you quote any landmark article regarding this PCOS association with periodontal disease?
So Dawson et al. In 2011 was the first one to state that there is a bidirectional relationship between PCOS and periodontal disease. And most of the review articles that I have referred have quoted Dawson et al. To be one of the main articles.
Okay. Is there any specific clinical feature of PCOS?
So main is insulin resistance. Insulin resistance, yes, sir.
If a patient is not referred from a gynecologist, that right, you don't know the history of the patient.
Yes, sir.
So what are the minimum investigations you might be asking the patient to do it?
So if the patient is having obesity, so that is one of the main signs along with hyperandrogenism. So hyperandrogenism will be seen as abnormal facial hair growth and abnormal hair growth. So that is quite visible. So if you suspect a patient who is having PCOS, we can easily refer them for an ultrasound. And in the ultrasound, we can identify if the patient has PCOS or not. I think for the basic procedures. Later, we can refer them to gynaec.
Okay. Thank you, Antara.
Thank you, sir. Thank you, ma'am.
Thank you, Dr. Antara. Our next presentation by Dr. Manvi Srivastav.
Good morning. The topic for my paper is Knowledge, Awareness and Attitude regarding oral health of adults visiting the Department of Periodontology. Introduction. Oral diseases pose as a major health concern due to its effect on the quality of life. The negative impact increases with the severity of disease. Functional effects include difficulties encountered during chewing or speaking. The main reason for non-adherence to oral practices is due to lack of information. When informed and positively reinforced with the regimen of the oral health care, the chances of patient compliance increases. Oral health education attempts to change behaviors by altering the knowledge, attitude, and beliefs about the oral health matters. The motive prompting people to seek preventive dental care include the belief that one is susceptible to dental diseases. Outlook of an individual decides the dental health. Even the people living in urban areas, despite access to dental facilities, fall prey to dental diseases because of negligence. Joint efforts from the dentist as well as the patient is required to keep a healthy oral profile. Need for research. A close relation between knowledge and good oral health has been established in a number of studies. However, association between behavior and knowledge is weak. Most people are unaware of the relationship between body health and oral hygiene. They are oblivious to the fact that most diseases present initially through oral signs and symptoms. Poor socioeconomic conditions have been believed to play a role in the poor standards of oral health in India. There is a need to continuously assess the knowledge, awareness, and attitude regarding oral health to monitor the status of oral diseases. Review of literature. Midwood et al. In their study found that the participants had good oral hygiene practices. The patients were educated and aware of their oral health. The study did identify that participants were not clearly confident about tooth wear and were not able to determine whether they had it or not. Jain and et al. In their study, which was conducted in 2012, concluded that the task to spread awareness among the masses of oral hygiene is critical. Kapurdi et al. In 2010 in their study found that there is lack in appropriate oral health awareness even among literates. The majority of patients were not aware of the fact that oral health has an effect on systemic health. So coming to the aim of this study was to assess the knowledge, awareness, and attitude towards the oral health of adult patients visiting the Department of Periodontology. The source of our data was the outpatient department of our college. The questionnaire was conducted to assess the knowledge, awareness, and attitude according to the oral health. A questionnaire consisting of 20 questions was prepared and validated. The questionnaire format was made in such a way that there were 20 questions which were divided into 4 sections. The first section was the demographics. Section 2 was related to the knowledge-based questions. Section 3 was the awareness-based questions, and section 4 had questions to assess the attitude of the patient. Now coming to results. So we received 240 responses in total. Out of 240 responses, 234 preferred using toothbrush and toothpaste. Maximum participants claimed to clean their teeth twice in a day. As we can see, 44.5% of the participants used circular motion while toothbrushing. 182 participants out of 240 never flossed their teeth. The maximum percentage of participants clean their tongue only once a day. 61.7%, constituting the maximum percentage of participants, never used a mouth rinse. A total of 223 participants cleaned their teeth for prevention of tooth decay and gum disease, and to remove bad breath, and to remove the stain. Maximum percentage of participants have not noticed bad breath, sticky deposits, and bleeding gums. Most number of participants felt that the health of the teeth and the mouth affect the health of the body. 214 responses, that is 89.2% of the total participants, were aware about the professional cleaning of teeth. 152 participants reported that they visit a dentist only in case of any dental problem. 65.4% participants, that is the bigger population of the participants, are most likely to inform the dentist about any medical conditions that they have. Out of 240, 186 participants were willing to undergo a surgical procedure, ensuring the safety to save a loose tooth. Coming to discussion, oral hygiene is highly neglected in developing country like India. Preventive oral health knowledge and its implementation are the important ways of keeping our oral cavity healthy. In a study by Kapurdi, Gill 2014, they found that visiting the dentist is still not considered a preventive dental behavior. At present, it only depends on the treatment need, which is similar to the results observed in this study. In a study done by Jain N. Mitra D. in 2012, where 54% of the subjects visited the dentist only when they were in pain. In the study by Kulshrestha R. et al. In the year 2018, it was concluded that participants who received a post-treatment communication reported higher level of oral hygiene compliance than participants in the control group. The limitation of our study was that our study plan involved a multi-centric approach, but due to the ongoing pandemic situation, we had to restrict the participants visiting our institution only. To conclude, dental education should start at an early age in life. It should be delivered by trained personnel and needs to be carefully integrated in general health. There is a need to educate and spread knowledge of proper dental care and prevention of dental diseases through the dentist. The result of this study depicted that dentists need to reinforce the importance of regular checkups along with the importance of brushing and flossing. Hence, oral hygiene programs through various mediums like teleconsultation and educational videos can encourage patients to adopt the correct method to maintain their oral hygiene. These are my references.
Dr. Manvi, can you hear me?
Yes, ma'am. Good morning, ma'am.
Good morning. I have a little doubt regarding the title of your study. I could not properly correlate it with the study.
Ma'am, so my title said was about knowledge, awareness, and attitude of the patients towards oral hygiene. So by knowledge, I wanted to assess the patient's familiarity with the maintenance of oral hygiene, like what are measures the patient knows, the patient is familiar with for the maintenance of oral hygiene. By awareness, basically, I wanted to assess the patient's level of consciousness, how much patient is ready to like he's aware of what is happening around the oral cavity and the maintenance of it.
It says knowledge, awareness, and attitude regarding oral health of adults.
Yes, ma'am. So my
visiting the Department of Periodontology of Dental Colleges in Navi Mumbai.
Yes, ma'am. So my sample size, I mean, the patient selection, I did only of patients who were above 18 years of age.
Okay. Over to you, sir.
Good morning.
Okay. Good morning. Good morning. Yes, Manvi, being a periodontal student,
yes.
I think in your questionnaire you have not characterized it as a mild, moderate, or severe periodontitis.
Yes.
Did you characterize it?
No, sir. So it was a general this thing. I did not characterize it.
Okay. How you have characterized the periodontal disease?
So my questionnaire actually was not to assess the periodontal disease as such. It was more about how the patient perceives it.
Okay, regarding
the oral health.
As for example, you tell me a question what you have included regarding the periodontal disease in your questionnaire.
So specifically, there were just 2-3 questions. One was whether they are aware about the oral hygiene, professional cleaning, by which I wanted to know whether they were aware of the scaling and root planing which happens. Next was I asked the patient if he was willing to undergo any surgical procedure if we could save a loose tooth. And the third question, which was specifically for it was if the patient is aware of the relation between systemic diseases and oral health.
Okay, in your questionnaire, there was no mention that oral health is also related with periodontal disease. There is no question mentioned, right?
No, sir. No, sir.
Okay.
Patient.
Okay.
Yes.
Thank you, Mani.
Thank you, sir.
Thank you, Dr. Manvi. Our next presentation by Dr. Sheikh Mohd Zubair.
Good morning, everybody. My name is Dr. Sheikh Mohammad Zubair. I will be representing the survey to assess the awareness of oral hygiene, periodontal disease, and ability of treatment techniques among undergraduate and postgraduate dental students. Introduction. Periodontology is one of the fast-growing dental specialties. It serves not only cover preventive and curative aspect of oral health, but also appear cosmetic flare and regenerative health programs. Periodontal disease is multifunctional in nature. If left untreated, can lead to advanced destruction. The bacterial plaque is the main etiology of periodontal disease, while many other factors such as hormonal changes, diabetes, poor nutrition, and smoking may affect the initiation and progression of gingival and periodontal disease. The dentist is often the first point of contact for affected patients. Of late, periodontal disease is thought to have systemic ramifications and has been implicated in a wide range of conditions. Yet, periodontitis is still seen to be nascent and perception of it is quite variable among the dental professionals themselves. Many studies are carried out to know the knowledge and behavior of patients attending the general and dental clinics. Aim to assess the awareness of oral hygiene, periodontal disease, and availability of treatment techniques among undergraduate and postgraduate dental students. Material and methods. 100 of dental students of CSMS Dental College, Aurangabad were interviewed through a questionnaire. Those interviewed included undergraduates and postgraduates. A total of 100 dental students were interviewed on a single day at their workplace. The questionnaire covered different areas such as understanding of the various terminologies, knowledge about and cause and or association with periodontal disease, availability of treatment and their related concept, awareness about different treatment technique used. The response were computed and analyzed for agreement or otherwise between and within the groups. Result. Figure 1 showing the knowledge about periodontal term, that is halitosis. 88% of undergraduate students say halitosis is a bad breath, while 92% of postgraduate students say halitosis is bad breath. Remaining 12% of undergraduate students say halitosis is fault test, while 8% of the postgraduate students say halitosis is fault test. Figure 2 showing knowledge about the etiology of periodontal disease, in which undergraduate students say 30% of the smoking affect the healing, while 20% of the students say diabetes is a risk factor, while 23% of the students say gingival enlargement is by bacteria, and 20% of the students say gingival enlargement is by drug. When this question is asked to postgraduate, 32% of the students say smoking affects the healing, while 31% students say diabetes is a risk factor, while 24% of the students say gingival enlargement is by bacteria, and 13% of the students say gingival enlargement is by drug. Figure 3 showing the knowledge about the concept of the treatment, in which implant replacement natural teeth, when asked the question, 75% of the students say it can replace the natural teeth, while 25% of the students disagree with that. While gingival overgrowth can be treated, when question asked to undergraduate students, 80% of the students say gingival overgrowth can be treated, while 20% of the students disagree with that. When student asked about the scaling cause removal of enamel, 20% of the undergraduate students say scaling cause removal of enamel, while 80% of the students disagree with that. While same question is asked on postgraduate students, implant replace natural teeth, 95% of the students agree with that, while 5% of the students disagree with that. When gingival overgrowth can be treated, question asked in postgraduate students, 88% of the students say gingival overgrowth can be treated, while 12% of the students disagree with that. When student asked about the scaling cause removal of enamel, 2% of the students say scaling cause removal of enamel, while 98% of the students disagree with that in postgraduate. Figure 4 showing knowledge about the awareness of periodontal treatment, in which different questions is asked in postgraduate and undergraduate students. When gummy smile can be treated is asked in undergraduate students, 85% of the students agree with that, while 15% of the students disagree with that. Laser used for periodontal disease, 60% of the undergraduate students agree with that. Gingival recession can be treated was question asked in undergraduate students. 70% of the students say gingival recession can be treated, while 30% of the students disagree with that. LDD used for periodontal treatment, 60% of undergraduate students say agree with that, while 40% of the students disagree with that. Dark brown gums can be treated. 40% of the undergraduate students say it can be treated, while 60% of the students disagree with that. In postgraduate, when gummy smile can be treated, question asked, 98% students agree with that, while remaining 2% disagree with that. Laser used for periodontal disease, 95% of the students say it can be treated, while 5% of the students disagree with that. Gingival recession can be treated, 90% of the students agree, 10% of the students disagree with that. LDD used for periodontal treatment, 75% of the students say yes, while 25% of the students disagree with that. Dark brown gums can be treated, 80% of the students say yes, while 15% of the students disagree with that. Discussion. To the questions pertaining to the various frequently used terminology, nearly 88% of all surveyed undergraduate dental students answered that halitosis is bad breath, while nearly 92% of all surveyed PG dental students answered the same. Regarding knowledge about etiology of periodontal disease, the survey resulted in postgraduate students being more knowledgeable and informative regarding the etiology, that is diabetes mellitus, smoking, and gingival enlargement by bacteria. Newmanji et al. In 2002 says, in hyperglycemic environment, AGA formation is excessive. AGA formation cross-link collagen make it less soluble and less likely to be normally repaired or replaced. As a result, collagen in the tissue of poorly controlled diabetes is AGS and more susceptible to breakdown. According to Biology SM et al. In 2008, one possible explanation is that the substance in tobacco and smoke, particularly nicotine, cocaine, carbon monoxide, and hydrogen cyanide, are cytotoxic to those cells that are involved in wound healing. Nicotine increases platelet adhesions, raising the risk of microvascular occlusion and tissue ischemia. Smoking is associated with catecholamines release, resulting in vasoconstriction and decreased tissue perfusion. Responses regarding knowledge about treatment offer for gingival overgrowth and treatable periodontal problems such as gummy smile were more in postgraduate students as compared to undergraduate students. The awareness level was marginally higher with postgraduate students. Conclusion. We have reported the analysis of awareness about periodontal health and disease among the undergraduate and postgraduate dental students and found a much higher awareness among the postgraduate as compared to the undergraduate. So training course can be conducted for awareness regarding the treatment and etiology of dental disease in undergraduate students. Thank you.
Dr. Zubair. Can you hear me, Dr. Zubair?
Good morning.
Zubair?
Yes, ma'am. Hello.
Your study was evaluation amongst undergraduate and postgraduate students. Yes?
Yes, ma'am. Yes, ma'am.
Don't you think there was a little bias because before doing the study itself, we can think that postgraduates must be knowing about it better? No? That is a very obvious thing that postgraduates must be knowing about it better.
We were comparing the knowledge. Yes, ma'am.
That is a normal thing, no? If at all anyone comes to a postgraduate course and it's like at least 1 year is being like he has done 1 year of any courses in dentistry, any of the amongst any of the 9 specialities, that student must be more aware about whatever the questions were being asked as compared to a first year BDS or a second year BDS student, right?
Yes. So, ma'am, we have taken interns only in undergraduate.
Okay, this was never mentioned in the study.
Oh, yes. Sure.
Okay, no more questions.
Good
morning, sir.
Good morning. Good morning. In the title shows periodontal disease and availability of treatment techniques.
Yes, sir.
What you actually ventilate, that is the home remedies or the clinic remedies, the treatment techniques.
Clinical remedies.
Oh, clinical remedy. Do you think there is a change or
sorry, sir. Can I?
Hello.
Hello, sir. Can you repeat question?
Do you think that there can be the change of treatment techniques?
Hello.
Hello.
Yes, sir. Treatment techniques in periodontal.
Treatment techniques in oral hygiene.
Hello.
Hello. Hello, can you hear me?
Sorry, sir, I'm not hearing you.
Okay, fine. Thank you. Thank you.
Thank you, Dr. Zubair. Let's proceed to next presentation by Dr. Arpit Oja.
Hello everyone, have a nice day. I am Dr. Arpit Oja, PG student from College of Dental Science, Amargarh. My topic is awareness of oral hygiene measures in the population of Bhavnagar district. It contains introduction, material and methodology, result, discussion, conclusion, references. So let's start with introduction. In introduction, oral ailments cause tooth misfortune and influence the general well-being. Additionally, oral issues and tooth loss prompt low positive mental self-esteem. Cavitation has been perceived as the most constant and incessant youth dental issues. Gingival and periodontal disease may in the end cause tooth loss. According to the Bowen WH in 1976, defined dental plaque clinically as a structured, resilient yellow-grayish substance that adheres tenaciously to the intraoral hard surface, including removal and fixed restoration. Plaque has been a significant causative factor in the improvement of oral maladies, for example, periodontal disease. Oral hygiene is viewed as the most significant factor in the anticipation of oral ailments. Simplified Oral Hygiene Index, developed in 1964 by John C. Green and Jack R. Vermillion, in order to classify and assess oral hygiene status. As you can see, 11, 16, 26, 36, 31, and 46 are targeted to which give a simplified oral hygiene index. Now come to the calculation and interpretation. In that, first is then debris index is equal to total score divided by number of surface. Second is calculus index, simplified calculus index is equal to total score divided by number of surface. Third is oral hygiene index, OHIS, is equal to debris index S plus clinical calculus index S. So debris and calculus score ranges from 0.0 to 0.6 is good, 0.7 to 1.8 is fair, and 1.9 to 3.0 is poor. And simplified oral hygiene index score ranges from 0.0 to 1.2 is good, 1.3 to 3.0 is fair, and 3.0 to 6.0 is poor. Now let's see uses of simplified oral hygiene index. It is widely used in epidemiological study, useful in evaluation of dental health education program, evaluating the efficacy of toothbrushes, evaluate an individual's level of oral cleanliness. Present examination was attempted to decide the pervasiveness of periodontal diseases in populace and to additionally describe the degree and seriousness of the ailment. Now come to the material and methodology. The study population consisted of 468 randomly selected individuals of varied age group in Bhavnagar. Detailed demographic data of all the subjects were recorded, and an intensive clinical assessment was performed with the help of diagnostic instruments so as to assess the periodontal status of subject. The obtained data was recorded in the data structure planned by the WHO standard chart. The oral hygiene status was determined via the simplified oral hygiene index developed by Green and Vermillion. It is simplified index consisting of two components of debris and calculus, each with a possible score ranges of 0 to 3. The total score was obtained by calculating the sum total of both the individual indices, like oral hygiene index S is equal to DIS plus CIS. So the possible score ranges from 0 to 6. The amount of calculus and debris were determined by examining the facial surfaces of teeth number 11, 16, 26, and 31, as well as the lingual surface of 36 and 46. Now, simplified oral hygiene index scores may be interpreted as good, fair, and poor. Now, let's see the result. A total 468 participants, in that 237 males and 231 females of various age groups were included in this cross-sectional study. The study was performed for the assessment of periodontal health by oral hygiene status. As you can see in the table depicting the maintenance of oral hygiene amongst genders in a population. Good oral hygiene was maintained by females under age group 10 to 19 years. Fair oral hygiene was observed in males under age 20 to 29 years, and poor oral hygiene was observed in females more than 50 years, as you can see in this table. This graph in discussion, let's see. The current graph shows the depicting the good oral hygiene status. So as you can see in the graph, 10 to 19 years have a good oral hygiene status, and in that females have a more good oral hygiene status. Now the graph 2 shows is depicting fair oral hygiene status. In that 20 to 29 years of males have a fair oral hygiene comparatively more. Third graph shows is depicting the poor oral hygiene status. In that more than 50 years of female have a poor oral hygiene status. Oral hygiene status might be impacted by an assortment of components including failure to keep up a solid oral cleanliness, deserts utilization, and propensities like smoking and so forth, which could make the oral depression an appropriate situation for microbial development and plaque. Plaque is a significant causative factor in the advancement of oral infection, for example, dental caries and periodontal disease. So let's conclude the presentation. So present investigation furnishes with proof of high predominance of periodontal infections among the populace. This examination likewise discloses the absence of mindfulness for dental well-being in the midst of the populace. After effects of present examination immovably express that the investigation populace requires inspiration for support of oral cleanliness. My references, as you can see in this. Thank you.
Okay. Dr. Arpit, are you there?
Yes,
Dr. Arpit?
Yes, ma'am.
Okay. Can you hear me?
Yes, ma'am. Yes, ma'am. I can hear you, ma'am.
Okay. Because much was being told about oral hygiene index simplified, I am bound to ask little questions regarding that. What is the disclosing agent?
This closing agent which shows the plaque that adheres to the tooth structures, which shows the plaque adheres to the tooth structure to the dentist to make it easy to clean it.
It's for the dentist so that we can easily clean it. Is it?
Yes, ma'am.
Okay. Is there any is any disclosing agent used in oral hygiene index simplified? Do we use any type of disclosing agent in OHIS?
Yes, ma'am. I used it, but I'm not recognizing name right now, ma'am.
Any other disclosing agent? Can you tell the name of any other disclosing agent? There are so many. Any other, only one name of any of the disclosing agents. Over to you, sir.
Arpit.
Good morning, sir.
Good morning. Good morning. Can you tell me in brief the new dimensions of mechanical plaque control?
Yes. The patient should maintain their oral hygiene by using a chlorhexidine mouthwash in day-to-day life.
I am very specific. Mechanical plaque control.
Mechanical plaque control. Okay, sir. Scaling and root planning is essential. Patient should visit person should visit dental clinic frequently while they need when they feel like there is adherence of soft debris on the tooth structure, and they used to check their dental status by going to the dental clinic and get the help by scaling and root planning.
No. Okay, fine. No, actually, I was asking about the mechanical plaque control aids. Anyway, last one is tell me what is superfloss?
Superfloss is used for interproximal cleanliness.
Which area? Where?
Sir, maximum posterior tooth in between the tooth where the chances to get food stuck over there, sir.
Is it in a normal dentition or is it used in prosthesis?
Sir, it can be used in prosthesis where there is the chances of food accumulation.
Have you seen what kind of? Have you seen the design of that? No.
Sir, once I have seen it's with little drops over the.
No. Okay. Thank you, Arpit.
Sir,
Thank you, Dr. Arpit. Then moving on to our next and last presentation by Dr. Anbarasi T.
Of knowledge and awareness. Good morning, everyone. I'm Anbarasi and I'm here to present my paper on assessment of knowledge and awareness about toothbrush contamination and disinfection among public across sectional study. So coming on to the introduction, as we all know, the toothbrush is a common mechanical plug controlling aid that is being used from 700 BC, and there is no better replacement found till now. Hence, it is important to address the fact that how clean is your toothbrush that cleans your teeth. Usually, our toothbrush become heavily contaminated in both the intraoral and extraoral environment, and which can access and soil for many microorganisms. After every single use, our toothbrush become contaminated with both pathogenic bacteria and viruses, which can maintain their viability on the toothbrush up to a week. So these microorganisms from contaminated toothbrush can transmit from one individual to others and cause many oral and systemic infections, including septicemia, gastrointestinal, cardiovascular, respiratory, and renal problems. Hence, this toothbrush contamination disinfection could affect our family, including the children, elders who were easily prone for infections. So this knowledge and awareness about toothbrush contamination disinfection is very essential for each and every individual. The rationale of my study is to know the perception idea about toothbrush contamination disinfection from people's point of view, which will help us to motivate them to practice it as an normal oral hygiene maintenance. There are many studies in literature about toothbrush contamination disinfection among dental students. To our knowledge, this is the first study to assess the knowledge and awareness about toothbrush contamination disinfection among general population. So the aim of the study is to assess the knowledge and awareness about toothbrush contamination disinfection in general population of socio-economic between two socio-economic classes. So the objective to assess the knowledge and awareness about toothbrush contamination disinfection among general population between two socio-economic classes by means of a questionnaire to compare the knowledge and also to compare the knowledge and awareness about toothbrush contamination disinfection between two groups. So the material method study population, people reported to our college OP were included in the study. Inclusion criteria, participants belong to socio-economic group of upper and upper lower class according to the modified Kupusam scale 2019 were included. Exclusion criteria include all healthcare providers. So the methodology, this was a study conducted between January 2019 and March 2019. All the participants were volunteer, and the questionnaire, standard questionnaire by Becker et al. And Saumya et al. Were used in the study, who met with the inclusion criteria of being upper and upper lower class socioeconomic class. So the socioeconomic class, socioeconomic scale we have used is modified Kupusami scale. Here, he broadly categorized into education based on education of the head of family, occupation of the head of family, and monthly income of the head of the family. Based on this, we have given a separate score for each thing, and the total score implies 5 socioeconomic class like upper, upper middle, lower, upper, lower, and lower. So we have taken upper and upper and lower class because the majority of the population in that category. The questionnaire, 14 questions included in this study, and the personal habits include 6 questions. So toothbrush contamination is about 4 questions, and 4 questions about toothbrush disinfection. So these are my questionnaires. Statistical analysis, descriptive statistics like frequency percentage were used. Chi-square test to test the significance between two groups, and p-value is less than 0.5% is considered statistical significance, and these are results. So totally 175 persons participated in this study. 80 participants belong to the upper socioeconomic class, and 95 participants belong to the upper lower class. So here in the table, each questions were given along with their choices. So number of participants who have answered who have chosen which option is given, and who have given the correct answers, and statistically we have calculator who have given the correct answer for each question, and also compare them between the two socioeconomic groups. The statistical significance were given on the p-value, the right side of the right side corner. So these are the results. So on the personal habits, most of the study participants reported they have used to brush their teeth once in a day, and change their brush after more than 6 months, and store their toothbrush outside the bathroom covering with their brush head, and they store their toothbrush holder shared with their family members, and they thought that the contact between the toothbrush was not an important issue. These numbers were how many participants answered these chose these choices. In the toothbrush contamination category, most of the participants answered common mode of transmission of infection by sharing toothbrush, and most of them answered there are no chance of infection from toothbrush contamination. In toothbrush infection category, almost all of them had no idea about the toothbrush infection, and a significant association was found between public who have disinfected their toothbrush and who are not aware of the importance of the toothbrush contact between the toothbrushes. But there is no significant difference between two groups about any of the following questions, any of the previous questions. So coming on to the discussion, there are many studies in literature, as I said before. One of the studies, Becker et al. 2015, among 147 dentists, 62% of the dentists, they did not have any knowledge about toothbrush disinfection. 85% they did not disinfect their toothbrush. Significant association found for knowledge about toothbrush disinfection and where they store their toothbrush and their toothbrush contact between each other during storage. And a very minority of dentists did their disinfection. Similarly, Swami et al. 2017 conducted a cross-section study among using questionnaire among 400 dental students, like postgraduates and interns. In that, 53% did not feel that it is necessary to practice disinfection. In that, postgraduate students have better knowledge about this disinfection contamination than the interns because of their academic knowledge and exposure to wide information and clinical experiences. Wei et al. In 2014 conducted a cross-sectional study. He compared between dentists and lay persons about the oral health status and oral hygiene practice behavior using a standard questionnaire and DVMFT and CPIT index. In that, 80% of the dentists found to be to brush their teeth twice daily, 94% layperson brush once daily, and 82% of dentists had CPT score of 0, where 71% of laypersons had a high score of 3, and 81% of the laypersons reported tooth mobility compared to the 1% dentist. So in our study, approximately 98% of the participants did not have any knowledge about toothbrush contamination disinfection, but there is no significant difference between two groups about the idea of toothbrush contamination disinfection. This states that socioeconomic status of the people does not influence the oral hygiene practice of the individual. From the above discussion, we have seen even the dental professionals were not aware of the toothbrush contamination disinfection, and it is no wonder the common people is also not aware. Hence, it is our duty to give a piece of advice and knowledge about this contamination disinfection along with the routine oral hygiene practice, and also by conducting some public awareness health program. By educating people about these toothbrush contamination disinfection, we can prevent many cross infections that is commonly affecting our family members. These are my references.
Okay, no questions from my side. Over to you, sir.
Is there any specific oral hygiene aid that you like to prescribe? Any specific which has a higher percentage to prevent the gingival or the periodontal disease?
Mechanical block control is the main thing, sir. Other than that, we can use adjunctive.
What?
Okay, sir. We can advise mouthwashes, antimicrobial mouthwashes. It's an adjunctive to mechanical block control.
Okay. You cannot ask them to use the interdental air.
Yes, sir. We can enforce them to do that also, sir. Interdental aids, flossing aids, tongue cleaners for full mouth disinfection.
There is a very good article. Last year it has come 2020 by slot. Right? You just go through. Yeah.
Okay.
Thank you, Anarvas.
Thank you, Dr. Anarvasi. With this, we end our session. Thank you, Dr. Jalaluddin sir and Dr. Rika Singh ma'am for taking out your valuable time and being a part of this first virtual PG convention. Sir, a sincere request, please do submit the evaluation sheet on mentioned email and or through that WhatsApp number, sir, because at today at 5 p.m. We are going to publish result. So
sure.
Okay.
Thank you so much, Rika ma'am.
Thank you so much, Jalaluddin sir. Thank you, sir. Thank you.
Thank you, ma'am.
Thank you,
ma'am.
Then we'll proceed to our next session, which is the poster presentation session. Then I would like to invite Dr. Prerna Agrawal ma'am, Reader, Institute of Dental Science, Bareilly, and Dr. Abhay Chandra Das sir, Professor, Institute of Dental Science, Bhubaneswar. Sir, please do chair this session. And here I would like to call Dr. Nida Isa Sheikh for poster presentation.
Hello. Dr. Nida, you can start.
I think Dr. Nida is not there. She's here.
Yes, sir, I'm there. Sorry, due to some technical issues, I couldn't.
Please start. Almost your 90 seconds is gone.
Good morning, everybody. Today I'll be presenting a poster on halitosis and laser tongue debridement, a new treatment approach. Halitosis is an unpleasant or offensive odor emanating from the breath, regardless of whether the odor is originating from an oral or a non-oral source. Oral malodor is known to decrease a person's confidence and well-being. Thus, a newer approach for awareness and treatment is required. Oral malodor is classified as genuine halitosis, pseudohalitosis, and halitophobia, causes of which are physiologic, morning breath, foods that can cause temporary bad breath. Pathologic, intraoral and extraoral causes. Intraoral, the main culprits of halitosis are tongue, teeth, gingival and periodontal areas, followed by tonsils and decreasing odor. Poor oral hygiene, insufficient saliva flow, periodontal infections, odontogenic infections, xerostomia, exfoliated epithelium, foreign particles in the tonsillar crypts, and skunk syndrome. Extraoral causes, pharyngitis, sinusitis, diabetes, Zenker's diverticulum in the gastrointestinal tract. Drugs associated with halitosis are lithium salts, grisoflavin, antihistaminics, and metronidazole. Bacteria producing volatile sulfur compounds, that is F-nucleatum, V. parvula, Treponema denticola, Porphyromonas gingivalis, E. limosum, S. armitidis, and A. odontolyticus. Diagnosis can be done by self-assessment test, whole mouth malodor, Rick-List test, spoon test, and dental floss test. Objective tests like organoleptic measuring using gas chromatography and Bana test. Also, halitosis associated life quality questionnaire. Fourth, Finkelstein's tonsil smelling test. Finkelstein's tonsil smelling test, which is based on squeezing the tonsils and smelling the squeezed discharge. The scoring criteria as follows. 1. Severe, when bad breath is felt during conversation with the patient. Moderate, bad breath is felt when sniffing the air exhaled from the patient's nose or from his or her mouth, or smelling a strong fetid odor from the glove at a distance of 10 centimeter. 3. Mild, when smelling a fetid odor, bringing the glove near to the examiner's nose. Tongue color analysis. It was developed by Roy Leeser. It uses an application on iPad Pro where the pictures are isolated and uploaded to the application. It analyzes the color and composition of the photograph and produces the percent distribution of each color shade. Colors are divided as shades of pink, shades of white light to tan, and shades of tan to brown. White light to tan indicate thick coating on the tongue surface. Pink color indicates healthy. Salmon pink indicates healthy. Brown color indicates foul, and chestnut color indicates foul. Treatment. The usual treatment modalities are mechanical reduction of intraoral microorganisms, chemical reduction of microbial load, and masking the malodor. Laser tongue debridement includes use of lasers such as hard tissue and soft tissue lasers, that is erbium YAG, erbium chromium YSGG laser, and carbon dioxide
Time's up,
laser,
ma'am.
etc. Hello.
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 Ida. Hello, Dr. Ida.
Yes, sir.
You have not completed actually. Your time is already gone. So tell me about any electronic instrument that measures halitosis.
Sir, halimeter.
Okay. You are supposed to use the debridement, tongue
Yes.
debridement with the laser.
Yes, sir.
Is it necessary with laser? You can simply tongue cleaner is sufficient.
Yes, sir, tongue cleaner is sufficient, but the amount of the studies have shown that the amount of bacterial load that reduces with the use of laser is far better than with mechanical reduction, or it can be used as an adjunct with the mechanical debridement.
Okay. Can you full form of the laser?
Sir, erbium YAG, it is erbium doped yttrium aluminium garnet. Erbium chromium YSGG is erbium chromium doped yttrium scandium gallium garnet laser, and CO2 is carbon dioxide laser.
Okay. Okay. Is there a chance there is some harm to the test buds during this debridement?
Sorry, sir.
Is there a chance of there is some harm on the test bud due to this laser application?
Sir, maybe because of the fumes that come out of the carbon dioxide laser.
You are telling that not effect on the test bud. Okay. Okay, any question? My side over. Dr. Prerna, you can ask.
Okay, I'm done, sir.
Thank you, Dr. Nida Isha. Let's move to next presentation by Dr. Renuka Devi.
Good morning, sir. Today I'm going to present, this is a case report, sir, actually. My slot is given here. I'm going to present a topic on log the socket, the techniques of risk preservation. On most of the occasions, the clinicians as well as the patients face a problem how to replace once the extraction has been done. Regardless, it's mandatory to replace. Ma'am, my slide is not shown, ma'am. Thanks, ma'am. It's mandatory to replace for the functional purpose, such as mastication, as well as for the aesthetics too. The alveolar bone resorption after extraction seems to be more for first 3 to 6 months comparatively. On providing beneficial to this mess, we put a stop, conserve, and safeguard alveolar bone to maintain height and width for further prosthesis in concern to make aware patient to consider about the future. The volume and the morphology of bone is maintained with normal anatomic structures. The essential of this procedure is to make to eliminate decrease in volume of alveolar bone so that the future placement of fixed or removable prosthesis or even implant come out with better results, and we can also avoid ridge augmentation procedures. So the patients about 20 years with a good systemic health, free of anti-inflammatory drugs for 6 months, with no adverse habits are taken into consideration for better outcome. The derivatives of plasma concentrates are used here, which are prepared by the autologous method from the patient's own venous blood, and this also acts as an anti-inflammatory and promotes better wound healing comparatively. Bharti, BK et al. Suggest that the socket preservation can be done at short, long, and medium term. In this case report, I have taken 2 cases with one with PRF, that is platelet rich fibrin, and other with CGF, that is concentrated growth factor. I have processed and the material is placed into the socket immediate after extraction. X-ray has been also taken immediate after placement of the material, and 3-dimensional, that is CBCT, has been taken after 3 months for the evaluation and comparison. The literature justifies that use of bone graft materials in freshly extracted sockets accelerates wound healing and it enhances the collagen synthesis and osteogenesis. It also functions as a fibrin tissue adhesive.
Time's up, ma'am.
Okay, sir.
Renuka, you have not completed.
Good morning, sir.
Good morning. You have not completed, no? Yes. So much
confusion is there.
Okay, but your written part is so much, so that's why. Okay. Why you said they lock the socket? But just
because I'm going to preserve the bone before it's going to get resolved.
Okay. What is concentrated growth factor you're telling? Can you?
It is CGF, sir, concentrated growth factor. It is the second generation, advanced second generation bone graft. It is the material which is processed by autologous method. It is processed by patient's own venous blood, sir.
Okay. Can you comparison of that? Which growth factor are there?
Sir, I can't.
Can you enumerate some names of the growth factors? Okay.
Yeah, ma'am. Then 4 minutes by 2400 RPM. Again 4 minutes by 2700 RPM, and finally 2 minutes I have processed for 3000 RPM, ma'am. Then deceleration was done 36 seconds, ma'am. Then the CGF has been got, ma'am. That there will be membranes, ma'am. The
2700 RPM, which machine you used for 2700 RPM? Which centrifugator you used?
Ma'am, acceleration only, ma'am.
No, I'm asking which centrifugator have you used for 2700 RPM?
Which centrifugation?
Okay.
Okay.
Thank you, Dr. Renuka. Our next presentation by Dr. Deepika Ajit Masurkar.
Good morning, ma'am. Introduction. One of the most important factor in closure of periodontal flap is attenuation of primary union of flap margins. So silk suture is most common suture used for the closure of oral wounds. However, it is associated with wicking phenomena. So an alternative for the suture is always felt. Cyanoacrylates are tissue additive materials which are bacteriostatic property and biocompatible and are not toxic in nature. Therefore, the present study will be undertaken to evaluate and compare healing after periodontal flap surgery of cyanoacrylate and silk suture with an objective to evaluate healing after periodontal flap surgery. You treated with cyanoacrylate. Clinical parameters recorded was healing by early healing index. Secondary outcomes were probing pocket depth, clinical attachment level, gingival recession, which was measured at baseline and 6 months. Papillary bleeding index was measured at baseline and 1 month. The surgical procedure was performed during local anesthesia and under all aseptic precautions. Circular incisions was made buccally and lingually for the teeth included in the periodontal surgery. The mucoperiosteal flap was raised on the buccal and the lingual aspect of tooth. Thorough debridement was carried out by local irritations and disease granulation tissue. After achieving hemostasis, suture were placed in the control group and cyanoacrylate was placed in a dropwise manner on the margin of the flaps, which were held in the place in the test group, and the application was done till the thin film of the set cyanoacrylate was formed, and then the periodontal plaque was placed. Post-operative medications and was prescribed. Patient was instructed not to gargle with chlorhexidine mouthwash and refrain from tooth brushing at the surgical site. Coming to the results, healing score for test group at 1 week was 1 plus or minus 0 compared to the control group, which was 1.6 plus or minus 0.2, which was statistically significant. No significant difference was seen in the healing after 2 weeks to 6 months when both the group were compared. Both the group resulted into significant reduction in PPD, gain in CAL, and no gingival recession post-operatively. Cyanoacrylate showed absence of pain, itching, and was found to be aesthetically present. Coming to the conclusion, cyanoacrylate is found to be significantly better as compared to the suture and aid in early healing, initial healing. However, over a period of 21 days to 6 weeks, both the site treated with both the material showed similar healing patterns. There was significant reduction in PPD, gain in CAL, and no post-operative gingival recession observed in both the groups at 6 months post-operatively. Thank you.
Hello, Dr. Deepika. Deepika? Hello, Deepika.
Yes, sir.
Which healing index you are using? Name that one.
So, healing index that I have used is Wechel's 2003 healing index, early healing index.
Yes. Which healing index you are using?
Sir?
Which healing index you are using? Audible or not? Which healing index you are using in this study?
So Wechtel's 2003 early healing index.
Hello.
Yes, sir. So it's Wechtel's 2003 early healing index, which he has.
Okay, you can use scoring criteria. Can you tell me the
Yes,
scoring criteria? Tell me that
sir.
one.
He has given 5 scores, in which score 1 is there is complete closure of flap and no fibrin like material in the interproximal areas. 2 is complete closure of flap, but there is fibrin like line in the interproximal areas. Score 3 is complete closure of flap, but there is fibrillin clot in the interproximal area. A score 4, there is no complete closure of flap and there is partial necrosis in the interproximal areas. And score 5, there is again no complete healing, closure of flap, and there is complete necrosis in the interproximal areas.
Okay, madam, you can ask. Dr. Paran,
Okay, Deepika. Yes,
Yes,
sir.
ma'am.
Deepika, how much time you need actually for flap approximation, and what should be the what is the fate of cyanoacrylates?
For flap approximation with cyanoacrylate, ma'am.
No, first you tell me what should be the ideal time till when you need flap approximation for healing.
Ma'am, with cyanoacrylate, it's 5 to 10 seconds for polymerization it takes. And yes, ma'am.
नहीं बेटा healing के लिए कितने time तक we should, for how much time flap should be approximated?
Sir, for 3 minutes.
For how many days?
7 days.
Okay, what is the fate of cyanoacrylates?
What is ma'am?
What is the fate of cyanoacrylates? How much time they resorb? What is the resorption process?
Ma'am, cyanoacrylate is bioresorbable and it is seen that it resorbs in around 7 to 8 days, ma'am.
Around?
7 to 8 days.
And how do they resorb?
Ma'am, it's a biodegradable material.
Thank you, Dr. Deepika. Our next poster presentation by Dr. Madhusri Venkatashan.
Hello.
Please start.
Good morning, everyone. It's my privilege to start present the e-poster of my study on the topic low-level lasers, the magical one. So we are going to analyze wound healing with low-level laser when used as an adjunct to gingivectomy. So as we all know, gingival enlargement is one of the common clinical features of gingival disease, and it is related to various etiological factors. It can lead to plaque accumulation and further destruction of periodontal tissues. So, though scalpel gingivectomy is a surgical treatment of choice to treat gingival enlargement, the additional usage of low-level lasers has enhanced the treatment outcomes. So, low-level laser therapy uses low powers that causes no tissue or least thermal damage along with wound healing process, and it also has certain properties such as biostimulation and angiogenesis. So it has also been proven that low-level laser therapy reduces post-operative pain and thus decreases patient's morbidity. So the aim of the study is to assess and compare the effects of low-level laser therapy following scalpel gingivectomy with scalpel gingivectomy alone on wound healing in inflammatory gingival enlargement patients that is caused only due to orthodontic irritational factors. So coming to the methods and methodology, the present study was a randomized split mode study done among 15 patients with the chief complaint of gingival enlargement bilaterally or contralaterally. So all the patients underwent oral prophylaxis followed by reassessment and then surgical intervention of scalpel gingivectomy in both test as well as on the control side on the same day. It was followed by low-level laser therapy only on the test side, which was given on the first and the third day post-operatively in non-contact, pulsative, defocused mode in a semicircular motion for 30 seconds at each two sides. And wound healing was analyzed on the 3rd, 7th, and the 21st day post-operatively using healing index given by Laundry et al. In 1981. And epithelialization was assessed using plaque disclosing agent alpha plaque. And then pain assessment was done using numerical rating scale and Wong-Baker face rating scale. So the results were analyzed using paired sepal test and ANOVA test, which was considered to be significant when the p-value was less than 0.05. And then complete epithelialization was noted at the end of 7 days in both the groups. And the healing score in the control group on day 3 was 3.73, which increased to 4.87 in the end of 21st day. And in the test group, it was 4.53 on day 3, and it increased to 5 on the 21st day. And the intra-group comparison of the mean numerical rating scores in the test as well as in the control groups showed significant differences from day 1 to day 7. So coming to the conclusion, so based on the results of this study, it can be summarized that low-level laser therapy using 980 nanometer diode laser at an energy density of 4 joules per centimeter square can be used as an adjunct to scalpel gingivectomy procedure to aid in better wound healing and epithelialization, and it also reduces post-operative pain and discomfort of the patient, reducing patient's morbidity. Thank you.
Madhusri,
Yes, sir. Good morning, sir.
you are telling that your topic is the low laser level, the magical one. So, which will be best, laser or a photodynamic therapy?
Sir, actually, when we use lasers, it increases the healing period, sir. It reduces the inflammation, all that. So lasers, when we use laser alone, it increases healing period. Although while using laser, the patient's comfort is increased and healing is the bleeding is all decreased. But when we use low-level lasers, it increases decreases patient's morbidity by reducing the pain as well as increasing the wound healing process.
Dr. Pranay, you can ask.
Okay, low-level laser therapy. What are you trying to do with low-level laser therapy? Low-level laser therapy is basically for biostimulation.
Yes, ma'am.
So,
Here,
what kind of biostimulation you are intending at?
ma'am, actually, I'll be giving low-level laser therapy on the first day as well as on the third day, ma'am. So when I give it on the first day, the pro-cytokine levels are reduced by using low-level laser therapy, ma'am. So hence the cytokine, when there is the pro-cytokines reduction, the inflammation reaction is reduced, thus enabling better wound healing. And when I give it on the third day, it enhances angiogenesis biostimulation. So in this process, it helps in enhancing ATP synthesis in mitochondria, thus enabling cell proliferation. So when there is activity of cell proliferation, it acts on fibroblast cytokines, fibroblast and keratinocytes, thus enabling better wound healing and faster wound healing, ma'am. And it also helps in nerve blockage, that therefore reducing the pain. So pain is also reduced, cellular proliferation is increased, bioactivity is increased. Thus, all helps in increasing wound healing as well as reducing patient's discomfort.
Okay.
Thank you, Dr. Madhusri. Our next presentation by Dr. Venkatesh.
Good morning to all. Am I audible, ma'am?
Yes, you are audible.
Yes, sir. Good morning to all. My e-poster topic was lasers in non-surgical periodontal treatment. As we all know, periodontitis is a group of inflammatory disease that affects the connective tissue attachment and supporting bone around the teeth. For treating this condition, a non-surgical periodontal treatment found to be the cornerstone of management in the chronic periodontitis patients. But initially, as we all know that, and also GCF is a potential biomarker in relating the severity of periodontal disease condition. In that, MMP plays a significant role, and in changes in MMP9 levels in GCF can be used as a biomarker to analyze the periodontal tissue destruction. But non-surgical periodontal treatment not alone completely remove the subgingival microorganisms. Hence, nowadays lasers can be used as a adjunct therapy to treat adjunct therapy in the non-surgical periodontal treatment. So, in mild to moderate periodontitis patients, laser can be used indicated for additional subgingival development. Aim of my study is to determine the efficacy of diode laser 980 nanometer therapy as an adjunct to non-surgical periodontal treatment in chronic periodontitis patients as a randomized clinical and biochemical study. Coming to the methodology part, study design was it was split both design, and the total of 8 moderate periodontitis patients with the clinical attachment loss of 2 to 4 mm were collected, and case history informed consent were obtained. Patients were divided into two groups. Control group received SRP alone and test group received SRP with laser as an adjunct therapy in first, third, and seventh day. Clinical parameters like oral hygiene index simplified, bleeding and probing, pocket depth, clinical attachment level recorded baseline and 3 months after the treatment. And GCF was collected in the test and control group at baseline and 3 months after for the MMP9 analysis. MMPs are so GCF is stored at minus 80 degrees Celsius to avoid the deterioration of the sample, and it was analyzed in ELISA leader using MMP9 kit. So after analysis of with the results, non-parametric test of statistics was analyzed, but based upon the results, we get the values, and from the baseline to 3 months, clinical parameters like bleeding and probing pocket depth, and attachment level were improved from baseline to 3 months in both the SRP and the laser groups. But there was no significant relation between statistical significant relation between the groups. And also GCF, in GCF evaluation, MMP9 levels were reduced from the baseline to 3 months in both SRP and SRP with the laser group. But there was no significant reduction of MMP levels from the baseline to 3 months in between the groups. So based upon within the limitation of my study, I concluded that adjunctive use of 980 nanometer diode laser doesn't have additional effects over the conventional therapy.
It's done?
Yes, sir.
Hello, Venkat sir.
Yes, sir.
Okay. You have taken the moderate to mild to moderate chronic peritonitis. What do you mean by mild to moderate?
Sir?
What do you mean by mild to moderate?
Sir, the clinical attachment of 2 to 4 mm. Clinical attachment of 2 to 4 mm. I have taken some moderate peritonitis patients, sir. Severe peritonitis patients of more than attachment loss over 4 to 6 mm are not taken, sir, because they are going for regeneration procedures. So I have taken moderate peritonitis patients for the non-surgical peritonitis treatment also.
Which statistical analysis you have done? Which statistical analysis?
Sir, non-parametric test of significance, sir.
Non-parametric. Name that one. Name that one. Name that one.
Sir, it's ANOVA, sir.
What?
ANOVA test of significance, sir. Multiple variables, sir.
ANOVA. Okay. Okay. Madam, you can ask.
Okay. I just want to ask Venkat, any specific reason for picking up MMP9? Like there have been many other inflammatory mediators that have been studied.
Yes,
so any of the
Ma'am, usually MMP8 and MMP1, the MM2 they were analyzed more studies for this periodontal destruction, ma'am. But the MMP9 also have a significant value of in role of periodontal tissue destruction, ma'am. But there was limited studies in relation to MMP9, ma'am. So I have to check. I have taken this MMP9 for analysis.
okay, there are less studies because it has less role. So any parent article which you could quote
after non-surgical treatment and along with laser, they have a minimal amount of studies in MMP9. That's why I taken.
Okay.
Thank you, Dr. Venkatesh. Our next poster by Dr. Bikas Vasisht.
Hello. Hello.
Hello, Bikas. You are audible.
Yes, may I start, ma'am?
Yes.
Yes, good morning, respected teachers. Today, my poster presentation is on the topic STEMS, a promising and a progressive approach. As the name stands for, the specifically targeted antimicrobial peptides, which are designed to selectively target and kill specific pathogens, and at the same time without affecting the normal microbial flora, in which we are discussing about the Streptococcus mutans, which is abundantly present in the oral cavity. It has been implicated as the major acid-producing karyogenic bacteria, which leads to plaque inhibition. Types of the stems. who et al., Arikert, McHardy have developed the stems and also evaluated its effect on the growth of Streptococcus mutans by flu. The types of the stems are as C8H, C11H, C12H, C13H, and 40, C16G2, M8G2, C1633, and M833, which significantly inhibited the growth of the Streptococcus mutans. Now going about the discuss of the structure of the C16G2. It has the two regions. One is the target region and other is the killing region. The target region is of the competent stimulating peptide pheromones, CSP16, and the killing region is the antimicrobial region, domain G2. These two regions are joined by a triglyceride linkage, flexible groups. The target region bind to the cell membrane and the killing domain act by killing it. And the mechanism of action, by going further, the mechanism of action is by the two process. One is by the perforation method and the other is the non-perforation. In the non-perforation, the antimicrobial peptides simply disrupt the normal physiological function of the cell wall and goes through the cell death. Whereas in the perforation method, the cationic peptides attaches to the negatively charged bacterial cell membranes and form a secondary structures, which then the antimicrobial peptides bring the fibers into the orient into the perpendicular or the peddler motion, which leads to the modes of insertion into the carpet model, barrel stem model, and the toropoidal pore model, which ultimately lead to the cell death and the results into the inhibition of the DNA and RNA synthesis, inhibition of protein synthesis and the protein folding, inhibition of cell wall synthesis and the enzymatic activity and the other targets. Now the stability and the protective effects of the C16G2. When we use the 0.04% of the weightage by volume in the form of rinse and gel, it effectively lessen the lactic acid production, protect enamel against demineralization, elevate the resting pH of dental plaque, and also in the terms of the stability, the C16G2 was estimated to be in the 18.18 minutes in the yes. Hello.
Yes. Hello.
Actually,
we are not completed. So, what is your conclusion? You tell. What is your main motto of this the poster?
Sir. Yes, sir.
Just what you want to show? What is your motto of this poster?
Sir, my motto is that in the leading in the future dentistry, it can be act as in the precautionary step, as it selectively target the Streptococcus mutans and inhibit the process of the demineralization and also the inhibit plaque formation. So in the leading time, we can protect the teeth and the many costly treatment of the patient by this.
Okay. Madam, can I ask?
Okay, what is the advantage of these specifically targeted antimicrobial peptides over broad spectrum ones?
Ma'am, advantages of these specifically targeted antimicrobial peptide is that it does not affect the normal other microbial flora. It affects only the specifically and the targeted, as we are going to telling about the Streptococcus mutans. So it only targets it. It does not affect the other pathogens which are normal or the resident microbial flora which are beneficial for the oral cavity.
Anything you know about how these are prepared?
Ma'am, these are chemically prepared. These are the oligopeptides which are formed from 5 to 100 peptides. Currently, up to 24 August 2020, we have been discovered 3,240 antimicrobial peptides.
Can we convert broad spectrum wala things to these specific antibodies, antimicrobial peptides?
Yes, ma'am, by selectively picking the target portion.
Right.
Thank you, Dr. Venkatesh. Our next poster by Dr. Tejasvi Kaur.
Am I audible?
Yes, you're audible. Start.
Good morning, judges. My topic of poster presentation today is comparative evaluation of surgical treatment of gingival hyperpigmentation using different techniques. It was a split mouth study. Gingival health and appearance are an essential component of an attractive smile. Gingival depigmentation can be considered as a periodontal plastic procedure whereby the gingival hyperpigmentation is removed by various techniques. Most of the studies conducted so far have compared 2 or more depigmentation modalities, including comparison of laser with surgical scalpel, electrocautery, and burr. Very few studies have been done previously using Kirkland's gingivectomy knife with other surgical options or modalities. The aim of my present study was to compare 4 treatment modalities that was using Kirkland knife, rotary burr, electrocautery, and a diode laser. The following clinical parameters were recorded at day 0 at the baseline, melanin pigmentation index and OHIS score. At day 1 postoperatively VAS scale. After 1 week, melanin pigmentation index, OHIS, VAS scale and the healing index. After 4 weeks, pigmentation index and
ये मतलब पूरी प्रेजेंटेशन होने से पहले इन्होंने बांट रखा
after 12 weeks, melanin pigmentation index, OHIS score, and the healing index were recorded. Surgical stripping has been the conventional treatment of choice as it is convenient, cost effective, and less technique sensitive, and has been considered the gold standard. But our review showed that new techniques are equally effective or even better than the conventional surgery when different parameters were assessed. So when healing was assessed, delayed healing was observed in electrocautery treated sites, followed by laser treated sites at first week, but comparable results were seen with respect to healing at 4th week by all treatment modalities. When pain perception was compared, increased pain perception associated with knife surgery was seen, followed by burr and electrocautery. Comparable results were seen with respect to depigmentation procedure with all the treatment modalities used. Due to psychological fear of pain and bleeding by conventional knife surgery, other treatment alternatives were preferred by patients. So in conclusion, depigmentation with laser, burr, electrocautery, and the Kirkland's knife appears to be a safe and effective alternative procedure for treatment of gingival melanin pigmentation in comparison with scalpel surgery. Thank you.
Hello, Tejasvi.
Yes, sir.
What is chances of relapse of this depigmentation?
So relapse chances have been there have been cases of repigmentation after seen at earliest around 6 months. Our study was for the duration of 3 months, so no repigmentation was seen.
Any method of which has a less chance of relapse? You are suggesting different techniques. Which techniques has a less chance of relapse?
So the surgical techniques, sir.
How melanin formed? Can you give the chemical pathway?
Sorry, sir.
Melanin formation, synthesis of melanin.
Yes, sir.
Tell me.
So melanin pigmentation. So melanin basically forms by the melanocytes, the basement layer, sir, and then so it is transferred to the various other cells, and it matures as the cell reaches the top most layer, sir.
No, I'm telling the chemical pathway from where to where that is given in the current. No? Okay. Madam, you can ask.
Okay, Tejasvi, in continuation to sir's question only, what is the theory of repigmentation? How repigmentation occurs at all? Yeah, I guess am I audible?
Yes, ma'am, you are.
I guess we can take up next.
I request to presenters, when they present or in the question answer session, please on your video. Thank you.
Thank you, Dr. Tejaswi. Our next poster presentation by Dr. Chitrika Suhadarshini.
Good morning, everyone. I'm going to present a poster on reaugmentation of deficient alveolar ridges using piezosurgery. The goal of aesthetic rehabilitation is to evaluate or eliminate deficiency and to obtain optimal aesthetic, which largely depend on the interaction between multiple variables. For reconstruction of severe localized ridge defect, various techniques have been evaluated. Traditionally, bone block graft have been tried in the literature, which include gold standard autologous bone graft harvested intraorally and extraorally. Intraorally from synthesis, ramus and zygomatic process, extraorally from iliac case. Allogenic bone graft, genogenic bone graft, and alloplastic bone graft also have been used. Coming to the etiology of ridge defect, advanced periodontal disease, improper tooth extraction, abscess formation, tumor, trauma, congenital disease, implant failure, long-standing periapical infection. So the aim of my case report is to evaluate the effectiveness of piezosurgery for harvesting autologous mandibular bone block graft to augment a single or multiple edentulous site. Coming to case presentation, a 25-year-old male patient reported to the Department of Periodontics to the chief complaint of missing teeth in lower front region of jaw due to road traffic accident 1 year back. On the clinical evaluation, the gingival biotap was thick and with adequate width of attached gingiva. The clinical and radiographic evaluation revealed that there was a lack of alveolar ridge height and width, hence it was decided to augment the alveolar crest both horizontally and vertically. The mandibular symphysis area was selected as the donor site for the bone augmentation. After anesthesia, full thickness mucoperiosteal flap was raised to expose and visualize the size of defect. Next, the buccopalatal width and height of the alveolar bone was measured, where the defect height was 2 mm and the width was about 3 mm. After the extent of the bone loss was outlined at the recipient site, we proceed with the donor site exposure. The surgical marking pen was used to outline the area of the vestibular incision at the symphysis region. Surgical template was obtained following 5 mm rule using piezosurgery device. The autologous bone block graft was obtained and placed in a ridge defect with the help of titanium screw. Before placing the autologous bone graft, decorticization of the recipient site was done. In 3-month follow-up, we can clearly appreciate the substantial gain in the both horizontal and vertical dimension of the edentulous site, which is suitable for the receiving implant therapy. Coming to the advantages of autologous bone graft are the only bone graft with an osteogenic potential. It is infection resistant. Secondary healing potential with wound dehiscence are minimum. Disadvantages are inevitable additional surgeries, limited amount of harvested material, possibility of significant resorption. Coming to the advantages of using piezosurgery over conventional method, persistent by the patient piezosurgery gene harvested is less traumatic as compared to the conventional or rotary burr method. Less postoperative morbidity is seen. The piezo-osteotomy makes a narrow cut with little bone wastage. Increased temperature during the bone cutting was avoided with reduced bone damage. The force necessary to cut using piezo is less. So the conclusion was there was almost complete restoration of the ridge dimensions of a longer edentulous span, both buccolingually as well as apicocoronally. Thank you.
Hello.
Yes, sir.
Okay, your main is piezo surgery. Who is
Yes,
invented that one?
sir.
Can you name the
Piezosurgery in 2002 by sorry, sir.
2002? Okay, what is the, you did not tell me what is the limitation of this piezo surgery?
Yes, sir.
Limitation of the piezo surgery. Limitation.
Sir, yes, sir. Sir, it is expensive, and in case of any systemic disease patients, we cannot use any piezosurgery. And
Like system, can patient with pacemaker can it use?
no, sir.
Okay, any other limitation?
And sir, it should be used in caution because it may break, the tip may break, and
Okay. Okay.
Okay. Can you tell me any supporting studies for your study?
Ma'am, yes, many studies were done using piezo. One study, they used ramus area as a autologous bone graft donor site for the
Tell me
defect in the
author name and year.
maxillary anterior.
Author and year. Just mention author and year.
Ma'am, autologous or any other bone block, ma'am?
What was that rule of 5 which you mentioned?
Ma'am, from the tip of the root to 5 mm from the tip of the root and 5 mm from the inferior alveolar canal, we mark the autologous bone block area, and after that we place a template using the BP blade cover, and then we mark the autologous bone block using piezo, cut the bone graft using piezo device. Thank you, ma'am.
Thank you, Dr. Chitrika. Next presentation by Dr. Bidusi Narang.
Good morning, everyone. Hello.
Yes, Bidusi, you are audible.
Okay. Good morning, everyone. Topic of my presentation is the comparative evaluation of the tetracycline fibers and the chlorhexidine chip as an adjunct to scaling and the root planning in the treatment of the chronic periodontitis. Chronic periodontitis is a complex multifactorial disease and results in a progressive loss of attachment and formation of the periodontal pocket. There are multiple options of the antimicrobials that can be locally delivered into the mucosa, such as the tetracycline, doxycycline, minocycline, chlorhexidine, metronidazole, enzymes, and the quaternary ammonium compounds. The initial treatment of the periodontitis involves the scaling and the root cleaning, mechanical debridement of the surfaces, or the oral hygiene orientations. To complement the non-surgical therapy, there are multiple options of the antimicrobials such as the chlorhexidine and the tetracycline fibers. Aim of the study is to evaluate the effectiveness of the tetracycline fibers and the chlorhexidine chip, and to compare the clinical parameters as measured for the pocket depth, and to evaluate the attachment level, Park index, and the gingival index. Methodology of the presentation includes the three groups: Group 1, Group 2, and the Group 3. Group 1 received the scaling and root planing alone. Group 2 received the tetracycline fibers as an adjunct to scaling and root planing. And Group 3 received the chlorhexidine chip as an adjunct to scaling and root planing. So the pockets having probing depth of more than 5 mm or equal to 5 mm.
10 minutes break. 10 minutes break till हम नहीं. The next point 10 minutes break.
Tech team, please mute yourself.
To conclude, the difference between the groups for the percentage reduction in probing depth and the relative attachment loss score comes out to statistically significant in Group 3, that is the chlorhexidine group, when compared to the tetracycline fibers and scaling and root planing.
Is it done, Bidusi?
Yes, sir.
Okay.
Hello.
Hello, Bidusi.
Yes, sir.
Okay, I will ask a simple question. Can you define scaling and root planning?
Yes, sir. Scaling is defined as the removal of the plaque and the calculus from the root surfaces, and root planning.
What is root planning?
Root planning is defined as the removal of the plaque and calculus in which the roots remain hardened.
Not telling proper. Madam, can I ask? Madam, you can ask.
Okay, Vidushi, can you tell me what should be the ideal length of tetracycline fibers and how much drug they are impregnated with?
Ma'am, in tetracycline fibers, 2 mg of chlorhexidine hydrochloride drug is impregnated. and 9 inches of 9 inch is the length of the fiber.
Come again. Can you tell me again how much drug is impregnated?
When tetracycline fibers contain 25 mg of pure fibrillar collagen with 2 mg of tetracycline hydrochloride.
Okay.
Thank you, Dr. Vidusi. Our next participant, Dr. Jaishan Prem Kumar, has not joined yet. So,
Okay, so shall we consider the session closed?
ma'am, yes, he has not joined, ma'am. Yes, so we'll end this session here, ma'am.
Okay, thank
Thank
you.
you, Dr. Avdesh sir and Dr. Prerna ma'am. Thank you very much for taking out your valuable time and being a part of this first virtual PG convention. And please, ma'am and sir, a sincere request, please do submit that evaluation sheet by half an hour to the mentioned email and WhatsApp number, ma'am.
Okay,
Yes.
thank you.
Thank you.
Thank you, ma'am. Thank you, sir. So our next session will be started at 11:30.
Friends, periodontal disease leads to loss of teeth, and this loss of teeth has to be rectified by way of placing artificial teeth. And who else better than a periodontist would be able to restore the teeth, and this by way of dental implants. Dental implants has been aggressively being practiced these days into dental clinics, and periodontist is one of the best specialist in terms of practicing implant dentistry, because he knows the details and nuances and also the structures which are involved into placement of dental implants. So whenever you are experiencing dental loss or tooth loss, better go to a dental surgeon and go in for dental implant therapy. Dear friends, on behalf of the Indian Society of Periodontology, I wish to inform you that according to the data of WHO, we have 80% of our population which is affected with some or the other sort of periodontal diseases. Periodontal diseases are gum diseases and which increase in severity and lead to periodontitis, which ultimately leads to tooth loss. So, if we consider the huge population, which is if we consider our country as the second most populous country of the world, then definitely it's a huge healthcare burden over us. And if we consider the clinical data, it reflects that very less number of patients are being treated for periodontal conditions into our clinical practices. And this is basically because of the fact that we devote less time into diagnosing these conditions. Since these conditions are asymptomatic conditions, there is a great possibility of them being missed upon in the initial examination. So, I would request all of you to devote adequate time into diagnosing these conditions at the initial screening visits, so that we would be able to provide a healthy periodontium and a healthy masticatory apparatuses to our patients. Thank you.
Aesthetic and smile designing is incomplete without the proper care of the pink. The judicious balance of white and pink is a prerequisite for aesthetic periodontal outcome. The various aesthetic periodontal surgeries, various aesthetic periodontal treatments like periodontal plastic surgery and even the newer advances in periodontal microsurgery are very handy in comprehensive aesthetic periodontal care for the patients.
Hi. As we all know, the periodontal disease is one of the integral part in dentistry, and the survey shows that 95% of the population are affected with periodontal disease. Here, we as a periodontist are taking an effort to get into the masses of the population to create an awareness among the general public and to create an impact as well as on the treatment line and to create an impact on the urban as well as the rural population in the coming years. So, we are creating an attempt as a President-elect of Indian Society of Periodontology to have a proper screening, charting and a treatment line for the patients and to have a benefit for them as such. Thank you.
Okay, pedicle buccal fat pad graph for the root coverage in the recession, gingival recession coverage defect is the topic for the paper presentation in the case report. The presenting author is Dr. Kshitija Sawan, myself, and second postgraduate, and co-author is Dr. Vinayak Merwade sir, is the reader. And the paper abstract is 430-591. The contents of this case report is introduction, case report, results, discussion, and the conclusion. So coming to the introduction, gingival recession is an apical displacement of the gingival margin from the cement enamel junction and exposing the root surface to the oral environment, which leads to root sensitivity, pain, root caries, plaque retention, poor aesthetics, and tooth loss. The etiology of recession is multifactorial, and all the recession coverage procedures have the goal is to restore the gingival margin to the cement enamel junction, and the prognosis for class 1 and class 2 millers is 100% root coverage, while only partial root coverage is anticipated in class 4, class 3, and class 4. So buccal fat pad was first described by Heisen in 1875, and then the buccal fat pad by 1977. And the buccal fat pad was used to in the upper and upper molar and premolar teeth, and several advantages as favorable anatomical location, easy harvesting and mobilization, excellent blood supply, and minimal donor site morbidity. The fat cells are completely replaced by a cellular fibrous tissue covered by stratified squamous epithelium, and it has a rich in vascularities and stem cells, and also resistance to infection. So the aim is to of this case report is to establish a new technique for the root coverage using pedicle buccal fat pad and Miller class 4 recession of maxillary second left premolar. Second premolar. The patient, 56-year-old male, referred to the Department of Periodontology by Prosthodontic Department for the prognosis with respect to 2-5. There was a class 4 Miller's class 4 recession. So 20.
A very good morning. Now I would like to invite Dr. Manvi Chandra Agrawal, ma'am, Professor, Department of Periodontology, Institute of Dental Science, Bareilly, and Dr. Nilima Katti, ma'am, Reader from ACB Dental College, Cuttack. Ma'am, please do chair this session, and our first poster presentation by Dr. Prerna Pandey.
Hello. Can I start?
Yeah, please do that.
Yeah. Good afternoon, ma'am. Today, my poster presentation topic is on rebuilding the interproximal papilla, description of tube technique, and the 2 case reports. So basically, the papilla reconstruction relies on the same principles like soft tissue grafting. It is uniquely challenging because of the small size and lack of blood supply. Inclusion criteria: individuals healthy, non-smoking, adults at attachment loss of 5 mm, whereas exclusion criteria: carious lesions, shallow vestibular depth, and patients with poor oral hygiene. So case 1 representing 31-year-old female with class 2 recession, bleeding on probing, initial recording for the recession with attachment loss of 5 mm. A net gain of 5 mm was noted on healing on 1 year follow. This is basically tube technique. Then it's a case 2, that is 27-year female with class 3 recession according to Carious, bleeding on probing, and recession was 5 mm in depth and 5 mm in width. Whereas at the end of 1 year, a net gain of 4 mm was noted on healing. So tube technique was basically the semilunar incision, buccally or palatally we'll give. Then we will reflect the flap with the help of excavator. Then we'll retrieve the graft from the palatal area. As such, we can derive the large dimension tissue from there with 2 mm away from the gingival margin, and then we get a tube-like recipient site with the 2 openings, buccal as well as palatal site. So with the help of suture at the one end, we'll place or we can slip out the connective tissue graft from the palatal towards the buccal area, and then we'll suture with both the flaps respectively in the palatal area as well as in the buccal area. This technique is basically advantageous because it provides larger grade blood supply, but the limitation is this is a technical precision and sensitive to any surgical trauma and tension, and cannot be performed in presence of any scar tissue at the recipient site. But it maintains, we can say, unrestricted blood supply at the recipient site, and it also helps in selecting appropriate thick donor tissue from the palate. And the graft size is larger, that is 12 to 15 mm at the defect site of the recipient site. Thank you.
Dr. Prerna, am I audible?
Yes, ma'am.
Who proposed this technique and when?
Ma'am, this technique is basically the series I have taken from the journal, ma'am, that I don't know.
You don't know, you're presenting and you don't know? Okay, that is, you're talking about the journal from where it has been taken. Tell me the pioneer person in this.
Ma'am, I don't know the name, that's what I'm telling.
That's a name which you don't know. Okay.
Yes, ma'am.
What's the advantage of using connective tissue graft in this?
Ma'am, we can get the keratinized tissue from the palate, or we can have the unrestricted blood supply at the recipient area, because it has a rich amount of keratinized tissue which we have derived from the palate.
So is it the connective tissue that we are harvesting is rich in keratinized this thing? Is it keratinized?
Ma'am, yes, ma'am. It is. We have deriving the connective tissue graft from the palate. So it always. Hello.
Yes. Speak up.
Yes, ma'am. We can derive the connective tissue graft as it is always better than the gingival graft because it also provides the genetic factors or it is a good supply of keratinized tissue.
Connective tissue of palate is not keratinized. I must tell you, it has the cells which has the capacity to induce the genetic makeup in such a way that the overlying. Yeah, that is, you were supposed to answer in that way. It has the potential of causing the conversion of the overlying epithelium into a keratinized tissue.
Keratinized.
Right?
Yes.
It itself, it is keratinized. That is why you're placing it. It is because of the ample blood that you can push the tissue inside the site.
Right. Yes.
Dr. Am I audible?
Yes, ma'am. Yes.
The first case which you showed as class 2 recession.
Yes, ma'am.
There was incidental tissue loss, so probably it will go in class 3.
Sorry, ma'am, I'm not able to.
The first case which you had showed.
Yes, ma'am.
I think it is class 3 because we can see some incidental tissue loss, soft tissue loss. Isn't it?
Yes, ma'am, it may be, but it is according to Keros classification that there is interproximal loss, but it is less than buccal interproximal. That's why.
Classification, not Miller's classification.
Yes, ma'am. Not Miller.
So if you are using Kairos classification, it is either RT1, 2, or 3.
Yes, ma'am.
We all know that papilla reconstruction.
Yes, ma'am.
No much evidence on long-term stability of the graft.
Yes, ma'am.
So in your study or in the original article, for how they follow it up? Because usually we see once the connective tissue is placed.
For how much follow-up?
Yeah.
Ma'am, it is for I have for 1 week, for 1 year.
1 year.
Okay. Yes, ma'am.
That's
all. Okay, thank you.
Thank you, Dr. Prerna. Let's move on to next poster presentation by Dr. Suham Chatterjee.
Hello.
Yes, start, Mr. Chatterjee, please.
Hello. My study is about the efficacy of electronic power sourcer in reduction of gingival inflammation, and it is a clinical study. The aim was to evaluate the efficacy of the electronic power sourcer after patients are selected. Well, did scaling and root planing in both the 30 patients only, and there at first there was scaling and root planing, and 10 patients were only brushing, and 10 patients were using manual floss, and 10 patients were using electronic power flosser. And after the scaling and root planing, I took the PI and GI score before scaling and root planing. Group A was 2.7, Group B was 3.1, and Group C was 3.2. After 1 month interval of them, and where there was indicated that they can use flosser and power flosser, and they had that abrasures, so I gave them. And after 2 months follow-up, I saw that the results were very good with the electronic power flosser, and there was a reduction of the PI and GI score very much, and so the patient's gingiva and everything was very healthy, and the use of electronic power flosser gave a nice oral hygiene, and maintenance of the patient was very good. And the conclusion was made that the electronic power flosser was very useful in the maintenance phase during the non-surgical periodontal therapy. So hello.
Done with your presentation?
Yes, ma'am.
What is the oral hygiene procedures post your
Yes, ma'am.
You have the oral hygiene procedures post it. I think there is a noise coming from the background.
Actually, here is a network issue, ma'am. Tell me.
Okay, so how did you standardize the oral hygiene procedures post groups? That is,
Ma'am, I standardized it by using, ma'am, the group A was only using brushing only and using
of the groups which are using floss, they are not only using just floss, right? They're also brushing their teeth. What brushing technique?
yes, ma'am.
What oral hygiene schedule did you put them on?
And they were brushing in modified bath technique, ma'am.
Okay, all the 3 groups.
Yes, ma'am.
That's one problem. Over to you, ma'am.
Dr. Soham?
Yes, ma'am.
The first group was doing brushing only. The second group you had brushing plus flossing, and third was brushing plus this power.
Electronic power. Yes, ma'am. Power flosser. They were using power flosser.
So, according to your results, you found that results were most convincing in group 3, right?
Yes, ma'am.
So they afforded added advantage, no, over brushing these electronic power flossers.
Ma'am, come again, ma'am, please.
Advantage over brushing, manual flossing. Since you were brushing also, using these power flossers also, so they
Yes,
afford
ma'am.
an added advantage, right?
Yes, ma'am.
Can you please tell me the name of marketed power flosser?
Ma'am, water pink I gave, water pick, ma'am. The value, the name of the water pick I gave, the serial number of that was FLA220.
Okay, thank you.
Thank you, Dr. Soham. Our next presentation by Dr. Namrata Khetal.
চলুন স্যার হয়ে গেছে ওটা
Good afternoon, ma'am.
বেশি লম্বা চলে
Am I audible?
I think somebody's mic is on other than
Good afternoon, ma'am. Am I audible?
Yeah, please continue. Please continue.
A very good afternoon. Today I'm here to present my poster upon the topic comparative evaluation of periodontal status after open flap approach and minimally invasive approach for piezosurgically assisted canine retraction. As we all know, periodontally accelerated osteogenic orthodontics plays a vital role in accelerating the movement of tooth by facilitating invasion of an array of biological mediators and reducing the overall treatment time of orthodontic therapy. The aim of present study was to compare and clinically evaluate the periodontal status following open flap approach and minimally invasive approach amongst the patients undergoing piezosurgically assisted canine retraction. 10 patients were randomly divided into 2 groups. Group 1 received the treatment sequence this was the preoperative view. Circular incision was given, full thickness flap was reflected, and the corticotomy was performed with the help of piezosurgical unit. After that, resorbable sutures were placed, and this is the postoperative view. Group 2 received placement of 2 parallel vertical incisions, sparing the interdental papilla. Corticotomy was performed with the piezosurgical unit, and the margins were approximated, and they were closed with the help of isoamyl 2 cyanoacrylate. And here is the postoperative view. The observations of the present study showed that 80% of patients, 80% of patient satisfaction was noted amongst the minimally invasive approach group, whereas significantly higher plaque index and resultant gingival score was observed in group 1, but only at 1 month postoperatively. And there were no significant difference observed regarding probing pocket depth and relative attachment level amongst the study groups at all the time periods. Similar studies to these have been conducted in literature. Abbas et al. In the year 2020 conducted a similar investigation with the purpose to evaluate the efficiency of corticotomy facilitated orthodontics and piezo-scission for rapid canine retraction. But the difference was he had checked the periodontal status directly after 3 months, in contrast to the present investigation where we have checked it at 1 month and then at 3 months. Subhash Chandra et al. In the year 2020 had compared a similar study to compare the efficiency with and without piezo-scission assisted. Similarly, he assessed the periodontal parameters, and the results are in accordance with the results of his observation. So we come to a conclusion that minimally invasive approach, which determines the alternative approaches that are developed to allow less extensive manipulation of surrounding periodontal tissues than what happens in conventional procedures while accomplishing the same objectives. It proves beneficial in maintaining stability of the periodontium, thereby emphasizing the maintenance of healthy periodontium during active phase of orthodontic therapy. Thank you, ma'am.
Dr. Namrata?
Yes, ma'am.
I guess you're talking about flap and flapless technique for canine infection for corticotomies?
Yes, ma'am.
Okay. So what do you think is the one major difference between both the techniques?
One major difference is in one technique we are reflecting a full thickness flap, and in the second one we are not disturbing the flap integrity. We are just incising the place at which we intend to place the piezo incision.
Right. How do you decide in which case you should opt for technique 1 and in which cases you should opt for technique 2?
Ma'am, on the basis of case selection for the present study, we had conducted it upon, we had not purposely selected certain patients. So it can be minimally invasive technique can also be done on all the patients that are scheduled for canine retraction. It provides
Right, absolutely right. I just want to ask you wherein technique 2 is indicated. Indication of technique 2.
Otherwise, ma'am, in certain cases where firstly the orthodontist, when he refers to us that he is not getting appropriate results, and when the patient has had previous experience of gingival inflammation owing to bracket placement and wire placement, and in certain cases we can consider minimally invasive approach for that purpose, because it will reduce the invasion altogether.
It's okay. That's not indication, Namrata. It's okay. Over to you, Doctor.
Yeah, Dr. Namrata.
Yes, ma'am.
It was based on the evaluation of periodontal status, right?
Yes, ma'am.
But there is no index you have checked for periodontal status, GI and PI, that's all. Something for the attachment loss, because you are comparing a minimally invasive with the open flap open flap technique for piezo-scission. Okay, so something related, because once you reflect the flap, the chance of attachment loss will be more. So maybe you could have added a Russell's index to check for the periodontal status.
Yes, ma'am.
Okay.
Yes, ma'am. I'll consider this and I'll try to incorporate it, because Russell's index would reflect better periodontal status.
That's all from me. Thank you.
Thank you, Dr. Namrata. Our next presentation by Dr. Snigdha Pujari.
Good afternoon, ma'am. Ma'am, I am not able to share my screen, ma'am.
This is the previous presentation, I guess.
Yes, ma'am. Ma'am, I am not able to share my screen, ma'am.
Somebody in the technical team?
Ma'am, it has been like you cannot share your screen while the other participant is sharing, ma'am.
Okay, I think this is yours. Is this yours? No, this is the next one. Swayamprabha, are you there?
Ma'am.
We don't have your presentation. If you have, you can share.
Yes, ma'am. Yes, yes. Yes.
Please share.
Good morning, ma'am. Today I'm Dr. Snigdha Pujari. I'm going to present my poster presentation on topic comparative evaluation of 1% curcumin and 0.12% chlorhexidine in the management of chronic periodontitis as an adjunct to scaling and root planning, a clinical study. So, ma'am, I have taken the patient for the materials and methods. I have taken 20 patients from the outpatient of Chhattisgarh Dental College and Research Institute. Then I have taken the inclusion criteria of having age 30 to 55 years, having mild to moderate periodontitis case, or having pocket depth 5 mm to 6 mm. So I have divided into two groups, group A and group B. Then group A, after scaling and root planing, I have done the chlorhexidine irrigants, and in group B, I have done the 1% curcumin irrigants. So first preparation of the curcumin, I have taken the curcumin extract from the Department of Ayurvedic College present in the CDCRI only. They have prepared the curcumin extract. Then I have prepared the curcumin irrigants by adding 5 ml of the ethanol with 25 ml of the glycerol. Then, and it should be, the curcumin has been prepared freshly. Then I have taken the curcumin extraction, and I have randomized the patient by computerized randomization technique. Then in group A, I have done the after scaling and root planing chlorhexidine irrigants, and group B, I have done the 1% curcumin irrigants. And as curcumin is having the antioxidant property and also better healing property and also anti-inflammatory action. So the result when we take also I have analyzed the gingival index, plaque index, and probing pocket depth. After 1 week, I have seen the evaluation was after 1 week, 1 month, and after 3 months. So the final evaluation after 3 months, it has been seen that when I compare the irrigants and the curcumin irrigants, it has no significant difference. But I have seen that as curcumin is an Ayurvedic product, so and it is now available everywhere, so it can be used as an alternative to chlorhexidine irrigant. Also, as chlorhexidine has been a gold standard, so it has been used from very beginning. So we can use curcumin solution as an irrigant as an alternative to chlorhexidine. Also, the chlorhexidine, also the curcumin solution is having the collagen proper. It has the property which has the kappa beta, which is present in the curcumin. Also, it is the property of antioxidant, so it has a better healing property. And also, it is a good alternative to scaling and root planing, which is used in chlorhexidine. Thank you, ma'am.
So you took curcumin extract.
Yes, ma'am.
In 1% concentration.
Yes, ma'am.
Okay, but
Yes,
what
ma'am.
you took hexidine mouthwash, or you took the molecule?
Ma'am, mouthwash only, ma'am.
You took the mouthwash, but here the curcumin is in pure molecular form, and hexidine doesn't have pure molecular form of chlorhexidine. It has additives also. Are you aware of that?
Yes, ma'am.
In a mouthwash,
Yes, ma'am.
some additives for prolonging the shelf life, for acting as an adjuvant. Then there is some water. So how do you justify this using a pure molecule versus a mouthwash?
Ma'am, chlorhexidine is also a gold standard, ma'am. It also has substantivity, but I am only evaluating the probing pocket depth, ma'am, and the gingival index and probing index, ma'am. So, ma'am,
yeah,
we
agreed.
we can use.
Yeah,
ma'am, we can use as an alternative to chlorhexidine, ma'am.
no, we can use it, but when you're comparing two molecules, both of them should be in the same molecular form. Okay, next question is you said as an adjunct to scaling and root planing. How is it possible? Curcumin can be used as an adjunct to to replace scaling and root planning. Some statement you had made in the conclusion, I think. So are you
No,
replacing?
ma'am. Yes, no, ma'am. First, mechanical debridement should be there, ma'am, by scaling and root planing. Then I have used the curcumin as an irrigant, ma'am.
Okay. Dr. Manvi, over to you.
Dr. Snigdha,
Yes, ma'am.
are you using an irrigant in the clinical department itself, or are you prescribing it to the patient as to be used as a mouthwash at home?
No, ma'am, as an irrigant in department itself, ma'am.
Just now you answered to Dr. Nilima that it has.
Yes, ma'am.
Just now you told to Dr. Nilima no that it is used as a mouthwash here in your case.
No, ma'am, not as a mouthwash, ma'am. I have used the mouthwash irrigant, ma'am. I have taken it 3 ml syringe, 24 gauge needle, and I by 110 degrees bending the needle, I have used as an irrigant, ma'am.
Both of these agents, chlorhexidine and curcumin, right?
Curcumin, yes, ma'am.
Okay. Next question is, which all indices did you measure to analyze the parental status of patient at baseline and then later on?
Ma'am, gingival index, ma'am, probing pocket depth, ma'am, and plaque index, ma'am.
Okay, just tell me an evidence-based study where they potentiate the anti-inflammatory property of curcumin.
Meta-analysis are there, ma'am, where they have proved that curcumin has an anti-inflammatory action because of the anti-collagenase activity, ma'am.
Name of the authors.
Ma'am.
Okay, thank you.
Thank you, Dr. Snigdha. Let's proceed to next presentation by Dr. Priyanka Das.
Can I start, ma'am?
Yeah, please.
Good afternoon, judges. Today my poster topic is on comparative microbiological analysis of periodontal pathogens in stage 3 grade B periodontitis and type 2 diabetes before and after non-surgical periodontal therapy. So as we know, subgingival plaque contains numerous microorganisms which have shown to be responsible for initiation or progression of periodontal disease. So analysis and identifications of this periodontal pathogen is an important aspect and for diagnosis and treatment of periodontal disease. So the BANA enzymatic test kit, it is one of the rapid and chairside diagnostic kit that gives information of the presence of 3 putative pathogens in subgingival plaque, namely the P. gingivalis, the Trichonema denticola, and the Tenorella forsythia. So with this, the aim of the study is to estimate and compare microbial levels in stage 3 grade B periodontitis patient with and without type 2 diabetes before and after non-surgical periodontal therapy. So coming to the methodology, 20 patients were selected for the study based on plaque index, gingival index, probing depth, clinical attachment level, and fasting plasma glucose level. So following which, these 20 patients, they were divided into 2 groups. Group 1 consisted of 10 subgingival plaque samples from 10 patients with stage 3 grade B periodontitis, whereas group 2 consisted of 10 samples from 10 patients with type 2 diabetes along with stage 3 grade B periodontitis. So at baseline, microbiological test of this collected subgingival plaque was done using the BANA test kit, following which all these individuals, they have undergone non-surgical periodontal therapy. And after 4 weeks, the microbiological analysis was once again done. So coming to the result, at baseline, it was seen that the BANA test score showed a positive result in both the groups. And but following 4 weeks, there was a significant statistical reduction on all the clinical parameters. Moreover, the BANA test scores also have shown a significant reduction of around 70% in the test scores of both the groups. So it was thus concluded that periodontal treatment have an impact on the subgingival microflora, and non-surgical periodontal treatment is effective in reducing the microbial load. Thank you.
Dr. Priyanka?
Yes, ma'am.
What is stage 3 grade B periodontitis?
Ma'am, stage 3 grade B is severe periodontitis with potential for additional tooth loss. And grade B, ma'am, it is a moderate rate of progression, ma'am.
Right. So you in your methodology, you have told that the groups were re-evaluated as group 3 and group 4. What do you mean by that?
Ma'am, this group 1 and 2, after the scaling and SRP was done, NSPT, they were categorized as group 3 and group 4.
After non-surgical periodontal therapy?
Yes, yes. The same group, group 1 and 2, it was re-evaluated as group 3 and group 4.
Okay, don't you think that HbA1c could have been a better parameter to evaluate as compared to fasting plasma glucose?
Yes, ma'am. HbA1c it is more. It will be more appropriate for diagnosing the diabetes, ma'am, as compared to fasting. But here we have taken the fasting glucose.
Thank you.
Dr. Priyanka,
Yes, ma'am. Good afternoon.
topic is comparative microbiological analysis.
Yes, ma'am.
But I think it should more aptly should have been renamed as comparative enzymatic analysis. Isn't it? You're nowhere measuring the quality or quantity of microorganisms, but indirectly you're measuring it through the enzymatic analysis, that is BANA. What does BANA stand for?
Ma'am, BANA stands for N-benzoyl DL-arginine 2-naphthalamide.
What is the significance of this BANA?
Ma'am, it is capable of hydrolyzing this synthetic trypsin substrate, ma'am. The microorganisms which are the.
How much each kit cost you, the BANA test? Whatever. I think that should have been highlighted in your topic because you're doing BANA test for measuring the enzymatic analysis rather than you're measuring the microorganism profile. Okay.
Thank you, Dr. Priyanka. Our next presentation by Dr. Syed Feda Najir Bukhari.
Good afternoon, everyone. My topic for the poster presentation is evaluation of effectiveness of topical anesthetic agent on pain and discomfort during scaling in patients with gingivitis. Since gingivitis is often associated with inflammation and there is no attachment loss, but the patients usually come with the pain and discomfort. So to control that pain and discomfort, it is important, it's very important for any successful periodontal therapy. In this study, I have used the intracellular anesthetic gel, which is a secure alternative for pain and control, to control the pain and discomfort during scaling and root planing. So the aim of the study is to evaluate the effectiveness of anesthetic gel lignocaine on pain and discomfort during scaling in patients with gingivitis. The methodology of the study is that 10 patients were recruited. It's the split mouth randomized controlled trial in which draw of lots was done, and the patients were divided into two groups. The quadrants were the mouth was divided in the split mouth design was divided in two groups, that is group 1 with anesthetic agent and group 2 without anesthetic agent. After draw of lot was done, there was a clockwise procedure which was then done to render the mouth plaque free. The scaling was done for 10 minutes, and the parameters which were chosen were visual analog scale and verbal rating scale. Results showed that through in VAS the statistically significant result was found, but with VRS statistically there was no statistical significant result. And the conclusion of this study was that intracellular anesthetic agent may be an effective measure in controlling pain and discomfort during scaling in patients with gingivitis.
How much time interval apart were the two procedures done? It's a split mouth design.
Yes, ma'am, it's a split mouth design, and 10 minutes were taken for each quadrant.
No, I mean the first one segment was anesthetized and the other segment was not anesthetized.
Yes, ma'am.
Like what duration was left between these two segments? On the same day they were done, or you left some time?
Ma'am, the first, like we did the draw of lots, and first quadrant we anesthetized. For 2 minutes we kept the anesthetic agent, and we started scaling for 10. In total, we started scaling for 10 minutes, and then we moved on to next quadrant. Yeah, on the same time, in the same scaling procedure, we did the same.
Got it. But what about the VAS scores? They were given by the same.
Yes, ma'am. Yes, ma'am.
The VAS scores.
Yes, ma'am.
Were given by the same patient for both the quadrants.
Yes.
So, do you think there must be some kind of overlapping? What is the main drawback of split mouth design?
Ma'am, the main drawback is that the split mouth design, it is the same same result, same patient will have the same. There will be sorry, ma'am, I'm just not finding a word for that.
Okay, I'll make it clear for you. What is washover?
Yes, ma'am.
What is washover effect?
Washover effect.
So probably in your study design, if you had anesthetized the segment, done the root planing, sent back the patient, maybe next day you would have recalled, and without anesthesia you would have done the root planing, then the VAS course would have been more appropriate or more accurate.
But ma'am, we have evaluated the pain during scaling.
Pain during scaling?
Yes, ma'am.
But the patient gave VAS course after the procedure was over?
No, during the procedure.
Okay, during the procedure.
Yes.
Dr. Syed Hazan?
Yes, ma'am.
Ask a question that what is the reason for this pain and discomfort during scaling? Does it depend upon the operator also, or does it, or it happens invariably in all the cases?
Ma'am, this topical anesthetic, about 40% of these all the periodontal surgeries we use anesthetic agents. So anesthetic agent patients do come with they might have pain, or they may be that could be psychological also, or that could be even during scaling they can develop the pain. So that depends. So we are actually making the patient more comfortable with controlling over the pain, and through intracellular placement of this anesthetic gel.
My question is the need for this study.
Yes, ma'am. Need of
study.
Yes, ma'am.
What is the need of study? What is the need of the study?
Ma'am, the need of the study is to make patient more comfortable, so that the phase 1 therapy could be can be over with the patient.
Thank you. Thank you, Dr. Syed. Our next presenter is Dr. Subham Jabak.
Good afternoon, respected judges. Am I audible, ma'am?
Yeah,
you are.
Yeah. Today's topic for my poster presentation is comparative clinical evaluation of periosteal pedicle graft technique with Zucchi's technique for management of multiple gingival recession defect, a randomized control clinical trial. Gingival recession is both unpleasant and unaesthetic. The use of periosteum as a pedicle can be used for the treatment of gingival recession defects, given by Mahajan et al. In 2009. The SCTG is gold standard, but we compared the two techniques like Zucchelli and periosteal pedicle flap. Zucchelli's technique given by Zucchelli and D. scientists in 2000 demonstrated the coronally advanced flap modification without vertical releasing incision. The aim of the present study is to compare the periosteal pedicle graft technique with the Zucchelli's technique for the management of multiple gingival recession defect. Materials and method: a sample of 10 recession defect of systemically healthy patient were selected. After the initial non-surgical test, they were divided into the test and the control group. Test was periosteal pedicle and control was Zucchelli's technique. The recession depth, percentage root coverage aesthetic score, width of keratinized tissue, and thickness of keratinized tissue was calculated at baseline and 3 months after the surgery. The coming on the surgical procedure, the anesthesia was given, and in periosteal pedicle graft, the horizontal incision given at the level of CJ, and the full thickness flap was performed 3 to 4 millimeter beyond that, and after that the partial thickness flap was incorporated, and a good amount of periosteum is reflected which is inverted from apicocoronal direction, and it is sutured with sling suture, resorbable sling suture. Then the flap is sutured over it, and the patient was sent in Zucchelli's technique. The oblique submarginal incisions were given, and the split flap was performed and sutured with non-absorbable silk suture. Coming on to result, the recession depth in the both the groups was reduced significantly, but intergroup there was no significant difference. The percentage root coverage, there was no statistically significant difference in both group. In also the root coverage aesthetic score, no statistical difference. The width of keratinized gingiva, was no statistically significant difference between the group, but the mean value was greater in the Zucchelli's technique, and the thickness of keratinized tissue was not significantly difference in both groups, but was greater in the periosteal pedicle graft. The periosteum is highly vascular connective tissue covering the external surface of the bones. Leolic in 1991.
Yeah, Dr. Shubham.
Yes, ma'am.
We used a periosteal pedicle.
Yes, ma'am.
And you yourself said that gold standard is your connective tissue graft with coronal displacement.
According to means literature, ma'am.
Yeah.
There are no more studies on periosteal pedicle, right?
No, I'm talking about the gold standard. So why did you compare with the gold standard?
Ma'am, there are studies with the gold standard already, so I compared with Zucchelli's technique.
Do you compare with the gold standard? Any new technique?
Sorry, ma'am.
Why do you compare any technique with the gold standard?
Ma'am, to evaluate the superiority of the technique.
So you
with the
exactly. So I think you should have compared with the connective tissue graft, because Zucchelli's technique is for the donor side incisions. It doesn't talk about the graft. Okay, but here you are using a novel technique as a graft.
Yes.
How multiple recession means how many recession defects can you cover with this technique?
3 to 4 recession defects.
3 to 4 recession defects.
Yes, ma'am.
Posteriorly, you are mobilizing the pedicle graft. You are mobilizing the graft from the posterior region, and then you are suturing to the anterior region. That is
no,
what.
ma'am. From apical region to then inward to coronal region.
Okay.
From the same tooth from apical to.
Okay, so it's inverting the graft. Okay.
Yes, ma'am. Inverting the graft.
Any studies with a big sample size or a sample size more than 30 has been done on this technique?
No, ma'am. More than 30, there is no study right.
So the studies you are quoted, they have a sample size of what?
10 each group, ma'am.
10 is the maximum.
10. Yes, ma'am.
Okay. What do you think?
This technique? They do not compare the Miss-Board technique like periosteal and Zucchelli. There are studies on periosteal and SCTG, but not on with Zucchelli.
What can the? I'm sorry, Dr. Manvi, please continue.
Shubham, what is the advantage of this periosteal pedicle graft?
Ma'am, periosteal pedicle graft contain the fibroblast progenitor cell, osteoblast progenitor cells, and also the stem cells, which can help for the regeneration of the bone and the cementum and the periodontium.
Is there any difference in the suturing techniques in the Zucchelli one and the first group?
Ma'am, in the test group, means periosteal pedicle, the sling suture plus the flapware suture coronally means 2 times it is sutured, but in Zucchelli's technique only one coronally advanced suture were placed.
Which suture?
Slings means sling to composites, ma'am. Interdental.
Okay, thank you.
Thank you, ma'am.
Thank you, Dr. Subham. As our next presenter, Dr. Girinandin Singh is absent, we will move to next presentation by Dr. Ashwini Lambole.
Hello. Good afternoon, ma'am. Am I audible?
Yeah, you are audible.
Topic of my poster presentation is patient response and recurrence of gingival hyperpigmentation when treated with using diode laser, diamond burr, and scalpel technique, a case series. Oral Oral pigmentation is a discoloration of gingival or oral mucosa, which is associated with several exogenous and endogenous factors. Gingival depigmentation can be considered as a periodontal plastic procedure in which hyperpigmentation is removed by various techniques. The aim of the present case series is to compare and evaluate the effectiveness of three different techniques, that is diode lasers, diamond burr, and scalpel in the depigmentation procedure. Three patients who were aesthetically conscious of their dark gums are requested for the same were selected for this procedure. Laser used in group 1, burr in group 2, and scalpel in group 3 were selected. I had carried out all three procedures in our perio department and recorded the picture for the same at the baseline during procedure 1 week and 1 month, 3 months post-operatively. So coming to the results, pain criteria which is calculated by using the VAS score, which was less in laser group as compared with burr and scalpel 1 day post-operatively. Pain criteria also less in laser group 1 week post-operatively as compared with burr and scalpel technique, and same score was obtained for the pain at 1 month and 3 months post-operatively. For bleeding criteria, less bleeding were noticed during the procedure for laser group as compared with burr and scalpel technique, and no bleeding were failed to the patient 1 week post-operatively, 1 month post-operatively, and 3 months post-operatively for all three procedures. Coming to the melanin pigmentation index, which is according to the Dummett et al. 1964. Laser pigmentation were noticed in laser section, laser group as compared with burr and scalpel at 1 week post-operatively, and no recurrence of pigmentation were seen in all three procedures 1 month and 3 months post-operatively. So coming to the discussion, there are increasing demands for the cosmetic rehabilitation for gingival hyperpigmentation. A present technique with using diamond round burr has difficulty in controlling the depth of the depigmentalization and obtaining an adequate access. Scalpel technique, which is most economical and causes unpleasant bleeding during and after the operation. Diode laser causes minimal damage to the periosteum and bone under the gingiva being treated, and it has the unique property of being able to remove thin layer of epithelium cleanly. So the conclusion of the case series is that better results of the depigmentation were achieved with using diode laser than scalpel and burr with respect to aesthetics, pain, and in terms of bleeding. And the lasers are more effective and also safe in removal of hyperpigmentation from the gingiva.
Ranjan?
Hello, ma'am.
Am I audible, Dr. Anshu?
Yes, ma'am. Yes, ma'am.
Ashwini, sorry, is it Ashwini?
Yes, ma'am.
You've mentioned in your discussion that laser has a unique property of causing minimal damage to the underlying tissue. Is it so? Or is it that it's difficult to control the depth of action of laser? Which statement is true?
Yes, ma'am. Diode laser causes minimal damage to the periosteum and the bone under the gingiva being created, as compared with the scalpel and the burr technique.
According to VRS and VAS, which is better? Arrange them in descending order or ascending order. Laser, scalpel, and diamond burr.
Sorry, ma'am. Hello.
Am I audible, Dr. Ashwini?
No, ma'am, not clearly.
Can you arrange laser, scalpel, and diamond burr in descending order in terms of their effectiveness?
Ma'am, firstly laser, then burr, and then the scalpel technique.
So laser is most
effective.
effective.
Lasers are most effective. Lasers are more effective than both these techniques.
And for in terms of patient
response, In terms of patient response also, ma'am, lasers are more effective in terms of bleeding also and in terms of pain also.
Thank you. Over to Dr. Nigama.
Yeah. What is the most common time period after which you see recurrence in gingival pigmentation after a depigmentation procedure?
Ma'am, actually it depends upon the recurrence of pigmentation. It is exactly time will not be.
There is a time frame. There is a time frame when most of the cases they start showing signs of repigmentation. That is after 4 to 6 months. Okay,
Yes,
you followed up the patients only for 3 months.
yes, I have taken follow up of only 3
So
months.
you should have followed up for a longer period of time.
Yes, ma'am.
Okay, that's all.
Recurrence of more times. Yes.
Thank you, Dr. Ashwini. Our next presentation by Dr. Anshum Gupta.
Yes, ma'am. Just a minute, ma'am. Yes, ma'am. Good afternoon, judges. The topic that was, hello, ma'am, am I audible?
Yeah, you are audible. Please go ahead.
The topic that was given to me today was modified coronary advanced flap in management of isolated gingival recession. This is a saddle flap technique. The indications are reducing of root sensitivity, minimizing cervical root caries, increasing the zone of attached gingiva, and improving aesthetics. Various surgical variants are pedicle graft. In that also comes the pre-gingival graft, connective tissue grafts, along with that guided tissue regeneration and combination of all of these techniques. The advantages of these are minimal invasive procedure to manage isolated gingival recession to obtain better aesthetic results. In addition, unique incision method helps in maintenance of the papillary integrity and associated critical interdental arterial plexus. The full thickness flap elevation coronal to the recession area in order to compensate for the thin biotep present in the gingival marginal area. The split thickness flap on the adjacent teeth and the area apical to the mucogingival junction prevents unnecessary denudation of the bone. This technique not only improved visualization and access to the treated area, but also judiciously flap elevation and greater post-operative comfort with the coronally advanced flap alone as compared to the coronally advanced flap in addition with connective tissue graft. No need for the second surgical site to harvest connective tissue. Like what we used in this technique, this is done is 3 steps. First phase is a saddle incision, then saddle flap elevation, and then modified saddle suturing. After giving the submarginal part of the incision, as we have marked the recession area on the mesial and distal side, we give the saddle flap design, and then we are going to give the intracervical incision on the recession side, which is followed by the horizontal saddle incision in the adjacent teeth. The split thickness oblique incision were given near the adjacent teeth, and then the full thickness was full flap was incision flap was elevated above the recession area. Then coronal to the denuded area, as we know, the elevation was carried out with blunt elevator, and then above the mucogingival junction, the split thickness elevation was done. Once the coronal mobility was deemed, the adequate flap elevation it is adapted. The surgical papilla is adapted on the anatomical papilla. After the deepithelialization of the anatomical papilla, and the sling suture was given with the 50 expanded polytetra fluoroethylene sutures, and the composite stop that we have put before the doing the procedures. We put the sutures over that particular area. Thank you, ma'am.
Okay. You said that there is no need for second surgical site if you are using this technique.
Yes, ma'am.
You say so?
Actually, in this technique, we are not using any pre-gingival graft or connective tissue graft in this case, ma'am.
Normal modified coronally advanced flap, you don't use any. What is the criteria which determines whether you have to use a matrix below the flap, advancing flap or not? What is the criteria which decides whether you have the graft or not?
Yes, ma'am. Ma'am, if there is a presence of 1 to 2 mm of attached gingiva below the area, so we need to go for two-stage surgery, in which we have to first put the connective tissue graft, and after we have gained the attached gingiva, then in the second part of surgery we can go for the we can go for the coronally advanced flap. But if there is a presence of more than 4 mm of the 4 mm of the attached gingiva above the recession area, then no need to go for the connective tissue graft or free gingival graft.
So you mean to say the classical two steps technique is first you do a CTG, connective tissue graft, and then you advance it coronally, or you rather do a free graft and then you advance coronally?
Ma'am, depending upon the conditions, ma'am, if the width of the attached gingiva, width of the attached gingiva is sufficient, and if the thickness of the attached gingiva in that particular area is sufficient, then we can go for the single stage procedure. And if it's not present, then we can go for the two-stage procedure.
It's the thickness of the tissue, thickness of the keratinized tissue, which determines whether you're going for a any matrix below the graft or not. Okay, so even with your technique, if the flap is thin,
yes, ma'am,
maybe you'll not be able to do it coronally advance it.
Yes, ma'am. In case of in this technique, ma'am, we are doing the full flap elevation in case of the denudation at the recession area, and surrounding areas like for the neighboring teeth, we are doing just the split thickness only. If the area is thin in that area, like the patient is having thin profile, then in that area, we may have to go for like what you are saying, two-stage technique, ma'am.
Okay, sir. Dr. Manvi, please.
Propose this technique, saddle technique?
Yes, ma'am.
Who proposed this technique, saddle technique?
This was given, ma'am, in the GIST, ma'am. Ma'am, ISP, ma'am, September 2020, they have given in ISP edition. So actually, we have done 4 or 5 cases in our college, ma'am. So that's why.
So that's okay. Do you have any idea who proposed this technique?
No, ma'am. Actually, that's ma'am. That's an advancement of. That's a mixture of multiple techniques, ma'am. Like first, Carnot's technique. Then similar. Then one Carbondent has given it for 2 teeth, and this is a modification of that technique, Carbondent technique, only on the single tooth only, ma'am.
Do you have a modification of this technique also? Modified saddle?
No, ma'am. Not till now, ma'am.
Okay, thank you.
Thank you, Dr. Ansum Gupta. With this, we end our session. Thank you, Dr. Nilima Katti ma'am and Dr. Manvi Chandra ma'am, for taking out your valuable time and being a part of this first virtual PG convention, ma'am. Ma'am, a sincere request. Please do submit that evaluation sheet by half an hour to the mentioned email and WhatsApp number, ma'am. Thank you, ma'am. Thank you very much. Thank you.
Thank you, Dr. Manvi. Thank you, ISP, for giving the opportunity.
Thank you, ma'am.
Okay, bye.
Let's move on to our next session. I would like to invite our chairperson, Dr. Jayasri Garg, ma'am, professor from Department of Periodontology, Institute of Dental Science, Bareilly, and Dr. Dhirendra Singh, reader, Kalinga Institute of Dental Science, Bhubaneswar. Ma'am and sir, please do chair this session, and I would like to call Dr. Swati for her presentation.
Am I audible, ma'am?
Yes, Swati, you are audible.
Okay, thank you, ma'am. A very good afternoon to the respected teachers. The topic of my presentation is effects of anti-epileptic drugs on bone mineral density and periodontal status in epileptic patients. Epilepsy is a neurological disorder that requires lifelong treatment and use of anti-epileptic drugs for long duration usually affects both bone and mineral metabolism and may leads into the risk of bone fractures. So there are mainly 2 types of anti-epileptic drugs, enzyme inducers and non-enzyme inducers. Enzyme inducers like phenytoin, carbamazepine, phenobarbital, and non-enzyme inducers like sodium valproate, levetiracetam, lamotrigine. So according to the published studies, data showed the effects of anti-epileptic drugs as decrease in bone mineral density, a low serum calcium phosphate, vitamin D, osteoprotein levels at a high soluble rank L alkaline phosphatase, and a high level of ratio of osteoprotein to the soluble rank L levels. So this is a cross-sectional study with inclusion of 24 individuals divided into 4 groups with 3 test groups of epileptic patients and 1 control group of systemically healthy individuals. Test group 1 are the individuals on the sodium valproate anti-epileptic drug. Test group 2 on levetiracetam. Test group 3 on sodium valproate and levetiracetam combination users. And control group that are systemically healthy individual or the non-users. Inclusion criteria were age range of 18 to 40 years with systemically healthy individuals in the control group, and the test group individual diagnosed with epilepsy according to the International League Against Epilepsy criteria 1981. So duration of anti-epileptic drug should be at least 1 year, which was included in the test group, while the exclusion criteria were the postmenopausal women, the individuals on vitamins and calcium supplements, individuals already on steroid and bisphosphonate therapy, diseases that affect the bone health like Paget's disease, and any history of alcohol and tobacco use. So we've measured the parameters like pedontal parameters of plaque index, gingival index, clinical attachment level, BOP score, and the pedontal pocket depth. Along with that, we measured the bone mineral density using the DEXA scan and alveolar bone levels using the radiovisuography. The results obtained with respect to the bone mineral density, we found that sodium valproate users, approximately 66%, have negative effects on bone mineral density, followed by the combination users of 33, while the levetiracetam users and non-users have no effects on the bone mineral density. Effects of the BOP score, all users have BOP scores above 10%. Sodium valproate users have highest BOP scores of 41%, followed by the levetiracetam, and then combination users, that is 32%, and then non-users have 29%. Effects on the GI score, all users have mild to moderate GI score. Combination users have approximately 83%, followed by the valproate and levetiracetam equal, that is 66%, and then non-user 50%. Effects on the alveolar bone levels, sodium valproate bone mineral. Sodium valproate users have increased alveolar bone loss, that is 66, followed by the sodium levetiracetam, and then followed by combination and non-users. So conclusion is, with limited number of data, sodium valproate may be a drug with more negative effects on bone mineral density, but further randomized trials are required to establish these facts.
Good afternoon, Jayashree ma'am.
Good afternoon. So you would like to ask?
Ma'am, you please ask, ma'am. Just a minute.
This study you had conducted, Dr. Swati?
Yes, ma'am.
Okay. What are the alternative drugs for phenytoin?
Ma'am, the phenytoin is an old anti-epileptic drugs which have a negative effect, already established facts on the soft tissues as well as on the bone mineral density. The drug we use are the new anti-epileptic drugs. That is first and second generation, that is valproate, levetiracetam, and lamotrigine.
Okay, what are the analogs of phenytoin that stimulate the proliferation of fibroblast-like cells?
Yes, ma'am. I can't hear, ma'am.
What are the analogs of phenytoin that stimulate the proliferation of fibroblast-like cells? What are the analogs of phenytoin?
Exactly, I don't know, ma'am, right now.
Dr. Shruti, can you tell me that what are the other methodologies you used for the correction, for the evaluation of the bone mineral density?
So
not
we
been
use,
clearly mentioned there.
so in our this study, we use the DEXA scan.
What is that? Can you elaborate? In just
It
20
is a
seconds?
dual energy X-ray absorptiometry.
Yeah. Hmm?
Yes, sir.
And
Can I
please tell me.
elaborate this
Yeah,
scan?
yes, just 2 minutes.
So this is a method in which there are two scores, T scores and the Z score. T scores mainly for the comparison of a person's bone density with that of a healthy 30-year-old of the same gender, while the Z score is the comparison of a person's bone density with that of an average person of same age and
Okay,
gender.
okay. Thank you so much. Thank you so much, Swati.
Thank you, Dr. Shruti. Our next presentation by Dr. Ayush Khatri.
Good afternoon, everyone. Topic for my poster is comparative evaluation of two different techniques of gingival depigmentation on healing outcome. Coming to introduction, Gingival depigmentation is a perioplastic procedure in which pigmented gingiva is aesthetically enhanced using various techniques. Gingival pigmentation is defined as the discoloration of gingiva due to extrinsic and intrinsic causes. Gingival pigmentation is a prominent, especially in the labial aspect of anterior teeth, and has become an integral component of general aesthetics of an individual nowadays. Aim to compare the efficacy and the healing outcome of two techniques, scalpel and laser, in gingival depigmentation by split mouth procedure. Now coming to material and methods, 10 patients presenting with moderate to severe gingival pigmentation according to the Damit-Gupta oral index score 2 or 3 of maxillary and mandibular anterior sections was selected. All the patient informed consent was taken and pre-hygiene therapy was done. Depigmentation was then carried out accordingly. In group 1, patient treated with scalpel after infiltrating the area with local anesthesia. Number 15 blade was used. Then in group 2, patient treated with diode laser of wavelength 800 to 980 nanometers at 2.5 watt in continuation mode. In continuation contact mode is used. Then patient were evaluated on day 0, 3, 5, 7, 10, 1 month and 3 months for the following parameters such as Damit Gupta oral pigmentation index, healing index according to Landry et al., visual analog score and Toledan blue test. And data was collected and statistically analyzed. Coming to the result, graph 1 shows that the Damit-Gupta index of both the groups, the statistically non-significant result was obtained. In in graph 2, the patient treated with laser showed the faster healing till 10 days as comparison to scalpel. Graph 3 shows visual analog scale, and where patient showed high pain till 5 days on the side treated with scalpel. Graph 4 shows Toledan blue test. There was no statistical difference. Then coming to discussion, Lagevi Day S et al. Stated that the application of diode laser appears to be safe and effective alternative procedure for the treatment of melanin pigmentation. And Karthikeyan G et al. Stated that the statistically significant results with scalpel and laser were obtained. However, the patient treated with laser demonstrated less pain. Grover HS et al. Concluded that both the procedures did not result in any post-operative complication and gingiva healed uneventfully. Coming to conclusion, gingival pigmentation is equally effective in both scalpel and laser techniques. However, laser-treated sites showed reduced pain, better operator patient comfort, faster healing, and laser is a magic wand in which there is very less or no bleeding. That is all. Thank you. Sir, I can't hear you.
Dr. Ayush, what are the parameters you checked for the healing outcome?
Sir, normal visual analog scale, Toledan blue test, and healing index.
You just did the comparison with the pictures, photographs you taken.
Yes. In Toledan blue test, we give Toledan to the patient and tell the patient to rinse after 1 minute, and then we evaluate the site.
Ma'am, please, ma'am. Just a minute.
Thank you. Ayush? Ayush, are you able to hear me?
Yes, ma'am.
So according to you,
Yes, ma'am, yes.
out of the two techniques, scalpel and laser, which is better?
Ma'am, laser is better as while doing it, there was no or less bleeding as in comparison to scalpel, and the discomfort was also less as a minimal amount of anesthesia was required in comparison to the scalpel, and post-operatively patient didn't showed any discomfort, and healing was uneventful as in cases of laser, protein coagulum is formed over
The healing, which you did, the recall of the patients, that is only for like 3 months.
Yes, ma'am. Due to lockdown, I was able to follow up the patient for 3 months only. We did the study previous
The follow-up was only for 3 months.
Yes, ma'am.
Okay.
Ma'am, the advantage over the scalpel and laser is protein coagulum is formed that helps in the healing.
Thank you, Dr. Ayush. Our next presenter is Dr. Yelotri Sarmika.
Am I audible?
Yes, Yelotri, you're audible.
My case report is on recombinant human fibroblast growth factor in observable collagen membrane in coronally advanced flap in class 1 and class 2 gingival recession defects, an randomized control trial. Coming to gingival recession is defined as an apical migration of the gingival margin where leads to the root exposure. Very many etiological factors leads to gingival recession like plaque accumulation, faulty tooth brushing, and other malposition tooth and many other. Coming to the case report, introduction, recombinant human fibroblast growth factor 2, which is an potent degenerative material, promotes hard tissue formation and exhibits an increased potential to the promote periodontal regression in recession defects. In this study, in this case report, class 1 and class 2 gingival recession are included, in which the site is prepared with full thickness mucoperiosteal flap is elevated and the de-epithelialization is done, and the surgical site is integrated with recombinant human fibroblast growth factor in the surgical site, and then the flap is advanced coronally until the root cover surface is covered and the sutures are placed. And the main in this main objective aim and objective is to preserve to cover the the aim of the present study is to clinically evaluate the regenerative potential of recombinant human fibroblast factor integrated membrane with coronary advanced flap in gingival recession defects. In this case report, the parameters which are included are recession depth, width of the keratinized gingiva, and probing depth. And the results are the recombinant human fibroblast growth factor integrated collagen membrane was effective in increasing the recession depth, width of keratinized gingiva, gingival biotype, and probing pocket depth compared to the control group, that is only the collagen membrane is placed. Coming to the conclusion, the recombinant human fibroblast growth factor integrated collagen membrane showed promising results in terms of increasing the width of keratinized gingiva and recession coverage compared to recession defects treated with observable collagen membrane. Thank you.
Yelotri, what was the randomized control trial here? Yelotri, can you hear us? Are you there? Shramika? Are you there? Scientific team, I guess she's disconnected.
Then our next presentation by Dr. Aparna Pathare.
Good morning, ma'am.
Aparna, you have to share your screen.
Yes, sir. Is my screen visible to all?
Yes.
Okay, good afternoon, sir and ma'am. Today I will be presenting a poster on the topic, the smartphone-based application for voice-activated digital periodontal case history recording. As we all know, during this ongoing COVID-19 scenario, OPD evaluation and understanding the case history increases the chances of cross-contamination by manifold. So to avoid this voice-activated digital case history recording application helps the dental practitioner with adequate safety. So the aim to design this application was to develop and evaluate the digital procedure or a digital application to assess, extract, and analyze the recorded clinical data in practice to assess the outcome of our periodontal treatment and to compare those findings with the current literature, which becomes easy with the digitalization. Now coming to the most interesting part, how we design this. This voice-activated dental application accepts and responds to the commands provided by the clinician. This application edits as well as segregates the patient-related information as per requirement. First, you will get the doctor's login screen, which is allotted to a specific doctor. Then that doctor can add his or her assistant, and her assistant will also have access to the application. After adding the patient's basic information and data, once data and basic information is fed, no need to re-record the patient while the second appointment. During the second appointment, the case history or the recordings which are we have taken will be tabulated and will be in front of us, so that we can compare the outcomes from our first appointment to second appointment. Along with that, we can voice activate the application by using the Google Assistants. Coming to the technological part, it can be run in the smartphones which are having the KitKat version and above. Also, the language used for designing was Java, and the tool was Android Studio. All our periodontal case history recording main concern area is pocket probing, depth, recession, mobility. We can just voice command this application. It will record it in our language, and then while generating the report, it will give us it in a tabulated form. So the date and time-wise organization of the data will be there, and the improvement can be compared in the final result. Also, this application would add to the patient's motivation and the education. Coming to the added conclusion and the results, this application can significantly reduce the surface contamination to some extent. The development of coding and software technology has improved the screening prediction and reduces the human intervention in medical practice. This application is time saving. It is user friendly, which can be used by anyone, the clinician or the assistant if you allot. Then it is eco-friendly and reduces the cross-contamination by avoiding surface contact as compared to the conventional case history recording methods. Also, the aerosols or droplets which are generated during the ultrasonic scaling, which are very minute in size, like 0.3 mm to 100 micrometer, they can contaminate the paper form of our case history recording, which paper we pass to the one another, and that could contaminate the whole environment. This scenario can be avoided. Okay.
Jayashree ma'am.
Yes, sir. Aparna?
Yes, ma'am. Good afternoon, ma'am.
This application was designed by you?
Yes, ma'am. With the help of software developer, I'm working on it. Whatever other requirements related to our faculty, we just inform them, and then they convert into the way that we want it to present it in application.
So you have actually done it?
Yes, ma'am. It is under construction, and the voice thing is the new thing. The voice activated command by Google Assistant is the newest thing that we incorporated in it, and it is under the running process and will be available on Play Store. If anyone all over India can have access to
It is still under the process.
Sorry, sir.
It's still under the process of making.
Yes, sir. Yes, sir.
Okay. Okay, then we cannot ask many, because if you want to know that what will the errors, and yes, ma'am. So if it is still in the process, okay, then we'll wait for it.
Yes.
Do share to ISP also, so that we'll use it in our clinics, and we'll see that what are the errors coming. Thank you.
Thank you, Dr. Aparna. Our next presentation by Dr. Neha Kumtekar.
Hello. My screen is visible?
Yes, Neha, it is visible.
My poster's topic is comparative evaluation of effects of subgingival application of ozonated olive oil versus chlorhexidine in the patients with chronic periodontitis, a clinical microbiological study. The methodology is in the split mouth design, 32 untreated chronic periodontitis patients who met the criteria of having periodontal pocket with the depth of greater than 5 mm and bleeding on probing in at least 2 different quadrants were included. Group 1. The second test group includes ozonated olive oil application with SRP. Clinical parameters were evaluated at baseline, 7 days, 14 days, and 21 days post-treatment, and plaque samples at baseline and 21 days. Microbiological analysis was done to assess the change in the level of P. gingivalis. Inclusion criteria is periodontal pockets with depth greater than 5 mm and no evidence of clinical attachment loss, willing to participate in the study, and no history of systemic diseases, non-smokers, and the 6 at least 20 natural teeth are present. Exclusion criteria are pregnancy, systemic antibiotic administration within an antibiotic within the 3 months prior to the treatment. Then I have used the ozonated olive oil, which is commercially available. It is Dentozone India and pardon, ma'am.
Yeah, continue.
Yes, and the chlorhexidine commercially available gel I have used. Both the ozonated olive oil and the chlorhexidine gel is applied subgingivally after SRP with the blunt tipped sterile plastic syringes. Then at the baseline and after the 21 days, the subgingival plaque samples were taken, were kept into the transport medium. It is RTF. Then for the particularly P. gingivalis, the enriched medium and selective medium we have used, that is kanamycin blood agar. It is nothing but the enriched medium blood agar, which is and kanamycin is incorporated into it. Then in the statistical analysis, both group test and control group showed the improvement in all the recorded parameters, that is probing depth, gingival index, and microbiological analysis. Then in my conclusion, subgingival irrigation with the ozonated oil can be effective used as an adjunct to the SRP in non-surgical management of the chronic periodontitis. And reference for my poster is Khare et al. That is the evaluation of the ozonated olive oil versus chlorhexidine in the Journal of Dental Specialties in 2019. Thank you. Okay, Dr. Neha. Yes, ma'am.
I would like to ask that it is a comparative study. So, which out of it, which one you found it better?
Ma'am, in my study, chlorhexidine as a gold standard and ozonated gel also. In the intergroup comparison, both the gels are equally effective.
How was the microbiological analysis done? Like you have not told in detail about it. How was the microbiological analysis done? You said you evaluated P. gingivalis. How did you perform it?
In my study, after SRP, supragingival as well as subgingival plaque are collected with the Hugh-Freddy's scalars. After that, it is transported through the RTF medium. After that, it is inoculated into the plates having the kanamycin anaerobic selective medium. And at the 37 degrees centigrade for 3 to 4 days. After that, we have checked for the P. gingivalis colonies.
Okay.
Dr. Neha, how you controlled the delivery? How you control that this much amount of the ozonated olive oil and this much amount of chlorhexidine should be delivered at the site? How you control the delivery? And
Sir,
how you maintain that this much dose of this much quantity of that olive oil and this much quantity of the clozapine should be there in the pocket for a certain period of time? How you control it?
Sir, syringes are having the uh, uh, graduated syringes were there to mark the particular solution. I mean, particular gel subgingivally.
Thank you so much.
One thing
Thank
more
you,
I
sir.
would
Thank
like
you.
to say to Dr. Neha, your poster,
Yes,
the color of it, like whatever you had put, it was like everything was next time whenever you present your poster, make it the color and everything was not that much of appropriate. So like it would be better if you use different the presentation should be a little much better of the poster. You can make it a bit better.
Okay, ma'am. Okay, ma'am.
Thank you, Dr.
Thank you.
Neha. Thank you,
Yes,
Dr. Neha. Our next presenter, Dr. Manisha Bihar.
Ma'am, am I audible?
Yes, Manisha.
Good morning, everyone. Today, my name is Monisha Vier. I'm going to present my poster on the topic assessment of gingival phenotypes and the relationship with regard to age, gender, and arch location. Coming to the introduction, the attached gingiva is one of the most important anatomic and functional landmark in the periodontium. Assessment of gingival topography plays a vital role in the periodontal diagnosis and treatment planning. Therefore, it is important to understand the variation of gingival phenotypes with regard to age, gender, and arch location. Coming to the measurement, the width of attached gingiva, it is a portion of gingiva extending from the base of the crevice to the mucogingival junction. Coming to gingival biotype, it is measured using a K file. Coming to my objectives, to evaluate the variation in gingival biotype with respect to age, gender, and arch location. Arch location in anterior teeth using K file, and to evaluate the variation in width of attached gingiva with respect to age, gender, and dental arch location in anterior teeth using measurement approach. Coming to the methodology, the study sample comprises of 50 participants, of which 26 males and 24 female patients, which is divided into two groups. Group A consists of 23 participants of age 19 to 35 years, and Group B consists of 25 participants of age 36 to 55 years, and each group comprised of 13 males and 12 females, and gingival biotype and width of attached gingiva are compared and evaluated between males and females, maxillary and mandibular arch, and different age groups. Coming to the results, in my results, they have seen that the female patients female maxillary arch had a greater width of attached gingiva than the male maxillary attached gingiva, and there was a maxillary when it was combined. Maxillary arch had a greater width of attached gingiva than mandibular. And coming to the mean width of gingival thickness, it was seen more in case of male compared to females, and it was seen more in case of maxilla. Coming to the mean width of attached gingiva, it was seen more in case of different age groups. It was seen in group A, it was more compared to group B, and it was seen more in case of maxilla than mandible. Coming to the mean width of gingival thickness, it was seen more in case of group A, and it was seen more in case of maxilla. Coming to discussion, it was observed that the gingival thickness and width of attached gingiva was significantly decreased with age in both arches, and the maxillary arch had a thicker gingiva than the mandibular arch, and the width of attached gingiva was higher in females, and the gingival biotype was higher in males than the females. And coming to the limitation, but the buccolingual tooth position was not taken into consideration, and the size and shape of the tooth was not taken into consideration, as this also might affect the gingival phenotype variation. And this was shortest study population it was done, and also the genetic factors and the racial factors that also plays in a role for gingival phenotype variations. Coming to the conclusion, in the present study, I have concluded that the width of attached gingiva and gingival biotype varies with regard to age, gender, and dental arch location. Thank you.
Doctor, what is the implementation of this study?
Sir?
What is the implementation of this study? You have designed this study. What is the implementation? How this study is going to help you or help us?
Sir, the gingival biotype and width of attached gingiva, it's very essential, sir. When we do the mucogingival procedures, it's very important us to know what is the normal, sir, so that we can it will help us for further diagnosis and treatment planning, sir. When there is very less width of attached gingiva and gingival biotype, it will be more prone for recession, sir. So this is very important to know as what is a variation, sir.
Ma'am.
Dr. Monisha?
Ma'am?
How would you, what are the criteria to classify the gingiva under thick and thin biotype?
Ma'am, according to this Oskin-Base and Rose, I have taken into thick the gingival biotype and thin gingival biotype, ma'am. I have used I have used K file, ma'am, to measure the gingival thickness, ma'am. 3 mm apical to gingival margin, I have measured the gingival biotype, ma'am.
I think some voice problem is there. Okay.
Ma'am.
Thank you, Dr. Monisa. Let's move on to our next presentation by Dr. Neha Garg.
Ma'am, is the screen visible?
Yes,
Hello?
Monisa, it is visible.
Okay. Good afternoon, everyone. Today's title of my poster is Management of Grade 2 Furcation Defect with Intramarrow Penetration along DFDBA and Amniotic Membrane prepared as Central Tissue Bank mates, a pilot study. The aim of my study was to compare the clinical outcome of Grade 2 Furcation Defect with and without DFDBA and Amniotic Membrane prepared at Central Tissue Bank mates. The inclusion criteria are adult patients in either sex in the age group of 18 to 55 years were included. Molars with a grade 2 furcation defect, vertical proving depth more than 5 mm and a horizontal proving depth more than 3 mm after phase 1 therapy. And RBG showing radiolucency in the furcation area. Materials, coming to the materials and method, it was a prospective clinical study and randomization was done according to a flip coin method. And there were 2 groups, a test group and a control group. After the subjects which met the inclusion criteria were included in the study and they were allocated in the groups. In the test group, we did oral open flap debridement and then IMP, intramarrow penetration, and then we placed the graft followed by amniotic membrane. And in the control group, we only did the open flap debridement and IMP and then sutured the defect. And as shown in this picture, it is a case presenting a preoperative vertical proving depth of 7 mm and a horizontal proving depth of 3 mm, and radiolucency can be seen in the furcation area. After that, in the operative phase, we have placed the graft and then followed by amniotic membrane. And then after 6 months, the patient were recalled and the post-operative vertical depth can be seen to be reduced to 4 mm and a horizontal proving depth has been reduced to 3 mm. And also we can see there is a radiopacity in the furcation area suggesting there might be a bone formation. There is bone formation in the area. The results. For all the tables, intragroup p-value was computed using pair t-test, and in the intergroup difference, it was computed using the unpaired t-test. There was a decrease in vertical and the horizontal proving depth from baseline to 6 months in both the test and the control group, although they were found to be statistically non-significant. There was also increase in the increase in clinical attachment gain in both the test group and the control group. And in both the treatment modalities show bone fill compared to the baseline values, and intergroup comparison between test and the control group were also found to be statistically significant. And there was an increase in the position of the gingival margin from baseline to 6 months in both test and the control group, but they were also found to be statistically non-significant. The results in the present study are in accordance with the study done by Charles R. Andrick et al. 1991 and Wallace SC 1994. And the bone fill can be attributed to the osteoinductive and the osteoconductive potential of the graft. Conclusion, the treatment of class 2 furcation defects with regenerative technique using indigenously prepared DFTB and air-dried amniotic membrane resulted in significant improvement in the clinical parameters evaluated. However, long-term multicentric randomized controlled clinical trials with larger sample size should be carried out to affirm the observation of this study. Thank you.
Dr. Neha?
Yes, ma'am.
The study was carried out by you?
Yes, ma'am.
Okay. You did?
Yes, ma'am. I did all the cases.
Okay. How much was the sample size?
Ma'am, sample size in the study was only 6, 3 control and the 3 control and 3 test sites.
Okay.
6 sample size.
And Neha, good effort. Good effort you're doing. And what can you tell us? What are the other treatment modalities for the management of the grade 2 furcation involvement?
So we can do osteoplasty. If there are white furcation defect, we can do furcation plasty also. And if it is not cleansable, then we can do through and through. We can make the furcation defect through and through so that patient is able to clean that defect. And mostly we want in period ultimate goal is regeneration. So we are trying to do regenerative techniques mostly.
As you have done the pilot study, have how much the follow-up? How much follow-up you have kept here?
So 6 months. I have kept 6 months. Regular follow-up was there for 3 months, then 6 months, so that we do the cleaning and all, and maintain patients' oral hygiene.
Okay, thank you so much.
Thank you. So.
Thank you, Dr. Neha. Our next presentation by Dr. Tanmaya Sri Nilam and Dr. Rohit Gampala.
Am I audible, ma'am?
Yes, Tanmaya, you are audible.
Okay. Good afternoon, everyone. I, Dr. Tanmaya, is going to present a poster titled Efficacy of RHBMP2 in Socket Preservation, a report on the initial results. Post-extraction, the bone loss occurs rapidly in the initial 6 months as the alveolar process loses its supportive function. As a consequence, it is progressively resorbed. Therefore, socket augmentation using biomaterials is readily suggested after tooth extractions to preserve or augment bone volume and height. One method of preserving the socket is with the use of biologic agents to accelerate the rate of regeneration. One such agent is recombinant human bone morphogenic protein 2, abbreviated as RHBMP2. Hence, the objective of this case report is to evaluate the regenerative potential of RHBMP2 in socket preservation. The case presentation. A socket preservation procedure was done using RHBMP2 gel along with the alloplast on subjects requiring extraction and consenting for socket augmentation using this technique. Atraumatic extraction along with degranulation was done under local anesthesia. The bone graft and RHBMP2 gel were placed in the extraction socket and were stabilized by placement of a membrane, and sutures were done to obtain primary closure. Radiographic images were obtained pre-operatively and 6 months post-operatively for bone density measurement. At the end of 6 months, there was significant increase in bone density in all the cases. Coming to discussion, bone morphogenic proteins belong to transforming growth factor B superfamily, and they are osteoinductive. They can stimulate angiogenesis, proliferation, and differentiation, and migration of stem cells from surrounding tissues into the area of injury. When added to socket preservation procedures, they have been shown to not only improve the quality of the bone graft, but also to accelerate the healing process. Radiographic images at the end of 6 months show a greater proportion of mineralized bone, suggesting a higher bone density, and it can be inferred that the graft underwent regeneration and new bone formation and maturation. With the limitations of this study, conducted over a period of 6 months, it can be concluded that the unique properties of RHBMP2 gel makes it a potential agent to be used as a graft material for socket preservation. Thank you.
Tanmaya, what is the need of doing socket preservation? Why you want to do the socket preservation?
Sir, after a tooth extraction, the bone loss occurs rapidly in the initial first 6 months, and the height of the alveolar ridge also gets reduced, and all the center of rotation of the alveolar ridge, it progresses lingually, and it becomes difficult for placement of implant.
So here you decided to do implant in this case?
No, sir. And all the patients were not motivated. I mean, they were not ready for it, sir. we have till now we have done on 4 patients, but implant was not done on any other patients, sir.
Just a minute.
How much was the follow-up time?
6 months, ma'am.
And 4 patients you did?
Yes,
You
ma'am.
did?
No, ma'am. My senior did, ma'am. I'm a first year postgraduate. My senior did it, ma'am.
Okay. Thank you.
Thank you, Dr. Tanmaya. Let's go into our last presentation, by Dr. Prafulla Bharti.
Good afternoon, judges. I'm Prafulla, and I'm presenting my poster, and my topic is clinical and radiographic evaluation of 3 manual periodontal probes in patient with periodontal disease. And in our study, we used 2 first-generation probes that were CPITM and Williams probe, and another one was the second-generation pressure-sensitive probe. And we did it on 26 patients, and the follow-up time was baseline, 6 weeks and 12 weeks. And what we found out, we took basically the parameters which we took were the sulcus bleeding index, pocket probing depth, and the clinical attachment loss, which we analyzed clinically as well as radiographically. And radiographically, we did it through RVG. And along with that, we placed a occlusal stent with a metal ball for the standardization. And what we found out in our study was that there was significant increase in the pocket depth and clinical attachment loss with the SRP after 6 and 12 weeks, and changes in the radiographic and clinical attachment level, they progress concurrently over a short period of time. But since radiographic changes are not easily seen for on a short basis, so a long-term studies with a larger sample size are needed, and probing depth was deeper at the interproximal sites as compared to the mid-buccal and mid-lingual sites. And pressure sensitive probe, it is the pressure sensitive probe, it yielded a least pain perception when we checked it. Actually, we also took the visual analog scale, and what we found out, out of all the 3 probes, the pressure sensitive probe, it yielded the least pain perception from all the 3 probes, as this probe, it maintains the consistency of probing force of 15 grams between the clinician and the operator when the force is applied, and the shank moves to the mark to match the mark when the force is maximum and it reaches 15 grams. And what we concluded in our study, that within the limitations, changes in the clinical and radiographic attachment level, it progresses concurrently over a short period of time. But since radiographic changes are not evident over short period, so long-term studies with larger samples are required. And the pressure of all the probes, it must be standardized to have a better comparison within the probes. So the demand for standardizing probing pressure and choosing the same probing force in periodontal tissue, it remains questionable in the first generation probe. Thank you so much.
Prafulla?
Yes, sir.
What exactly what you wanted to evaluate in probes?
Sir, actually, we wanted to evaluate the 3 probes. Basically, we did a comparison between the 3 probes, like which probe will be better when we are, because we used all
Because
the
your title itself is incomplete.
So actually, what we did was we clinically and radiographically we evaluated all the parameters using these probes, and what we found out was that when we took different parameters, so we found out that when pain perception was done, it was found out that the patient gave a good response towards the second generation probe, because he felt the least pain with the pressure sensitive probe.
Ma'am?
Dr. Prafulla, your poster, like if suppose anyone wants to read it, it's not at all like the font size, the whatever, it is not clear at all. I don't know why, but like I wanted to read it also, few things out of it, but nothing is like, everything is very blurred.
Really sorry, ma'am. Actually, when I converted it to JPG file, the clarity was lost. So really sorry for that. I'll try to make it more clear for the next time.
Yeah, make it sure that whenever you present, at least whoever the person is seeing your poster is able to read it at least.
Yes, ma'am.
Or
Yes.
see whatever it is.
You all could use a PDF also. You can transfer to PDF, or you could use to PNG also. PNG is more visible, having more
Yes, sir,
density.
but actually it was mentioned there that you have to upload it in a JPG, so that's why we did it. So
Okay.
we'll try to make it more clear for the next time.
Okay, no issue. Thank you.
Thank you, Dr. Prafulla. With this, we end our session.
Scientific team, Dr. Vashanta, she did the presentation.
Yes, I also wanted to ask the same thing.
Sir, he will not come. Actually, he is absent. He is also not picking our call.
तो चलो छोड़ दो उसको.
We don't have to evaluate him then.
No need to. Yes, sir. Yes, sir.
Thank you, ma'am.
Thank you, ma'am, and thank you, sir, for taking out your valuable time and being a part of this first virtual PG convention. Sir and ma'am, a sincere request, please do submit your evaluation sheet to the mentioned email and WhatsApp number. Yes, thank you, ma'am.
Thank you so much. Thank you so much.
Thank you, sir.
Good afternoon, everyone. Good afternoon, everyone.
Good afternoon, sir.
Okay, we can now begin with our fifth session. I may introduce the chairperson of this session, Dr. Rasmita Naik, ma'am. She is Professor, Institute of Dental Science, Bhubaneswar, Odisha. Along with her is Dr. Vinita Gupta. She is Professor and Head from Government Dental College, Raipur, Chhattisgarh. This is a poster presentation session, ma'am. I would like to call the first presenter, Dr. Mali Chetla Sindhu.
Okay.
Yes, you can speak up a little more. Your volume is very down.
Am I audible, ma'am?
Yes, you can go on.
Yes, you're audible.
Hello, good afternoon, everyone.
Yeah.
Today I'm going to present poster regarding the evaluation of API gel iontophoresis and 980 nanometer diode laser with a graphite paste in management of dental hypersensitivity. It is a split mouth clinical trial. Coming to the aim of the study, to compare the effectiveness of iontophoresis with APF gel and diode laser coupled with graphite paste in the reduction of dentinal hypersensitivity. Coming to the introduction, as we all know, dentinal hypersensitivity is a common challenge faced by every clinician. Iontophoresis is a popular technique where concentrated application of the drugs into the desired localized region blocks the exposed dentin, and the diode laser with the 980 nanometers along with the graphite paste results in the morphological changes of the dentin surface, creating a melted, resolidified surface, thereby reducing the dentinal hypersensitivity. Coming to the materials and method, a totally 15 subjects with 30 sites, that is contralateral, maxillary and mandibular arches, were selected. With a chief complaint of sensitivity were included in the study, and the figure 1 represents the sensitive teeth that should be isolated and dried, and the sensitivity was performed by the tactile test by using the explorer or a probe, and the sensitivity was assessed by the tactile test, and it is measured in the visual analog scale, and ask the patient to mark on the visual analog scale that consists of markings from 0 to 10, where the 0 indicates the no pain and the 10 indicates the extreme pain, and the figure 2 represents the iontophoresis unit with impression trace, APF gel and the sponge, and the figure 3 representing the iontophoresis treatment relating to the mandibular arch. First, the sponge is filled with a thin layer of APF gel, and this sponge is placed on the impression tray, and it is kept in contact with the teeth, and the metal electrode with the red spiral is held on the patient hand, and the black spiral is kept on the rectangular slot which is present on the impression tray. Then the resistance knob is turned clockwise direction by increasing the electric current from 0.5 to 2.5 milliamperes, and the current should be applied for 2 minutes. Then the treatment should be stopped, and repeat the tactile test to evaluate the response from the patient. And the figure 4 shows the diode laser irradiation after the application of the graphite paste. Coming to the results in both groups, that is iontophoresis and the diode laser group, shows the significant reduction in the dentinal hypersensitivity from the baseline to the immediately post-operative 2 weeks and the 6 months. But the diet laser with a graphite paste shows significant reduction in reducing the sensitivity after post-operative immediately and after follow-on periods. Coming to the discussion, several hypotheses have been proposed by which iontophoresis produce desensitization of the dentin. The mechanism produced by the Lefkowitz states that the application of the current to the dentin leads to the formation of reparative dentin, which results in the dentin tracts in the primary dentin. Diet laser is a soft tissue laser with a wavelength ranging from 655 to 980 nanometers, and the application of the graphite paste enhance the absorption of the beam on the dentin surface will also provoke an important increase of temperature localized at the dentinal surface to close the dentinal tubules through a melting effect. Coming to the conclusion, diet laser with a graphite paste shows a significant reduction in the dentinal hypersensitivity after 6 months.
Dr. Malichetla.
Thank you, ma'am.
Okay, just tell me one thing. Why did you choose graphite? Why did you choose graphite?
Hello?
Hello, am I audible?
Hello?
Am I audible?
Yes, ma'am, you are audible. I think there is some problem from Dr. Malichetla's side.
Okay. Oh, Dr. Vinita, you can ask. I think she can hear you.
Hello, am I audible?
Hello, madam. Yes, ma'am.
Why did you choose graphite? It is from Dr. Rashmita Nayak.
Madam, this graphite paste is a very dark pigment, madam, so that when we use with the diode laser, it can absorb. Diode laser work more effectively in the darker pigment. So we have used a graphite paste, madam.
Is it a first kind of study?
Madam.
Okay. Okay.
What about
over to you? Yeah, over to you, Vinta, ma'am.
What about the recurrence of the sensitivity? Am I audible, Vita?
No, ma'am.
How can you say the laser is more effective? What about the recurrence?
Ma'am?
So it's all right. We can take the next participant. The audio is, there's some problem with the audio with her.
Thank you so much, Dr. Malichetla. Now we can move on to our next presenter, Dr. Lipsa Surovit.
Am I audible?
Yes, you are audible. You can carry on.
Good afternoon, everyone. Today I'm going to present a poster on evaluation of antioxidant activity of coenzyme Q10 as an agent to non-surgical therapy. Coenzyme Q10, that is, it serves as an endogenous antioxidant, but advent to periodontal disease, gingiva shows a deficiency of coenzyme Q10. So the use of antioxidant therapy by the use of coenzyme gel, that is a PerioQ gel, which is a mixture of coenzyme and vegetable glycerin base at a ratio of 1:9, could counteract this periodontal disruption. So the aim of the study was to test the efficacy of coenzyme Q10 in the form of gel in patients with chronic periodontitis patient. Our objective was to test the efficacy of the coenzyme gel in control, that is SRP alone, and the test group, that is SRP plus PerioQ gel, and was to compare the clinical parameters of both the groups, that is control and the test groups. So now, coming on towards the methodology, here this study was performed in 30 chronic periodontitis patients. This is a split mouth design where two contralateral quadrant having two sides for each quadrant were having 5 to 8 mm of pocket depth were selected for the study. After that, all the clinical parameters like plaque index, gingival index, modified sulcus, bleeding index, and pocket probing depth were recorded in the patients at the selected sites. Then after that, the patients were grouped into group A, that is SRP plus PerioQ gel application, and group B, that is SRP alone. After that, the group A were applied with PerioQ gel with a applicator for the first 3 alternative days. Then both the group were asked for follow-up for second week and fourth week for the clinical parameter assessment. Now coming on towards the result, our result has shown that when we compare the intra-group comparison within the group we are comparing from baseline to fourth week of both the side, it showed a significant result in both the group A also, in group B also. But when we are comparing the intergroup comparison has been done, it doesn't show any significant result. It showed a similar result. And this result was in accordance to a study by Hens et al., who reported that the subgingival mechanical debridement only and along with coenzyme Q10 showed a similar result, and it doesn't provide any significant difference. So here we can conclude in our study within the limitation that the study confirmed the primary role of mechanical approach for the periodontal therapy, and it did not provide enough clinical support for the superiority of the adjunctive use of this perio-Q gel along with this SRP. Thank you.
This perio-Q is in like it's gel form or like it's in which form?
Ma'am, it is in gel form. I have used it in gel form, and I have done with a topical application with the help of an applicator.
Is it available in the market? Like how did you get?
Yes, ma'am. I have ordered it from India Mart. I have ordered from outside, from international. They have a contact from outside. They have then transported to the India. Then after that, I have used.
How much it is costing?
Ma'am, it is 1200 for 4 bottles. I have got.
Okay, thank you. Over to Dr. Vinita.
Can you detail the mechanism of action?
Yes, ma'am. In periodontitis, ma'am, in periodontitis and coenzyme Q10 relation. Yes, ma'am. Yes, ma'am. The main causative organism in the periodontitis and gingivitis is that the anaerobic bacteria and the facultative anaerobes. So when these are present, our host defense system comes into work. And we know that neutrophil is the first line of defense. And this neutrophil, what does they do? They show this phagocytosis effect in oxidative killing mechanism and non-oxidative. This oxidative killing mechanism, what does they do? They produce ROS. And this ROS has the ability to initiate the free radical formation, and this free radical does it damage the tissues. What does this antioxidant property of this coenzyme do?
Okay.
They marks. Yes, ma'am.
You have designed this study. This has already been done in 2008, I guess, 2007, and
yes,
before that also.
Yes, ma'am.
What is new in your study?
Ma'am, here the topical applications here and
topical application. It was a pocket therapy that had been done.
Yes, ma'am. Yes, ma'am. Pocket depth.
What is new in your study? It's all.
Thank you.
We can take the next participant.
Okay, thank you,
Thank
Dr.
you,
Lipsen.
Thank you. Thank you.
Our next participant is Dr. Udbhavana. Dr. Udbhavana, are you there?
I think we'll continue with the next participant.
Yes, ma'am.
Yeah.
We can move on to the next presenter by Dr. Aarti.
Udbhavana, I can see her. Asit, I can see it.
Yes, ma'am.
Hello. Am I audible now?
Tech team, we can go now for Dr. Udbhavana's presentation. Okay, thank you. Yes,
sorry.
Udbhavana, doctor, you can start now.
Yes, sir. Good
Afternoon, ma'am. The topic for my case report is pouch and tunnel technique with PRF membrane for managing multiple gingival recession defect. Periodontal defects that surpass the mucogingival junction has proven to be a major concern for both clinicians and patients alike. The gingival recession is defined as displacement of the gingival margin apical to the CEJ. The recession may be caused by periodontal disease, improper tooth brushing, frenal pull, etc. And a wide variety of periodontal plastic procedures have been performed to correct and eliminate the recession defects. For the treatment of multiple adjacent recession, Ellen was the first who suggested the technique of envelope technique. So now in our study we have used, however, the pouch and tunnel technique with PRF membrane, and platelet-rich fibrin, as we know, is a modification of PRP with large quantity of platelets, leukocytes, cytokines, growth factors, etc. So, a 25-year-old male reported to the Department of Periodontology with Miller's class 2 with respect to 4.1 and class 1 with respect to 3.1. Upon clinical examination, it was found that there was inflammation in the marginal and interdental papilla of the lower incisors, and for case management, preliminarily we did scaling and root planing and gave instructions to the patient for proper brushing technique and home care maintenance. So after the inflammation resolved, we went on with the further procedure. For the surgical procedure, there was administration of local anesthesia and sulcular incisions were given through each recession area with a number 15 blade. Care was taken not to extend the incision up to the interdental papilla. The full thickness mucoperiosteal flap was reflected beyond the mucogingival junction, and the tension on the flap was reduced to facilitate coronal displacement following placement of the PRF. Each pedicle adjacent to the recession was undermined gently without detaching it completely to prepare a tunnel. Then the tunnel was extended laterally by about 3 to 5 mm. The PRF was prepared according to Chopron et al. 2001 protocol. The 10 ml of blood was obtained from the patient by venipuncture of the antecubital vein in a sterile glass tube without anticoagulant. The blood was quickly collected and it was centrifuged at 3000 rpm for 12 minutes at room temperature. So the pre-suturing for the PRF membrane placement, the pre-suturing was done and there was placement of the PRF membrane into the tunnel from the sulcus. It was positioned over the recession coronal to the CEJ. The independent sling sutures were taken.
Hands up, ma'am.
And flap was stabilized without tension and periodontal dressing was given. And the patients were also...
Dr. Kalita, your time's up.
Yes, Udbhavna, I couldn't see any improvement in the follow-up in 3 months. It is, I mean, the recession is the same, what I could see in the pre-operative. And also you have not shown in the probe, like if there's any improvement. I couldn't see anything.
Good aesthetic results that were seen with due to the pouch and tunnel procedure that we carried out.
No, what I'm asking is I couldn't see any improvement in the follow-up period. I mean, there is no improvement in the recession.
Maybe the photographs are not clear.
And also you have not shown with the help of the probe how much is the improvement, like how you have shown in the pre-operative period. Okay, and that image is also very much elongated. Maybe for that reason, it is not appreciated.
Yes.
Okay, so please do focus on the quality of image next time. All right. Over to Dr. Binita.
The presentation, I guess, it's not very clear. I'm very much convinced with Dr. Rashmita. And have you done the case or someone else has done it?
Me along with my partner, we did it.
You are in third year?
Ma'am, no, second year.
How do you prepare the PRF? Which machine? What do you use? Which machine do you use in your department for preparation of PRF?
Ma'am, we do it in the advanced research lab.
Okay. How much time interval what is the critical time interval when you use it? The membrane and the surgical placement?
Ma'am, the centrifugation is done for 12 minutes at 3000 RPM.
No, the time limit, what is the time limit? We have to use it, the membrane is ready. During the surgical procedure, what time lapse you have to take into consideration?
Ma'am, I didn't understand.
You're getting it made from some other lab, yes?
Yes, ma'am.
So what is the time interval that you're using it for the surgery? How do you get it?
Ma'am, it is in our college itself, ma'am, in the lab, advanced research lab. So we get it from the advanced research lab.
So next part.
Thank you, Dr. Kalita. We can now move on to our next presentation by Dr. Arati.
Good afternoon, ma'am. Good afternoon, ma'am. I'm going to do, actually, it's initially submitted as a case report. This is gingivectomy, which is the oldest surgical approach in periodontal therapy, where a portion of gingiva is surgically removed. By historical point of view, we can note that by 1951, Goldman is the one who employed the procedure that is done today. Instrument point of view, we can appreciate Perry Fauchard in the 18th century. We have Pickerel in the 20th century, and Zentler, who introduced the scallop incision, which is clean, fine margin. Marginal cut is done, where healing is very much appreciated afterwards. Then we have a brief discussion about the patient. This is a patient who's a 29-year-old patient hailing from rural parts of Rajasthan, coming with a chief complaint of bleeding gums since 30 days. She had poor oral hygiene. She brushes around like 3 times or 4 times, and she's not educated. And then on examination, we can appreciate gingival enlargement, which has been seen. And when we asked about the enlargement, she said that it is more than the bleeding time. Like she had the bleeding about in 30 days, but before the 2 or 3 months prior, she already had this enlargement, but she did not bother about it. But after that, we tried to convince her. She was a historical patient who did not want to do surgery at all. But at first, we convinced her by doing scaling, which is a phase 1 therapy. After phase 1 therapy, she was less reluctant to do the surgery. She came after 7 days, and then we had to we had to proceed by giving anesthesia. Then we had to do pocket marking. After doing pocket marking with the Kaplan pocket marker, then after that we used the surgical technique, where we used the Bart Parker blade and Bart Parker handle of 3 number, and we use as 15 blade. And then after that we excise the tissue in the external bevel incision, where we do it in the coronal direction. Then we can appreciate the excised tissue afterwards. And after that, we can see that the operating site has a little bit of work to do. So we did irrigation and a little bit of curettage. And then after that, after fully irrigating, we did the perio packing. Before perio packing, we did a slight frenal relief in case patient doesn't have any other problem in the future, because she comes from a rural area. She don't want to come again and again. And after that, we did the perio packing. Then after that, we send her home with post-operative instructions, and the medication was given to relieve her pain and to cope up with her healing. Then after that, we can appreciate the healing after a week, where she was very happy that her bleeding has stopped, because previously she had this bleeding problem in which food even when she's
What do you think is the positive factor for this enlargement? Have you treated the patient completely?
Yes, ma'am.
What was the positive factor for this enlargement?
Plaque induced, ma'am. The patient, yes, ma'am. The patient.
What kind of bite does she have?
Yes, ma'am.
What
The
kind of occlusion does she have?
She has class 3, I guess, ma'am.
Why is it only related to the anteriors, lower anteriors?
Because she was having a mouth breathing problem also, ma'am. A slight opening of the mouth when she when she sleep. Yes, ma'am. And apart from that, a local irritation from the plaque and calculus, ma'am.
No. She has a traumatic deep bite. And you have missed that. You should have gone for an occlusion correction first so that the trauma is relieved, and then you have to go for a gingivectomy. Otherwise, there's no point. Have you done that?
Actually, ma'am, patient is not willing to do any treatment. Even scaling was not even.
Like you have to convince the patient. The patient doesn't know. You have gone for a surgical removal of that. How can the patient not be convinced? With your
Yes, ma'am. Yes, ma'am. Because we thought that if bleeding stopped and she's happy with the result which she wanted, then she might come back, ma'am.
You should convince her, I say.
Yes, ma'am.
Ma'am, you can take over.
Yeah, I completely agree with Dr. Vinita. Like you have done also the vestibuloplasty or only gingivectomy?
A slight frenectomy with a little bit of vestibuloplasty, but not deep, ma'am.
Like why haven't you showed that IOP? At least you could have seen the bone, right? There's
Yes,
no
ma'am.
IOPA. Only you did something clinical, and as ma'am said, you could have first you could have gone for the occlusal correction. You know, you now did loss instead of helping the patient.
Yes, ma'am.
Anyways, okay. Thank you.
Thank you, ma'am.
Okay, thank you, Dr. Aarti. We can now move on to our next presentation by Dr. Chinu Varghese.
Ma'am, am I audible?
Yes, you are audible. You can carry on.
Thank you. Good afternoon, jury members. My topic of poster presentation is on pre-procedural rinsing for reducing viral bacterial count during ultrasonic scaling procedure, a clinical microbiological study. Starting with the introduction, the use of water as an ultrasonic coolant during debridement procedures increases the chances of aerosol production, the risk of cross-contamination, and also the chances of transient bacteremia. Using a pre-procedural rinsing with an antimicrobial agent prior to the dental procedure is easy, economical, and safe method to produce a reduction in overall bacterial load during dental treatment. So our aim was to evaluate and compare the efficacy of the pre-procedural mouth rinses, that is neem, trifla, chlorhexidine digluconate in reducing microbial content of aerosol product during ultrasonic scaling procedures by viable bacterial count. 5 patients was assigned in each group: Group A, neem; Group B, trifla; Group C, chlorhexidine; Group G, control group, which included water. So patients with chronic periodontitis with the age range of 25 to 55 years were included in this study who are systemically healthy. And the patients who had at least 20 permanent teeth. And the patients who had excluded from the study was the patients who had systemic diseases, who had taken antibiotics and oral prophylaxis since past 9 to 11 weeks, and the smokers, the lactating mothers, and the pregnant women were excluded from the study. And this study was done in collaboration with pharmacology department, Ayurveda department, and microbiology department. So preparation of herbal mouthwash of neem and trifla was done in the Ayurveda and the pharmacology department. The neem powder and the trifla powder was obtained from the Ayurveda department, and then the further procedures was done in the pharmacology department. Then the obtained lab formulated mouth rinse, that is, it was labeled as neem and trifla. And before starting off with the clinical procedure, the patients were asked to rinse their mouth with 10 ml of mouthwash for 30 seconds. And then the plate positioning was done at specified sites, that is at chest, tray, and spittoon, and taking patient's mouth as the reference point. So distance from the reference point to chest were 12 inches, and from the reference point to tray was 25 inches, and from the reference point to spittoon were 30 inches. Then the scaling and root cleaning procedure was done for 10 minutes, and then the aerosols which were collected were sent immediately to the microbiological department for the further investigations. The plates were placed in an incubator at 37 degrees Celsius and for 24 hours. And then the obtained results were, it showed that when rinsed with 10 ml of neem mouthwash, it was more potent in reducing the microbial content as compared to other mouthwashes. Also, the reduction was seen in tray location when rinsed with chlorhexidine, and also the reduction was seen in the spittoon as well as the chest position when rinsed with neem. So, but also it was noticed that the chest was the most exposed area, which necessitates the usage of the pre-procedural rinsing to avoid cross-contamination in dental practice. So we can conclude that neem was better than chlorhexidine. Chlorhexidine was better than trifla. Trifla was better than the water. So though chlorhexidine is considered as the standard mouthwash, it also has some side effects like tooth staining, which on the other hand, herbal mouth rinses with the natural ingredients offers a safe and effective that should be made use of in the most favorable way. Thank you. Thank you, sir. Thank you, ma'am.
Yeah, Dr. Chinu, like Dr.
Yes,
Chinu,
ma'am.
yeah. What was the patient reaction when she gargled with the neem mouthwash?
Ma'am, the patients tasted it bitter, like they were not ready to rinse with the neem. But when we motivated the patient with that, like it has no side effects, that it has no chemical constituents included in that. So they got more motivated and were willing to use that mouthwash as a pre-procedural rinse when we explained them the procedure.
Yeah. And what about Trifala? Even it was accepted by the patient?
Yes, ma'am. The taste was not acceptable, but if when we explained the side effects of the chlorhexidine as compared to neem, they were ready to use that mouthwash.
Okay, thank you, Chinu. Over to Vinita.
What is the mechanism of action of trifla?
And trifla, ma'am, it is an antioxidant which helps to boost the immune system in the gums and tissues in the mouth. There were studies, which was compared to the chlorhexidine, and it proved to be better. In my study, neem proved to be better than the chlorhexidine. The main it is antioxidant.
What side effect of chlorhexidine you are trying to overcome with use of trifla and neem extract?
Ma'am, mainly tooth staining, because when I went through the neem articles, it also had some side effects like it can't be used in liver and kidney diseases. So the main intention was to reduce the tooth staining. And the salivary pH also was maintained, and it has proved in many studies that the salivary pH has been maintained and the gingival response was better than the chlorhexidine.
How, if chlorhexidine can be used for a longer period of time? Chlorhexidine can be used for a longer period of time if it got staining. How long can neem and trifla be used?
Ma'am, it also can't be used for longer duration. That is why the systemic diseases were excluded from this study. Like the main motive was that the tooth staining only, because even neem can't be used for longer duration, as it also has some side effects, like it can't be used in liver and kidney problems.
Next.
Okay, thank you, Dr. Chino.
Thank you, ma'am. Thank you, sir. Thank you, ma'am.
We can now move forward to our next presentation by Dr. Pujita Gade.
Sir, am I visible?
Yes, you are visible and you are audible. You can continue.
Okay, sir, thank you. Good afternoon, everyone. I'll be presenting my poster on magnification-assisted regenerative periodontal surgery. To introduce the complex anatomy of the furcation area pose a challenge for effective instrumentation of multi-rooted teeth. The limited access contributes to the unpredictable outcomes of the treatment. So to improve the visualization of furcation defects that have been assessed with full thickness flap, which compromises the blood supply at the surgical site, impaired wound healing and gingival recession. The concept of minimally invasive surgery utilizes the surgical loops to visualize the surgical site, which have an added advantage of reduced trauma, ease of flap and wound stability, better wound closure, faster completion and surgery, and reduced patient discomfort. So today in my poster, I will be presenting a case of grade 2 furcation in mandibular first molar managing using microsurgical approach. The surgical technique was done with a microsurgical loops, Carl Zeiss dental loops of 2.5x magnification, and microsurgical instruments for incisions and reflection and debridement were used. So after the incision and reflection, in step 4, as you can see, the bovine hydroxyapatite allograft is placed into the furcation defect, that is a Cirabone allograft, and in step 5, collagen membrane is adapted over the graft onto the root surface. Then in step 6, you can see the sutures placed with number 6 Vicryl ethicon sutures, and the patient was recalled at 3 months interval up to 1 year. Then in step 7, you can see a 12-month post-operative clinical picture with a vertical probing depth reduction of 1 mm. And in step 8, you can see the 12-month post-operative clinical picture with a horizontal probing depth reduction of 1 millimeter. Then in step 9, a preoperative CBCT shows a vertical bone length of 4.9, and in step 10, postoperative CBCT with a vertical bone level of 3.6. Thus, the outcomes of the study is there is a reduction in horizontal probing depth and the vertical probing depth, and horizontal cal gain and vertical cal gain, and horizontal bone gain and vertical bone gain seen in CBCT. Thus, to conclude, the microsurgical approach provided better visualization and instrumentation and facilitated improved clinical outcomes. Thank you, ma'am.
Okay, Pujita,
Yes.
this is the real case you have done, or you have just copied the pictures from some book?
No, ma'am. Since I was a first-year student, ma'am, this is my seniors has done this case, ma'am. It's not a copy paste.
Okay, it seems like.
No, ma'am.
Okay, over to Dr. Vinita.
What is the best method of doing FRP? You have done root planing and scaling, I guess.
Yes, ma'am.
Okay. For furcation, what will you prefer, an ultrasonic scaler or a manual scaler? And why?
Ma'am, can you repeat, ma'am?
If you have to do scaling and root planing in furcation area, what will you prefer, a manual scaler or an ultrasonic scaler, and why?
First with the manual, ma'am, then later with an ultrasonic for complete.
What is the entrance area? You know that the entrance is lesser than the diameter of your instrument. So you
Yes, ma'am. Yes, ma'am. It is a local factor affecting the furcation areas.
Furcation currents?
No, ma'am.
Next presenter.
Thank you, ma'am.
Thank you, Dr. Pujita. Now our next presenter is Dr. Vaishnavi and Dr. Anne Teresa Tommy.
Hello. Hello, am I audible, ma'am?
Yes, you are audible.
Can I start the presentation?
Yes, you can start.
Okay. Good afternoon to one and all. Today I am going to present my poster titled Comparative Evaluation of Efficacy of Herbal Mouthwash and Chlorhexidine Mouthwash on Gingival Health. Plaque control is a critical component of dental practice. In addition to mechanical methods, chemical methods like mouthwashes have proven to be effective anti-plaque agents. Among the chemical agents, chlorhexidine is considered to be an effective anti-plaque agent, but it has got its own limitations like extrinsic staining, altered taste perception, and oral mucosa erosion. To overcome this, many products have been developed, and now herbal products have developed more of interest nowadays. So the aim of my study was to analyze the efficacy of herbal and chlorhexidine mouthwash on gingival health. So the herbal mouthwash which we have used here consists of 3 active ingredients like neem, pomegranate, and miswak, which have got properties like anti-inflammatory properties by regulating the pro-inflammatory cytokines, antioxidant activity by free radical scavenging mechanism, antimicrobial effect, and astringent properties. It has also got advantage like it is free of alcohol and it does not cause any post-use burning sensation. Coming to the materials and methods, the study was conducted on patients reporting to the Department of Periodontics. After obtaining ethical clearance from the ethical committee, a sample of 70 subjects were selected. Out of the 70 subjects, subjects who satisfied the inclusion criteria like age between 19 to 35 years, patients with minimum 22 teeth, and patients with generalized chronic gingivitis were included in the study. And subjects with malaligned teeth, those wearing orthodontic appliance, removable partial dentures, and subjects with chronic generalized periodontitis, and those who underwent oral prophylaxis within past 6 months, smokers were excluded from our study. And finally, the 45 subjects who met with the criteria were randomized into 3 groups using an envelope method, and an informed consent was obtained. The 3 group was 15 patients, group 1, 15 patients who were administered with herbal mouthwash, and group 2, 15 patients who were administered with chlorhexidine mouthwash, and group 3, 15 patients who were administered with a distilled water. A detailed case history was recorded for each of these substances, and indices like oral hygiene index, gingival index, and plaque index were recorded. Supragingival scaling was done, and the subjects were instructed to use mouthwash twice daily at a dilution of 1:1, and variables were relocated at every 7th and 14th day. The data obtained was subjected to statistical analysis using ANOVA test, and it was concluded that both chlorhexidine and herbal mouthwash proved to be effective than placebo on maintaining gingival health, and there was no significant difference between the test groups on gingival health, and it was concluded that herbal mouthwash proves to be an effective alternative to chlorhexidine mouthwash with minimal side effects. Thank you.
Dr. Vaishnavi?
Yes, ma'am.
Dr. Vaishnavi, can you hear me?
Yes, ma'am.
Yes, ma'am.
Yeah. Actually, poster should be very presentable, and the choice of your color I didn't like. I couldn't see. I couldn't see half of your things. In the light green color you have written in white. I couldn't see anything. Okay, and there were no images. And what's new in this in your study?
Ma'am, this herbal mouthwash contains neem, pomegranate, and meswak, ma'am. This combination was not tried in previous studies, ma'am. So we tried to.
I don't agree. I don't agree. There are numerous studies in this.
Okay.
Yes. And that's it. I just wanted to, at least the poster would have been a bit more presentable. Nothing, no images, nothing. I didn't like so much. Anyways, thank you, Vaishnavi. Over to Dr. Vinita.
Vaishnavi, why do you think there's less popularity of this herbal mouthwashes, though we can easily, they are available?
Sorry, ma'am, I didn't get the question.
Commercially, there's less availability of herbal mouthwashes. Am I audible?
It is commercially available, ma'am.
Why is it less popular then?
I don't know, ma'am.
I will give you a much simpler question. What is the difference between a mouthwash and a mouth rinse?
Mouthwash contains this medicaments, medicated values. It has anti-gingival and anti-plaque effects.
When you are dealing with the topic, you should thoroughly read it. You should read it thoroughly. You are a periodontist. Yes? You're going to complete a degree on it. Huh? Next participant.
Okay. Thank you, Dr. Vaishnavi. We can have our next presentation by Dr. Ramya Arya.
Good afternoon, everyone. Am I audible?
Yes, you are audible. You can start now.
The topic for my poster presentation is periodontal health and severity of COVID-19 complications. SARS-CoV-2 is a single-stranded RNA virus that caused a pneumonia outbreak of uncertain etiology in Wuhan, China in December 2019. WHO on March 11, 2020 declared it as a pandemic. Severe cases are complicated by acute respiratory distress syndrome. SARS-CoV-2 infects the cells by using its spike protein to bind to the CD147. CD147 has been seen to be expressed by the cells of gingival epithelium and periodontal pocket cells. These are various proposed mechanisms for the potential role of the oral bacteria in pathogenesis of respiratory infections. Periodontal disease-associated enzymes in saliva may modify the mucosal surfaces to allow for adhesion and colonization of respiratory pathogens. Periodontal disease-associated enzymes may destroy the salivary pellicle to hinder the bacterial clearance. Cytokines originating from periodontal tissues may alter the respiratory epithelium to promote infection by respiratory pathogens and aspiration of oral pathogens into the lungs to cause infection. These are various shared risk factors by periodontal disease and severe COVID-19 illness. These are diabetes mellitus, obesity, pregnancy, oral dysbiosis, asthma, COPD, liver diseases. Common pathway of inflammatory responses.
Can you be a little slow? We are not able to follow it.
Yes,
you.
ma'am.
It's like you are too fast.
Yes, ma'am. Common pathway of inflammatory response pointing towards a possible association between periodontitis and COVID-19 related adverse outcomes. SARS-CoV-2 causes hyperinflammatory state with the release of immune mediators, which is cytokine storm. Lab results from clinical studies and autopsies on COVID-19 patients show elevated inflammatory markers IL-6, 8, TNF-alpha, IL-17. Elevated levels of the same cytokines have been found in gingival tissues and serum of the patients suffering from periodontal diseases. The same cytokines advocate the imbalance between osteoblast and osteoclast activities, causing inflammation-induced periodontal bone loss. Elevated cytokine levels in patients with periodontitis could exacerbate the inflammatory effects of SARS-CoV-2 infection, as shown in this figure. SARS-CoV-2, which causes the lung injury, may lead to the activation of node-like receptor, pattern recognition receptors subfamily, inflammasome, and also there might be release of damage-associated molecular patterns, which in a hyper-responsive host lead to cytokine storm, which is then in which there is increase in the levels of IL-1 beta, IL-6, 8, TEL. Also, there is increase in the C-reactive protein, which leads further. This cytokine storm leads to lymphocyte apoptosis, which leads to immunodeficiency. There is older coagulation cascade leading to thrombocytopenia. All of these increase the further injury in the COVID-19 patients. And periodontal disease, which are precipitated by stress, bacterial superinfection, and microbial dysbiosis, also lead to cytokine storm, further increasing the comorbidities. Thus, we can conclude that successful treatment of periodontitis improves the serum markers of systemic inflammation, and establishing and maintaining the periodontal health can reduce the severity in COVID-19 patients. Thank you.
Dr. Arya, a compliment for you. You will be a very good newsreader. Definitely. I'm sure about it. I don't know. I couldn't hear. I don't know. Dr. Vinta could have heard something. I just came to know there's something you're talking about COVID. That's it.
Ma'am, actually the time was very less and the matter I had to cover within 3 minutes.
Yeah, so, but we should understand something what you are speaking, right?
Yes, ma'am.
You just can't see what's the time. Which year you are in?
I'm in 3rd year.
3rd year, and you are presenting this. You could have gone for some better subject, some surgical topic.
Yes,
that was expected from you, right?
Yes,
okay. Nothing to ask. Over to Dr. Vinita.
Being a periodontist, how will you help a COVID patient, a positive patient?
Ma'am, can you please repeat?
Being a periodontist, if someone, a COVID patient is there, how will you help?
Ma'am, in a COVID patient, since the periodontal disease increases the cytokine levels in the body, and there is increased exacerbation of all, for example, the respiratory disease will increase to further. Thus, I can help by maintaining the periodontal health, which is I can advise, I can educate and motivate the patient to take care of their oral health, which would decrease the.
How? He's positive right now. How will you help him?
Ma'am, I can only educate and motivate the patient to maintain the oral health.
That is what I'm asking you. How?
Ma'am, by proper toothbrushing, and ma'am, by advising the various mouthwashes, which will further decrease bacterial.
You will advise.
Sorry, ma'am.
Literature, which mouthwash you will advise?
Ma'am, any mouthwash containing povidone iodine has been seen to decrease the bacterial load in the COVID-19 patients. Ma'am, there are many, but mainly povidone iodine containing mouthwashes.
State the reference.
Ma'am, there is an article by Frank et al. In which they have seen that there is decreased bacterial load in the COVID-19 patients by using mouthwashes.
Okay. Read it properly. You are not well versed with the subject.
Okay, ma'am.
Fine.
Thank you, ma'am.
Okay, thank you, Dr. Ramya. Now we can move on to our next presentation by presenter Dr. Tripti Rawat and Dr. Nilima Chennasari.
Hello, am I audible?
Yes, you are audible.
Okay. Shall I start?
Yes, yes.
A very good afternoon to respected chairpersons. The title of my study is A Survey on Impact and Change in Knowledge, Awareness and Oral Hygiene Practices After Infection with COVID-19 in General Indian Population. As we all can see that COVID-19 pandemic continues to be a significant problem worldwide, with India alone accounting to 49% of the world's new cases. This is according to a WHO report dated 5th May 2021. So periodontitis and tooth decay are two most common oral diseases. The lungs, similar to oral cavity, are referred to as an ecological community of commensal, symbiotic, and pathogenic microorganisms. Cytokines such as interleukin-6 and TNF-alpha from the periodontally diseased tissues can infiltrate the saliva and GCF and can be aspirated easily. Therefore, inadequate oral hygiene can increase the risk of interbacterial exchanges between the lung and the oral cavity. With this background, we conducted a survey comprising of 30 close-ended questions undertaken for 100 COVID-recovered people. The questionnaire consisted of 4 sections. First was the demographic data, medical and habit history. Second was to assess the attitude and practices before the COVID-19 infection. Third section consisted of symptom charting, severity of the infection, and practices during the infection. And the last section was to assess the change in attitude and practices after their infection. So in data analysis, we found that our study population consisted of 58 females and 42 males, with the majority belonging to the upper middle-class families. So 67% of them experienced mild disease, whereas 12% were hospitalized for the severity of their condition. Most common oral symptoms reported were dysgeusia and anosmia, followed by xerostomia in 31% people and loosening of teeth in 8% people, whereas 6% people reported painful gums. So upon asking if COVID-19 had really changed their thinking on the importance of oral hygiene, 56 people responded to yes. But during the analysis of change in brushing routine, only 17% showed positive change. And 21% people were now of the opinion to visit a dentist regularly in every 6 to 12 months. So with this data, we concluded that positive change was seen when it comes to knowledge and awareness, but noted that only little change was seen during oral hygiene practices after COVID-19 infection. So evidence from the past MERS and SARS infection have shown that public knowledge is important in tackling pandemics. Therefore, further new methods of oral hygiene awareness programs that not only increase the awareness among the people, but also motivates them, boosts them to implement those practices while adopting healthy and responsive behavior should be formulated. Thank you.
Okay, Dr. Tripti,
yes,
just tell me one thing, one takeaway point like I should take from your poster.
Ma'am, the major takeaway point was that knowledge and awareness has still increased, but people are not following those practices. During the oral hygiene practices analysis, their brushing routine, like only 10 to 12 people had changed their brushing routine to twice daily. Earlier, like they used to do once daily, and now they changed to twice daily after their infection. And use of oral hygiene aids also. So very less number of people are now like using tongue cleaners and interdental brushes. Like they are aware, but they are not ready to use them. Like.
Good, Tripti. Over to Dr. Vinita.
How will you associate tongue cleaning with oral hygiene in COVID patient?
Ma'am, in COVID, we have seen the tongue involvement is a lot more. Like we can see swelling of tongue, and there are patches on the tongue that are formed in COVID people, and there are coated tongue also during involvement of mucormycosis or candidiasis patient. Like it is highly increasing these days. So importance of tongue cleaning plays a major role in for maintaining the oral hygiene for any infection, viral infection. Yes, ma'am.
Any article you can quote?
Ma'am, Victoria Sampson et al. Conducted a study recently in which she reported that a lot of people, not of mucormycosis, it was done in US. So, like the cases of fungal super infection was very less. But yes, ma'am.
That study is not related with tongue.
Ma'am, it had symptoms of tongue involvement.
I'm talking about symptoms. I'm talking about the relationship of tongue coating and any COVID symptoms or enhancement of COVID symptoms. Because you're stating.
Yes, ma'am.
You're stating so, yes?
Yes, ma'am.
If there's a patient of COVID positive, he has tongue coating, what will you advise?
Ma'am, proper use of tongue cleaners, proper use of mouthwashes can be prescribed, ma'am.
Which one will be indicated?
Ma'am, which mouthwash will be indicated? Ma'am, povidone iodine mouthwash.
Tongue coating with mucormycosis?
Yes, ma'am.
See, you are confused in little bit. Tongue coating, patchy tongue, mucormycosis, ये सब क्या एक साथ related हैं क्या they are different? First, you should understand that.
Ma'am, they are different. Definitely, they are different. But
So what will you advise at the primary goal? And if the patient is, you doubt that he is going to have mucormycosis at a later stage, so how will you change the treatment?
Ma'am, initially the tongue coating can be treated with the help of tongue cleaners and with the help of mouthwashes. If later on, if we see that the person develops mucormycosis, there are antifungal agents such as isoconazole or posaconazole drugs that can be prescribed to the patient for like reducing. Ma'am, we will educate and motivate the patient to maintain their.
Next present.
Thank you, Dr. Trupti. We can now move on to our next presentation by Dr. Aditi and Dr. Mayur.
Shall I start, ma'am?
Yes, you can start now.
Good afternoon, everyone. Today I am presenting a poster on topic comparative efficacy of diode laser iontophoresis and desensitizing agent in treatment of dentinal hypersensitivity, a randomized clinical trial. The dentin hypersensitivity is a true pain syndrome. Turo in 1990 has stated that tooth hypersensitivity should be considered in the spectrum of pain as the term should be allodontia. In the light of hydrodynamic theory, various treatment modalities are used like potassium nitrate, that means KNO3, is the most popular desensitizing agent, exerts a better desensitizing effect, iontophoresis, which acts by enhancing ion uptake by the dentinal tubules and reduces sensitivity, and diode laser have given an additional therapeutic option for the treatment of dentinal hypersensitivity. So I conducted this study to evaluate and compare the clinical efficacy of diode laser in combination with topical KNO3 gel, iontophoresis, and KNO3 topical gel alone in treatment of dentinal hypersensitivity. So total 30 patients, 10 patients in each group with 3 hypersensitive teeth in each patient due to the periodontal diseases or the wasting diseases were selected. The degree of sensitivity was determined with an air stimulus by the 3-way air syringe. Then the dentinal hypersensitivity was recorded using the verbal rating scale before the treatment, 10 minutes after treatment, 7, 15, and 21 days post-therapy. It is a 4-point scale where 0 denotes no sensitivity, 1 is for mild, 2 is for moderate, 3 is for the severe, 4 is for the very severe sensitivity, was used after withdrawal of stimulus. There are 3 groups in my study. Group 1, in which the patients were treated with diode laser and potassium nitrate gel. In group 2, the patients were treated with iontophoresis treatment with sodium fluoride gel with 2 milliampere output current for 2.5 minutes. Group 3, in which the patients were treated with 5% potassium nitrate topical gel. On intergroup comparison by post-hoc test, it shows that on 7th and 15th day, group 1 showed significant reduction as compared to group 3 followed by group 2, and graph 1 and graph 2 showed that on 7th and 15th day, group 1 showed significant reduction in VRS scores as compared to group 3 followed by group 2. So using diode laser, the depressed transmission of nerve impulses within the dental pulp occur rather than alteration in exposed dentin surfaces. So on CA et al. In 1989 reported that the success in laser irradiated teeth in 98% of their cases. A year VH in 2014 suggested that the better effects of combined treatment, that means diode laser and KNO3 gel, may be due to the higher KNO3 gel adhesion to the dentinal tubules combined with the laser energy. So the other clinical implications of diode laser are like periodontal surgeries, teeth whitening, and the antiphorosis for the decay prevention and parental use. So I concluded that the diode laser associated with
Okay, doctor, your time is up
showed
now.
better results. Yes, ma'am.
Ma'am, I can start with the question answer.
Yeah, Dr. Aditi.
Yes, ma'am.
What's new in your study?
I use the diode lasers with the 380 nanometer wavelength, so it gives better result with combination with the conventional therapy like potassium nitrate gel.
Well, that has been done. It's not new. Yes.
But it gives it gives better results than the
Yeah,
conventional.
that's I'm not denying. What I'm saying is what's
Yes.
new in your study. That's it.
The lasers means in everyday practices. Recently, the lasers are used by various dentists. So
Lasers are used. That is only very old. What new you have done? Lasers are being used everywhere.
yes, ma'am.
Yeah. And have you taken any Likert scale?
Verbal rating scale.
No, Likert scale.
Pardon, ma'am.
Have you taken any Likert scale?
That no, ma'am.
You could have taken, right?
Yes, ma'am.
Okay. Thank you, Aditi. Over to Dr. Vinita.
How will you say that lasers are better than conventional treatment?
Because the laser energy which we pass through the retinal tubules, it shows minimal side effects and less damage or least damage to the pulp and the odontoblasts. And if you use these lasers with the conventional therapies, like it shows better results due to this than other like conventional therapies like antiphorosis and potassium nitrate or others.
And what are the chances of recurrence?
Pardon, ma'am?
Recurrence फिर से sensitivity होगा अगर lasers हम लोग use कर रहे हैं?
Yes, ma'am.
Okay, it's all right. Next time.
Okay. Thank you, Dr. Aditi. We
Yes.
can now move on to our last presentation of this session. We can now move on to our last presentation of this session by Dr. Neha Vasudev.
Neha Vasudev is not there. It Aditi.
Hello.
Hello.
I did saw Neha here in the chair in the participant section.
No. Basically, Dr. Aditi, Dr. Mayur, Chavan, Dr. Neha Vasudev, they are the same.
Okay.
For the
Sorry.
last.
Okay, sorry. It was
So,
my mistake.
no
My part.
problem. It was the last presentation. Yes.
Yeah. Okay.
Okay. Thank you, Dr. Rashmita ma'am and Dr. Vinita Gupta ma'am for taking out your time and chairing this session and being a part of this first ever virtual PG convention 2021.
Thank you, Dr. Asi. Thank you, team. Thank you, Dr. Vinita. Nice meeting you.
Same here, ma'am. Thank you.
Yeah. Thank you. Thank you all participants.
Yes, ma'am. Ma'am, a gentle reminder to send the evaluation sheet.
Yes, I will do that.
Yes, ma'am.
Yeah. Yes.
Thank you so much, ma'am.
Yes. Thank you.
Dr. Misra, the next section will be start at 2:30.
We will start at 2:30.
Yes.
Okay.
But it's up to you. If you want to start it now, that's not a problem.
Only Anurag sir had joined. Abhishek sir has not joined. I have called him.
Okay, then wait for him.
Okay. We can wait for Dr. Abhishek sir to join.
Thank you.
Good afternoon, everyone. We can now proceed with our sixth session. May I introduce the chairperson of this session, Dr. Anurag Satpathy. He is professor from the Department of Periodontics, Institute of Dental Science, Bhubaneswar, Odisha. Along with his is Dr. Abhishek Verma. He is professor from Buddha Institute of Dental Science and Hospital, Patna, Bihar. Welcome, sir.
Thank you.
Okay, now we can proceed with our first presentation of this session by Dr. Priyanka.
One minute.
Hello, sir. Good afternoon.
Good afternoon, Dr. Abhishek.
How's you, sir?
I'm fine, thank you. Dr. Randir is there in your college?
Dr. Priyanka, please start.
Good afternoon, one and all. Today I am presenting a poster on clinical evaluation of gingival fiber retention technique in the treatment of patients with chronic periodontitis. First, I am starting with the introduction. Periodontitis is a multifactorial disease resulting in inflammation with the destruction of connective tissue attachment of the teeth. Gingival fiber retention technique was introduced in 1960 by Ramford and Kohler. Levin Leslie in 1972 described the technique in the conjunction with the flap surgery. Aims and objective of this study to assess the effect of periodontal mucoperiosteal flap surgery with gingival fiber retention technique in treating with suprabony periodontal pocket and minimizing the post-surgical gingival recession. 4 patients with moderate to severe periodontitis, chronic periodontitis patients were selected and randomly divided into 2 groups. In group 1, flap surgery with gingival fiber retention technique. In group 2, conventional periodontal flap surgery, that is Kirkland flap. Then clinical parameters were included: plaque index, gingival index, periodontal disease index, clinical periodont probing attachment, recession length, recession width, area of recession were recorded at baseline, 4 weeks, 8 weeks, and 12 weeks. In flap surgery with gingival fiber retention procedure, an internal bevel incision were made approximately 2 mm apical to the free gingival margin. Oblique and vertical releasing incision were made if required. Flap surgery were reflected with blunt periosteal elevator and excision of detached gingiva coronal to the adjacent epithelial curve was done. Then result in both intra and intergroup comparison, the recession length and width were significantly higher in the control group, that is Kirkland, compared to the experimental side at 4 weeks, and 8 weeks, and 12 weeks. Then I am concluded with the study. Gingival fiber retention technique it is a simple, required less working time and excellent results, and it also showed that less post-surgical recession throughout the study. Thank you so.
Yeah, Dr. Abhishek, if you want to ask any question. Hello, am I audible?
Yes, sir.
Yeah. Dr. Abhishek, your microphone is muted.
Yeah, Dr. Anurag, please continue.
Yeah, thank you. Yeah, Dr. Priyanka, okay. How did you go for the measurement of the recession length?
So from CEJ,
yeah, you went for CJ.
Yes.
Don't you think a relative length would have been a better measurement?
Yeah, sir.
What was the inclusion criteria for your case?
So inclusion criteria for moderate to severe periodontitis cases, then with the age group of 20 to 40 years, patient who would be physically healthy and present no detectable clinical signs, and with minimum patient with in each patient's at least 6 teeth were included in this
How did
study.
you differentiate between the? How did you differentiate that the periodontal fibers have to be left out? What was the diagnostic or the identifying criteria? You still had to do the debridement procedure, right?
Yes, sir.
So
Yes,
how
sir.
did you differentiate that what to leave behind and what to debride? Well, that was central to your experiment, right? Study.
Yes, sir. Right, sir.
What was the pocket depth you selected?
Sir, more than 5 mm.
No, in all your cases.
Yes, sir.
So what did you find out? What was your conclusion?
So my conclusion is in gingival fiber retention, that is the more that is good as compared to the Kirkland, because in gingival fiber retention there is a less post-surgical recession as compared to the Kirkland flap.
So what was the follow-up for how many days?
Sir, follow-up for 12 weeks. That is, first is from baseline, then 4 weeks, 8 weeks, and 12 weeks.
No, post-operatively.
Hello, sir. Sorry, sir.
Post-surgical follow-up for how many days?
So there is only post follow-up is 4 weeks and 8 weeks and 12 weeks.
Okay, need to have a little more period of a time for follow-up. For this initial time period, you will not be able to appreciate the exact amount of recession.
Right, sir.
Okay.
Thank you, Dr. Priyanka. Our next presentation by Dr. Madhusri Jetty.
Hello.
Yes,
Am I
Madhusri.
audible?
Yes, you're audible.
Good afternoon, everyone. My topic for today's poster is comparative evaluation of wound healing after frenectomy by conventional or laser-assisted surgery. Coming to the introduction, the frenum is a fold of mucous membrane that attaches the lip and cheek to the alveolar mucosa, gingiva, and underlying periosteum. The gingival health will be hampered when frenum is attached too closely to the gingival margin. Such condition is treated by frenectomy. Coming to the methodology, 20 patients with high frenal attachment were treated either with conventional technique or laser-assisted surgery. Standardized healing index given by Laundry et al. And VAS score for post-operative pain was evaluated on first week, second, and fourth week. 10 patients were divided in each group. Coming to the scoring, in VAS scoring, subjects were asked to rate the degree of pain on 10 centimeter horizontal visual analog scale by placing a vertical mark to assess position between two endpoints. Scores are given from 0 to 10. Left hand point was nominated as no pain, and right hand point was nominated as worst pain imaginable. In healing index given by Laundry et al., this assesses the wound healing using score from 1 to 5. A wound healing with very poor healing receives a score of 1, whereas excellent healing receives a score of 5. Coming to statistics, Mann-Whitney U-test was applied to find out the significant difference between two independent groups in the parameters measured. According to VAS score, the test showed statistical significant difference between groups, where laser group showed less pain at baseline, with the p-value less than was 0.05. There was no significant difference seen between groups at first week, second week, and fourth week. According to healing index, Mann-Whitney test showed no statistical significant difference between groups at baseline, first week, and second week, and fourth week. Coming to the results, the healing index showed better results in group A, that is conventional method, on second week, but it was not statistically significant, whereas post-operative pain was significantly less in laser group at baseline. Finally, I would like to conclude that based on the current findings, both techniques showed similar results in healing, but laser group also showed better VAS score, therefore leading to good patient compliance. Thank you.
Yeah, Dr. Abhishek, please.
Yeah. What was your conclusion?
Sir, both groups showed better healing, sir, but in laser group, even the pain was less. So we would recommend laser
So
than
doing
conventional.
you did all these surgical procedures.
No, my senior did, sir.
You have not done any of the case?
Sir?
Have you done any of the cases?
No, sir, I'm first year student, sir. I'm not done.
So you have evaluated only on the VAS score or questionnaire?
Yes, sir.
How did you evaluate the healing?
Healing index given by Laundry et al, sir. Four scoring criteria was
You are
used.
not getting my point. Since you have not done the cases, how did you evaluate the healing?
Sir, this study was done by my senior, so all the statistics, everything was given by them.
Okay, fine. Dr. Anurag, please.
Yeah. Okay. Tell me one thing. When you are comparing between these two, so what other parameters could have been taken for this study apart from just you can say patient parameters and Lorry index? What other parameters could have been taken? Can you suggest?
Hello, I'm not able to hear, sir.
Okay, I'm asking you what other parameters could have been taken for a better assessment of wound healing apart from these two parameters?
Sir,
You're comparing
we
conventional
can use
versus
in blue for
laser, right?
assisting the healing.
Yeah.
Yes, sir.
So the knowledge that you have got is already known, no? That laser is better or pain is less. But in your study, you are saying that there is no difference between them.
Sir, we used standardized index to check whether laser is better.
Which laser did you use?
Sir, diode laser, sir.
Okay, thank you.
Thank you, sir.
Thank you, Dr. Madhusri. Let's move on to our next presentation by Dr. Kamal Pandey.
Good afternoon, everyone. My poster topic is the application of ozone therapy in periodontics. Ozone is the inorganic molecule with the chemical formula O3. It has ability to filter ultraviolet rays, critical for maintenance of the biological balance in the biosphere. It is applicable in medical field mainly due to its properties of anti-hypoxic, immunostimulating, antimicrobial properties. Medical grade of ozone is the mixture of pure oxygen, which consists of 95 to 99.5%, and pure ozone in the concentration of 0.05 to 5%. Ozone is naturally produced by the photodissociation of the molecular oxygen into activated oxygen atom, which then react with the further oxygen molecules. Ozone generated are the ultraviolet system, cold plasma system, and corona discharge system. Corona discharge system produces the high concentration of ozone. It is the most common system used in the medical and dental field. It is easy to handle and it has controlled ozone production rate. Mechanism of action of ozone are antimicrobial, immunostimulating, and anti-hypoxic properties. Antimicrobial, ozone works destructively against the bacteria, virus and fungi. Fungi and immunostimulating effect influence the cellular and humoral immunity, activate the function of macrophages, and it stimulates proliferation of immunocompetent cells and synthesis of immunoglobulin. Anti-hypoxic effect, ozone increases the transportation of oxygen in blood and change in the cellular metabolism. Form of ozone use are ozonated gas, ozonated water, ozonated oil, and ozonated nanobubbles. Ozone indication of ozone use in periodontics are it can be used in the mouth ringes in gingivitis, periodontitis, and the stomatitis. It can be used in sterilization of periodontal pocket, and ozone act is the powerful disinfectant. Ozonated water also demonstrate the ability to prevent plaque accumulation, and it can be used to clean wound in bone and soft tissue, irrigation of the surgical site. Application of ozone water enhances the health of periodontal tissue. The ozone therapy improve the oxygen supply to the wound and improve the wound healing, and it can be used to treat the dentinal hypersensitivity. It can be used as the irrigant along with the scaling and root planing, and can be used in the toothbrush decontamination. Ozone therapy is found useful in grafting and bone regeneration procedure, and it can be used in the implant surface debridement in case of peri-implantitis. Contraindication of ozone use are the it cannot be used in case of acute alcohol intoxication, recent AMI, severe acute hemorrhage, pregnancy, hypothyroidism, ozone allergy, and patient on ACE inhibitor. Conclusion: modern dentistry is all about the non or minimum invasive dentistry. The clinical application has not achieved a strong level of efficacy, but it is proving to be the new therapeutic modality to the patient. However, for the research work is indicated, there is the evidence of the good biocompatibility of aqueous ozone with the human oral epithelial cell, gingival fibroblast, and periodontal cell. Thank you, sir.
Dr. Murad, please.
Yeah, thank you. Dr. Pandey, can you elaborate on how ozone therapy can be helpful in desensitizing therapy in treatment of dental hypersensitivity?
Sir, it produce the if we apply the ozone, and it can produce the smear layer in which help in the blockage of the dentinal tubule, so patient does not perceive the sensitivity.
Can you cite any reference for that?
Sorry, sir.
Can you cite any reference for that who has postulated this?
No, sir.
Okay, over to you, sir. Dr. Abhishek, yes, sir.
Dr. Pandey, your poster was not very clear.
Yes, sir.
If you're presenting a poster, it should have been legible now. If you're not able to read it properly.
Yes.
Second thing, have you done the cases?
Sorry, sir.
Have you used?
No, sir.
So from where have you collected this data?
Sir, I have collected from the various articles, sir.
Pardon?
Sir, I have collected these sources from the various articles, sir.
So you have not done it yourself?
Yes, sir.
So can you brief a little more on the ozone therapy?
Sir, it can be used in various periodontal procedures. Sir, it can be used as the irrigant along with the scaling and root cleaning. It can be used as the
voice is not very clear, Dr. Pandey. Be a little.
Yes, sir. Hello, sir.
Carry on. Be a little louder.
Yes, sir. It can be used.
Okay, fine. Leave it. Okay, fine.
Thank you, sir.
Thank you, Dr. Kamal Pandey. Our next presentation by Dr. Lishana Momin.
Am I audible?
Yes, Lishana, you are audible.
Good afternoon, judges. Today, my presentation is about a survey conducted on how general dentists and other dental professionals view the scope of periodontics and why is it important to investigate their perception, attitude, and knowledge toward the specialty. A survey was conducted for 3 months using Google Forms in which 15 close-ended questions were asked to the respondents, and I got 110.
Sorry, just be a little louder.
And I got responses from all over India. Now, coming to the result, participant demography reveals maximum respondents were female, practicing in urban area, and general dentists. Now, regarding interest and knowledge, 78% out of 100 have interest in periodontics, and respondents were even asked to raise their interest in periodontics, and 28% have given a score of 7 out of 10. Now, only 16% out of 100 think that periodontics has a scope in future dentistry, and 37% out of 100 see the scope and future prospects is limited to dental practitioner. Now, regarding type of practice, 63% out of 100 would prefer group practice and with general dentists and other dental specialists. Coming to the diagnosis part, 64% out of 100 performs full mouth periodontal examination, and 86% have checked for bleeding on probing, 91% have advised for IOP, and 53% have advised for OPG for the diagnosis of periodontal disease. Now, questions regarding treatment. 81% investigated underlying causes for treatment of bleeding gums, and 42% out of 100 are uncertain about periodontal treatment that actually discouraged them from providing periodontal treatment. Now, coming to the referral, only 56% have referred to a periodontist, and the reason for referring is seen in 74% is due to knowledge, understanding, familiarity with periodontal disease, and 66% who have is due to few patients who gets motivated for periodontal therapy, and 42% have frequently referred to periodontists for periodontal surgery. Now, in conclusion, I would like to conclude that it's important to provide knowledge and insight of our scope of practice to determine best prognosis and treatment options to your patient to assure quality care. And also, it is important to recognize the cornerstone of dentistry, where every specialty revolves around in terms of keeping the tooth healthy so that treatment can be rendered.
Dr. Lishana, what was the hypothesis? Why did you conduct this survey?
Sir, actually, I want to give the insight, and I want to know the perception, attitude, and knowledge of the general dentist, basically general dentists all over India, towards their understanding about periodontics, so that they give their best treatment and best prognosis and treatment options for the patient for their quality care.
How many respondents did you have?
I got 110 responses.
And did you conduct any sample size estimation before conducting this?
Sir,
this is pan-India survey, right?
Pan-India survey.
So, and you got 130.
Only 110 responses I got from the general dentist.
Okay. Do you think this is sufficient?
Sir, actually, it should be 10% of the population of India, where population of India is 134 crore. So it is not actually sufficient,
No,
but there are.
No, it should not be 10% of population of India. That's not possible. Okay. Okay. You should have done a sample size estimation. Then would have been better.
Yes, sir. Yes,
it's
sir.
an interesting study. Little more focus should have been there.
Yes, sir.
Dr. Abhishek, yes.
Yeah, as said by Dr. Nathar, the sample size would have been a little more. It's very less. So what was your observation by taking all these details?
My observation is that maximum people have, maximum general dentists are not aware of the scope of practice, our periodontics as a scope of practice and also as a specialty. And also in there are varieties of results that I've got for the diagnosis and treatment, and only 64% have examined like full mouth examination, and that also only for bleeding on probing. And the treatment also maximum have investigate underlying causes for bleeding gums, and maximum are uncertain about periodontal treatment that actually discourage them from giving the periodontal treatment, and maximum have not referred to the periodontist.
I suggest you to pursue with the study, okay? So that you collect the larger sample size.
Same here, Dr. Lishana. Continue with the study, okay? Take some good time, as Dr. Abhishek rightly said, okay?
Okay, fine.
Okay, thank you, Dr. Lishana. We can now move on to our next presentation. Presenter is Dr. Kalpana Pandey.
Good afternoon, sir. Myself, Dr. Kalpana Pandey, PG second year student. I'm here to present the poster on the gingival bar type assessment in periodontally healthy population of Madhya Pradesh. It is a cross-section study. The aim of this study is to assess the gingival thickness in a 30 sample size of patient. Basically, gingival bar type was, this term was proposed by Seibert and Linde in 1989. The basic pioneer work was done by Oceanbin and Ross in the year 1969. This basically the gingival thickness was classified into thick, flat, and thin and scallop type. What is the significance of gingival thickness was by the following thing, like the mucogingival surgery, GTR, implant dentistry, crown lengthening procedure. Gingival surgery, now we are coming to the material and methods. They were basically three methods were used to assess the gingival thickness biotype. The transgingival probing with the standard periodontal probe, the acupuncture needle was used with a 0.188 mm diameter, and the third was the visibility. The inclusion criteria was systemically healthy patient, healthy gingiva, and 10 to 50 years of age of patient. Exclusion criteria was those patients where those were lactating, pregnant, where orthodontic treatment is going on, or orthodontic treatment or surgical intervention, or those on the medication which can cause the gingival enlargement, and those where the restorations are there in the area of interest was excluded for the study. The intergroup comparison was done between the male and female through all these three methods. The conclusion was about 2/3 of the population, what we have studied was that they were clear thick gingival biotype in male, rather than if we compare to the female gingival biotype. The other methods by which we can assess the gingival biotype is ultrasonic method and CBCT. Ultrasonic method is much more reliable than these direct methods because of it is non-invasive and there's accurate reading, but it is costly, unavailable, so it is not used much for the gingival thickness assessment. The other method is CBCT method, which is used here, but there's a radiation exposure and cost effect. Then also, that is the only reason, again, it is not used for the assessment for the gingival thickness. Now we have completed the material method and the different ways of checking the gingival biotype. The conclusion was that male has a higher thickness biotype than the female type. Thank you, sir.
Yeah, Dr. Abhishek, please. Yeah.
Any specialized probe you use for assessing the biotype?
So Williams probe was used, sir.
Do you know any other specialized probe which can be used?
Other specialized probe, like the different probe you're asking, sir?
Yes.
So UNC 15 can also be used.
So you were limited only to the maxillary centrals?
Yes, sir. Because of the aesthetic and the functional reason, the maxillary central was only used, sir.
So what was the sample size you took?
So it was just 30, sir. Because of 30. The pandemic, the flow, yes, sir. Because of the pandemic, the flow of patients were not there in college, so it was just.
So your result may vary. The 30 patients is very less sample size.
Yes, sir, very less. But as we have to present it,
so how do you justify your result?
So what with the samples were taken? So it is a bias. Actually, the sample size is not sufficient, but what we have got in that only we tried means what we got we have shown, sir.
Okay, fine. But yes, Dr. Anurag.
Thank you, Dr. Abhishek. Dr. Kalpana, see, firstly, as Dr. Abhishek said, the sample size is too less. It probably will not even qualify for a pilot in such a survey. Okay, or you can simply should have put it as a pilot survey. Number one, because you are assessing the gingival biotype, okay, which has a which needs a very large sample size in order to determine. Number one. Number two, if you are using a probe such as Williams probe, the least count is 1 millimeter. Okay.
Correct.
So that itself is a deficient, or it is a faulty instrument to use. You should have gone for a higher sensitive instruments for that. Okay.
Right, sir.
Because the thickness of gingiva, as you're determining from two dimensions, right? From the vertically as well as from the thickness, the length, yes, right?
Transgingival probing.
Transgingival probing you are going for. Right. So you should have gone for an instrument which was more sensitive. Right. Thirdly, the best method is histologic. Only the histologic assessment will give you the exact the dimension, but that is not ethically true. Okay, acceptable. I propose that you carry out in a wider sample size and right. do not jump into the conclusions that yes, male are more than females. okay, it is very, you can say misleading. Okay, go for age criteria, okay, gender variations, okay, and maybe the variations could be in arches because gingival thickness only at the central incisors without taking into consideration the amount and the adequacy of the width of attached gingiva is also misleading. Okay,
Correct,
take
sir.
all these things into consideration.
Right,
Good
sir.
luck. Thank you.
Okay, thank you so much, sir.
Thank you, Dr. Kalpana. We can have our next presentation. Our presenter is Dr. Sakshi Tiwari.
So shall I start?
Yes, yes, you can start.
Good afternoon, everyone. Today I'm going to present. Today I'm going to present poster with the title an in vitro evaluation and comparison of efficacy of tetracycline and doxycycline as root conditioning agents for smear layer removal and fibrin clot adhesion to the conditioned root surface, a scanning electron microscopic study. The aim and objectives. The first is to evaluate and compare the efficacy of tetracycline and doxycycline in smear layer removal from the root cementum post-root planing. And the second is to evaluate and compare the distribution of fibrin clot adhesion to the conditioned root surface. Then coming to the introduction, the periodontitis is an infectious disease which results in inflammation with the supporting tissues of the with progressive attachment loss. And the rationale of root conditioning is to remove the smear layer on root surfaces and also to uncover and widen the dentinal tubules, and it also unmasks the dentine collagen matrix. Then materials and methods. In this, the 60 freshly extracted teeth were selected and it washed with saline. Then the crown portion of each tooth was cut at CJ and removed with metallic disc under copious irrigation. Then the root planing was done with greasy curettes, and the specimens were divided into the 4 groups. The first group is tetracycline hydrochloride. The second group is doxycycline hydrate. The third group is blood drop post tetracycline conditioning, and the fourth group is blood drop post doxycycline conditioning. Then the samples of each group rubbed with saturated cotton pellets of the test solutions for 3 minutes. Then the area of each sample is rinsed with saline. Then the drop of fresh human whole blood was applied to the specimen in group 3 and 4 and left it to clot post, which were then rinsed with saline for 3 minutes. Then the samples were viewed under the SCM for the evaluation of smear layer removal in group 1 and group 2. And then the micrographs were taken and then evaluated. For smear layer removal, the Zia A et al. Scoring criteria were used, and for the fibrin clot adhesion, the blood element adhesion index score were used. And the statistical analysis was done by using the Mann-Whitney U-test. Then coming to the result, both the groups removed smear layer and adhered fibrin clot, but the doxycycline was has found to be more effective as compared to the tetracycline. Hence, the study was concluded that the doxycycline hyclate could provide the enhanced results in terms of regeneration.
Thanks, sir.
Thank you.
Yes, Dr. Sakshi. Hello.
Yes, sir.
Yeah, it's a good study. Okay, so can you tell me? See, you said you have 4 groups, right? But
Yes,
basically
sir.
there are 2 groups, and then you have carried out the smear layer study and the fibrin clot adhesion study, right? In
Yes,
the
sir.
same tool. So there are no 4 groups. There are 2 groups and 2 assessments.
Yes, sir.
Am I right?
Yes, sir.
Okay.
Sir, there are 4 groups and 2 assessment for smear layer removal and the adhesion of fibrin clot.
No, group 1 is the one which you have used doxycycline. The second group is tetracycline, right?
Sorry, sir, I can't hear you.
first group you have used doxycycline, the second group you have used tetracycline, right? Or vice versa?
Yes, sir.
And in group 3,
First
have
is
you used any?
tetracycline hydrochloride, and second is doxycycline hyclin.
And group 3?
Sir, a blood draw post tetracycline conditioning.
So both the 3 and 4 are basically the group 1 and 2 where the post drop test has been done, right?
Yes, sir. Yes, sir.
That's what I'm saying. It's not 4 groups, 2 groups, 2 assessments.
Yes,
First.
yes, sir. Sorry,
Okay.
sir.
Yeah.
Yes.
Secondly, see how did you choose the area, because you are using SCM and then the blood clot. So did you standardize for an area to be seen, because there are wide areas? How did you choose for the areas and select for identification and estimation of this Smear assessment? You used 2 indices, right?
Sorry, sir.
You used an index for assessment of the smear layer and an index.
Yes, sir. Yes, sir.
How many fields did you choose, and at what magnification did you see?
Sir, for smear layer removal, sir, at 100, 200, and 300 magnification, and for sir fibrin clot adhesion, sir, 500.
Okay, okay, and your sample size was 60 teeth, right?
Yes, sir. 15 in each group.
Okay. Oh, good enough. Over to you, sir.
Okay, fine, no questions.
Okay, sir. Thank you, sir.
Thank you.
Thank you, Dr. Shakshi.
Okay.
We can now move on to our next presentation by Dr. Bola Sushma and Dr. Shadan Tabassum.
Good afternoon. Today's poster presentation is on the topic, the efficacy of autologous particulate dentin in socket preservation. Alveolar bone loss and soft tissue loss are seen following tooth extraction. Because of the significant changes, the placement of implant or fixed prosthesis becomes difficult. Within first 6 months of tooth extraction, there is bone loss in height and width of the alveolar bone. In order to prevent this resorption, different methods of alveolar-rich preservation have been described. So the aim of this case report is to demonstrate the efficacy of autologous particulate dentin for rich preservation prior to implant placement or fixed restorations. Indications of socket preservation are maintaining original anatomy of the ridge to achieve predictable aesthetic and functional restoration and implant placement. Advantages of using particulate dentin are dentin and bone has similar organic and inorganic structure. It can be used as either block graft or in particulated form. It is involved in bone remodeling and in expressing osteoconductive and even osteoinductive properties. The bone scaffolds have inflammatory response and neovascularization similar to that of an isogenic bone. In the present case report, the patient of age 45 years came to the department with a chief complaint of loosening of teeth in upper front tooth region. On clinical examination, grade 2 mobility is seen in respect to 1-1 with trauma from occlusion in the anterior teeth. In the treatment plan, a traumatic extraction of 1-1 performed under local anesthesia and the socket was thoroughly irrigated. The crown and root portion of the extracted tooth was separated and the root dentin was thoroughly cleaned and pulp portion was removed. Subsequently, the remaining dentin is made into pieces and these pieces were grinded using a bone mill to obtain a particular size of 300 to 400 microns. Then the obtained autologous particulate dentin is placed into the alveolar socket carefully. The free gingival graft was then harvested from the patient's palate using a soft tissue punch, which is carefully adapted over the particulate dentin and the sutures are placed. Then the crown portion was splinted using the support of adjacent tooth. Suture removal was performed after 10 days and 4 months post-operative radiographs have shown less resorption of alveolar bone in its height and width. And the fixed prosthesis was given to the patients 5 months post-operatively. So in conclusion, it can be said that the particulate dentin of autologous tooth may serve as an alternative to autologous bone for alveolar-rich preservation prior to placement of implant or fixed restoration. Thank you.
Yes, Dr. Abhishek, please.
Yeah, doctor, tell me one thing. Is the augmentation like socket preservation is important in prognosis of an implant? Good better prognosis of implant or in non-augmented socket. If you compare with an augmented socket or a non-augmented socket, which is better prognosis for the implant?
Augmented socket also.
How?
The bone resorption will be less
When do you go for augmentation of socket?
when the alveolar bone height is less for implant for future implant placement.
So when there is no requirement of augmentation, that means there is no deficiency of that socket.
Yes.
If there is no deficiency, if you put an implant, even with the immediate placement, will the prognosis will be poor?
No, sir.
Just now you said it will be better for the augmented sockets. So what is the basic rationale for the augmentation of or preservation of any socket?
To prevent the resorption of the ridge, sir. To prevent the resorption of the alveolar ridge for future implant placement or any prosthesis.
Any socket you put in the implant, there will be a certain amount of resorption will be present, right?
Yes.
So you cannot prevent the resorption of a ridge. Okay, no worries. Okay, Dr. Anurag. Dr. Anurag, you are muted.
Sorry, no further questions here. Thank you.
Okay. Thank you, sir. Thank you, Dr. Sushma, for your presentation. We can now move on to our next presenter, Dr. Varsha Rani Soni.
Good afternoon, sir. Shall I start?
Yes, you can start.
Good afternoon, everybody. I'm Varsha Rani Soni. Today, I'll be discussing about the association of gingival biotype in relation to age, gender, dental arch, and facial phenotype. Coming to the introduction, a clinically healthy periodontium has been shown to have a varied anatomical, physiological, and phenotypical changes between individuals. Gingival morphology plays an important role in determining the final aesthetic outcome. Therefore, during treatment planning, it is important to recognize differences in gingival biotype. Long back, Oskebin and Miller discussed the importance of thick versus thin gingiva in restorative treatment. And in 1986, Clefey defined gingival biotype in which more than or equal to 2 mm is thick gingival biotype and less than 1.5 mm is thin gingival biotype. Coming to the materials and method, it is an observational analytical study. A total 48 subjects recruited in this study and subjects was divided into 3 different groups based on age with an equal proportion of male and female. After that, gingival biotype evaluation was done by probe transparency and Remo method by injecting lidocaine spray to determine the gingival thickness. And then prosopic index evaluation was measured by digital caliper and then facial index was calculated. The collected data was tabulated, compiled and subjected to the statistical analysis by using chi-square and t-test in which p-value was taken 0.05 was considered as statistically significant. Then coming to the result, it is observed that the thickness of gingiva significantly decreased with age in both arches and female is having significantly higher gingival thickness as compared to male. Analysis also shows that the maxillary arch is thicker than mandibular arch. With regard to facial phenotype, most individuals are leptoprosopic in our study, which have significant association with thick gingival biotype. Then coming to the discussion, Agrawal et al. in 2021 showed similar result as in this study, as compared to this study, and on contrary, D. Rook et al. In 2009 observed that female is having a thin gingival biotype in contrast to present study. Another study by M. Asiri et al. In 2019 concluded that mesoprosopic facial phenotype significantly associated with thin gingival biotype. Then, by concluding this, there are definite differences in gingival biotype among different individuals according to age, gender, arch form, and facial phenotype. So, we should consider biotype during treatment procedure for better prognosis. Thank you.
Yes, good study. What was the exclusion criteria for your study?
Sir, exclusion criteria are, sir, with a patient subject with a prosthesis or restoration, pregnant or lactating women having pocket exceeding with 3 mm, and a history of orthodontic treatment and drug-induced gingival enlargement.
How many sites have you checked?
So, anterior, mandibular and maxillary arch.
Both, and you have taken an average mean?
Yes, sir.
Okay, your sample size could have been more. Please continue the study. Okay.
Yes.
This can also be a pilot and should continue the study.
Yes.
Okay. Dr. Abhishek.
Which probe did you use?
So I have used two methods. First, in probe transparency, I have used UNC probe, sir, for assessment.
So why you are not using a second generation pressure sensitive probes?
So, I'll definitely use.
It may again vary with the amount of force you apply in.
Yes, sir.
Understood. So ideally you should have used a second generation pressure sensitive probes.
Okay, sir. Yes, sir.
Okay. And as Dr. Nurag said, you continue with the study, but with a larger amount of sample size.
Yes, sir. I'll definitely continue the study, sir.
Okay, fine.
Thank you, sir. Thank you, sir.
Thank you, Dr. Varsha.
Thank you, sir.
Can we have now the next presentation? The presenter is Dr. Vallari Shah.
Good day, ma'am. Good day, sir. So today I'm going to present a poster as a part of the clinical research which was carried out as a short study in the form of a case report. So case report here is basically a comparison just done between two surgical dressings, that is barricade as well as Copac, which is given following periodontal flap surgery. So why is surgical dressing given? So basically it protects the surgical site and area and prevents damage and infection, and also protects the area from any trauma and prevents the surface during the trauma which is caused during mastication. Also it prevents post-operative infection and hemorrhage. So this is that is the reason of surgical dressing is given following periodontal flap surgery. So beginning with the case report, a 44-year-old female patient reports to the Department of the Periodontology with the chief complaint of bleeding gums and swollen gums, and reveal a presence of generalized periodontal pockets depicting horizontal bone loss, which is appreciated in the radiograph when clinical and the radiographical findings were taken. Patient was systemically healthy with no parafunctional habits or deleterious habits. Other intraoral findings included grade 1 percussion involvement in relation to 2636 and 46, as well as generalized gingival recession was present in relation to the dentition, as well as the missing teeth which were present were 1121, 3132, 41, and 42. Patient had undergone fixed prosthesis in relation to 11, 12, 21, and 22, as well as 31, 32, 33, 41, 42, and 43. So as per the clinical and the radiographic diagnosis was made, which was as being to generalized chronic periodontitis. So as a part of the treatment plan, scaling and root planing was performed, as well as a full mouth periodontal flap surgery was planned as indicated. So at the baseline, as a part of the study design, plaque as well as gingival index scores were taken, which was included in the part of the study design, as well as flap surgery was performed in relation to the first quadrant in relation to the teeth number 13 till 17. Sutures were given, and the periodontal dressing which was given here in the first quadrant was the periodontal pack. Contralaterally, flap surgery was performed in the third quadrant, wherein barricade was given as a surgical dressing post-operatively, as well as a questionnaire was handed to the patients at the 7th day, on the day of the suture removal as well as pack removal, where the patient was basically asked about the pain perception, discomfort, or any discomfort which occurred.
Sir, you can have the question and answer session now.
Yeah, Dr. Abhishek, please.
Are you asking or should I ask?
Yes, please proceed.
Okay. So you once said that it by putting a dressing, you reduces or minimizes the post-operative infection. So how it is done? You said that by putting a dressing, you will be minimizing a post-operative infection. This was one of your So how do you minimize the post-operative infection? I think you're not.
Dr. Varshak, we are not able to hear you. Please.
Yeah. Unmute yourself. Unmute yourself.
Yeah.
Yeah.
No. We are still not able to hear you.
Yeah, it's you. You please say something. No. We are not able to hear you.
No, tech team, please help. We are not able to hear her.
So, can we share next slide?
Yeah, please.
Yeah.
This is the last presentation by Dr. VNV Sathya, Wali DR, G. Dinesh.
Good afternoon, everyone. I'm here to present a poster titled as Impact of Periodontal Disease on Sleep Quality and Oral Health Related Quality of Life. Oral health is an integral part of general health, and diseases of oral tissues may have an impact on the general well-being of the patients. Amongst the varied oral diseases, periodontal disease is the most common with an impact on individuals' well-being. Some systemic conditions have shown their association with progression of periodontal disease. Sleep deprivation has shown a little evidence on periodontal disease action. Sleep deprivation is associated with decreased immunity and increased inflammatory markers, which have a deep impact on the occurrence and progression of several infectious diseases, including periodontal disease. Although periodontal disease is initiated by bacteria that colonize the tooth surface and gingival sulcus, the pro-inflammatory cytokines released by the host is believed to play an essential role in disturbing the tissue homeostasis. The aim of the present study is to investigate the association between the periodontitis as classified according to AAP in the year 2017 and sleep quality and oral health related quality of life in periodontitis patients. Coming to the methodology, the study is an observational study where a total of 120 subjects who met the inclusion criteria were taken into the consideration. After a thorough clinical examination, periodontal disease activity was recorded using periodontal parameters like plaque index, gingival index, probing depth, and clinical attachment level. Patients were categorized based on the new classification system given by AAP in the year 2017. The degree of periodontitis was determined based on the staging and grading system, wherein the stage classifies the severity and complexity of the periodontal disease. Grade assists in the estimation of likelihood of the disease progression. The results obtained by the study were the mean age of all the participants were 35.34 years and the mean of the global Pittsburgh Sleep Quality of Index score was 7.53 and the mean scores were greater in stage 3 when compared to stage 1 and were greater in grade C compared to grade B. The mean oral health impact profile scores was 21.13 with a statistically significant difference between the stages and grades and have seen greatest in stage 3 compared to stage 1 and the grade C compared to grade B. To conclude, within the limits of the study, there is a possible association of the severity of periodontitis with the sleep deprivation and can have an impact on quality of life of an individual. The clinical relevance of this study were there is a need to focus on prevention of periodontal disease. Assessing the oral health related quality of life should be an integral part of examination by healthcare professionals for general health and well-being of an individual. Thank you.
Okay, Dr. Nice study. No, you have taken a global scale, right?
Yes, sir.
Okay, and what was your conclusion?
So, as the stage and grade of periodontitis is increasing, there is a chance of sleep deprivation in the patients. Means I have found out that stage 3 and grade C periodontitis patients have more sleep deprivation than in.
No, how do you give a underlying biological plausible
So
reason for this?
that is the limitation of my study, sir. I have only taken a sample size of 120 and the other confounding factors like systemic diseases, smoking, and they were all excluded. It's an observational study to find an association between periodontitis and sleep.
No, what I'm saying is when you found an association, then how do you give a reasoning to it? That what could be the relationship of between periodontitis and sleep deprivation?
So in sleep, there will be increase in inflammatory markers, increase in CRP, sleep deprived patients. Similarly, there will be increase in inflammatory markers in periodontitis condition also, sir.
Can you name a marker which may be affected by deprivation of sleep? One major marker which is associated with periodontitis.
Interleukin 1, interleukin 6.
More related to the sleep cycle and light. Have you heard the name melatonin?
Yes, sir.
Okay. Dr. Abhishek, over to you.
No questions from my side.
Thank you. Detective, if Dr. Varsha is through and, Valerie Shah, yeah. If her audio is okay, we can give her another chance for a rebuttal. Otherwise, we are through.
Yes.
Okay, let's check.
Yes, sir. Thank you, Dr. Vali Veluri. Tech team, can we have Dr. Valerie Shah for her question answer session for 2 minutes?
Yes, she is there.
Okay, Dr. Vallari, are you there for your question answer session?
Okay, then. If it's not so, then yeah, thank you.
Yes, sir. Thank you, sir. With this, we end our sixth session now. I express my deep gratitude to Dr. Abhishek Verma sir and Dr. Anurag sir for chairing this session. And,
thank you.
Thank you. Nice meeting you, Dr. Anurag.
Same here, Dr. Abhishek. We'll meet sometime.
Can you please send me the evaluation sheet?
Yes, sir. Yes, sir. I will send you the evaluation sheet,
Please
sir.
mail me and also the number to which we have to send it back.
Yes, sir. Yes, sir. And Anurag sir, kindly send back the email, the evaluation sheet to Subhash sir as soon as possible.
Yes, sir. So we have to send it to Subhash, right?
Yes, sir. Yes, sir.
Okay, fine. I have the number.
Hello, sir. Am I audible?
Yeah, Dr. Shah is there. Yeah.
Yeah. Am I sorry with the sir? There was some technical problem.
No issues. Dr. Abhishek, yeah, you can.
Yeah, you said once that putting your dressing, it
Yes,
prevents the post-operative infections.
Yes, sir.
So can you justify that?
Sir, mainly it reduces any salivary contamination or through any food particle or debris by shielding the site as a dressing when it's given.
So then this would have been a mandatory. In West they don't use a dressing pack. So it is not a mandatory to put a dressing pack after periodontal surgeries.
Yeah, sir, there are various controversies going on. So some authors support the use of application of surgical dressing, and some are do not advocate the use
So
of.
that is what I'm asking. So what is the rationale for using it? Why do we use here? Is in Asian continent or in India? Why do we use?
Sir,
as compared to West?
Yes.
Since it does not aid into the healing process, it does not aid into any other additional qualities of wound healing. So why do we go for putting up a dressing after periodontal surgeries?
Sir, mainly there are various rationales like it improves it accelerates the healing by protecting the surgical site, and also like it prevents a trauma which occurs during mastication, and also it is used for like it reduces post-operative hemorrhage.
Okay, fine. Dr. Anurag, you can do this.
Thank you. So you belong to the other side of the team which postulates the use of pack, right, Dr. Shah? Okay, what I wanted to ask you, see, in your objective, one point was to assess the aesthetics, right?
Yes, yes, sir.
But you have done the surgeries on the posterior quadrant, both one on the upper and one on the lower.
Yes, sir. Yes, yes.
So that
yes.
does not qualify for assessment of aesthetics, number one.
Yeah.
Number two,
Yes,
you
sir.
are caught between a case report and a pilot study. You are trying to assess with something and with the help of a single case. Okay.
Yeah, sir.
So you're
Actually, it was
confused
converted
between
into a case report thing. I was to present as a study, then it was converted as a case report. So I added a case in it, which was recently done.
So that's what I'm saying. You make up your mind what you want to do. So this could, if this is a case report, present it as a case report. If it is a study, present it as a study. Okay. Thank you.
Yes. Yes.
Thank you, Dr. Valerie. And
Thank you,
also, I
Dr.
extend my thanks to Dr. Abhishek Verma sir and Dr. Anurag sir.
Thank you once again, ISP and the tech team. Fantastic job. Thank you, Dr. Abhishek. It was nice sharing the platform with you. Sometimes we'll meet up again in Patna.
Definitely.
Okay?
Same here.
Thank you.
Okay. Bye-bye.
Can we log out now?
Yes, sir. Yes, sir.
Yeah. Thank you.
Thank you, sir. So with this, we can now begin our 7th session. First, I may introduce our chairperson for the session, Dr. Sheila Kumar Gujari, ma'am. She is professor of Department of Periodontology, JSS Dental College, Mysore. Along with her is Dr. Kaushik Patnaik. He is reader from SCB Government Dental College and Hospital, Cuttack, Odisha. Welcome, ma'am. Welcome, sir. Ma'am, your audio is mute, ma'am.
A very good afternoon. And,
good afternoon, ma'am.
Thank you for the introduction.
Yes. Good afternoon, sir.
Yes, hello, ma'am. Good afternoon. And good afternoon to the ISP team.
So shall we begin with the session?
Yeah, please get started.
Yes. The first presenter of today's session is Dr. Fatima Teresa. Can we have her presentation?
Yes, sir. Can I start, sir?
Yeah, sure.
Yeah. Good afternoon, sir and ma'am. First of all, heartfelt greetings to all the delegates on the panel. I'm Dr. Fatima from GDC Trivandrum. I'm here to present my poster, which was a study conducted in our department, which is a clinical trial on the efficacy of diode laser as an adjunct to scaling and root planing in the management of chronic localized periodontitis compared to conventional scaling and root planing. Non-surgical mechanical periodontal treatment is the gold standard of periodontal therapy, as lasers can achieve excellent tissue ablation with strong bactericidal and detoxification effect. They are one of the most promising new technical modalities for non-surgical periodontal treatment. As rightly pointed out by Dr. Rashmi Hegde on the importance of laser in periodontal therapy, which was one of the initial sessions, they can be effectively used as an adjunct, but not so much as a monotherapy. Various studies have been conducted in this field by Yukna et al., Romanos et al., etc. Now, especially in our current clinical scenario, where minimally invasive techniques are favored, lasers have come up as a blessing in disguise, and soon lasers will become an irreplaceable part of periodontal therapy. So the aim of the study was to determine the efficacy of application of diode laser of wavelength 940 nanometer as an adjunct to scaling and root planing as compared to SRP alone in treatment of chronic localized moderate periodontitis. The sample size came up to around 60, but patients were lost due to follow-up, and 3 patients were lost to surgical treatment after that. Hence, 52 patients were included. Group 1 were cases where 28 subjects were subjected to scaling and root planing along with laser curettage with diode laser. And group 2 were controls where 24 patients were subjected to scaling and root planing alone. In brief about the methodology, the study design was a single blinded randomized controlled clinical trial of 1 year. And the parameters that were studied were probing pocket depth, gingival index by means of low and stillness index, plaque index by stillness and low. And the study subjects were patients who came to the OPD of Government Dental College Trivandrum with chronic localized moderate periodontitis. Now, coming into the results, based on the 3 parameters which were checked, all the 3 parameters, that is probing pocket depth, plaque index, and gingival index, showed a very highly significant reduction from baseline to 1 month, 2 months, and 3 months and 6 months, which were the readings which were taken. So basically 5 readings were taken. Coming into the discussion, the Pleasant clinical trial showed a significant reduction in PPD from baseline to 1 month when compared to SRP alone. The study also statistically showed statistically significant difference in the mean gingival and plaque index, and these results were in accordance to studies by Sacklam et al. In 2014 and Icol et al. In 2011. So to conclude, diode lasers as an adjunct to SRP was more effective in reducing probing pocket depth and gingival inflammation as compared to SRP alone. So basically, as an adjunct, diode laser can be used, but not so much as a monotherapy. This is the same conclusion that was came here. Thank you, sir.
Yeah, the diode laser, you have used only the clinical parameters to evaluate the efficacy. Could you have used something else, some other parameters?
No,
apart
ma'am,
from
three parameters were checked.
Yeah, would it have been better if you had used some other parameters?
Yes, surely, ma'am.
So what parameters you could have checked apart from your clinical parameters? With SRP itself, there will be improvement.
Yes, ma'am.
Isn't it?
Yes.
So yeah, how can you say that it's just the adjunct use? In what way it was better compared to your SRP when you used it as an adjunct?
Ma'am, it was found that inflammation reduced to a more extent and healing was promoted. And basically, invasive procedures like flap surgery, which would have been followed after a moderate periodontitis patient scaling and root planing, was not done. So mainly patients who are mostly immunocompromised or has other issues in which surgical treatment cannot be done, lasers have become a very good adjunct, ma'am.
Yeah, but yours was a healthy group, right?
Yes, ma'am.
Yeah, so what I'm trying to say, what were the benefits of your laser over just conventional?
They could actually probing pocket depth, gingival index, and plaque index, which were checked in the study. They showed highly significant reduction based on between cases and controls.
Yeah, what I'm trying to say, in what way did the laser help in giving a better result?
They promoted, basically, they have 2 main mechanisms. Inflammation was reduced and it had more bactericidal effect, rather than just scaling and root planing.
That's what, if you had used some microbial
Yes, that would have
you would have been able to assist.
Yes, sure.
Okay, over to you, Dr. Kaushik.
No, ma'am, it's okay. I mean, we can go ahead with the next topic. Thank you.
Thank you, sir. Thank you, ma'am. Thank you, Dr. Fatima.
Thank you, sir.
We can have the next presentation by Dr. Krishna Chaitanya.
Good morning, respected panel members. My name is Chaitanya. Today I'm going to present my post presentation on comparison of analgesic and anti-inflammatory properties of aceclofenac and arnica montana as a post-operative medication. It is important to choose the safe and effective analgesics in the management of post-operative pain is a challenge to the periodontist. Aceclofenac is considered as a safe analgesic with minimal side effects, but it has some disadvantages like altered taste sensation, constipation, and diarrhea. To overcome this, homeopathic medication is considered. My objective is to evaluate the analgesic and anti-inflammatory properties. In my study, we have a sample size of 24 patients, which they're with the split mouth quadrants, and with patients with in between of 20 to 60 years. These patients were selected under the criteria who were included for a periodontal surgery. These patients were randomly assigned to each surgeon, and then their respective quadrants have been surgery has been done. After the surgery, some patients have been assigned for an aceclofenac and others have been assigned for arnica montana. For first 8 hours, the patient were asked to take the same amount of medications, that is 3 tablets for every 8 hours. Followed that, the patient were asked to take the medication according to the pain perception. Coming to the results, both the arnica montana and aceclofenac showed similar results in terms of visual analog scale and wound healing index, but the patients are more inclined towards arnica montana, and this arnica montana group has showed a better healing when compared to the aceclofenac. My conclusion is that both the medications showed comparable results in both anti-inflammatory and analgesic activity, but the arnica montana is comparatively a little bit more desirable than aceclofenac with a minimal side effects.
Yeah, what is arnica montana?
Madam, arnica montana is a homeopathic medication, madam, which is used for post-operative medication like anti-inflammatory and analgesic, madam.
Yeah, but what are the contents of it?
The drug itself is the arnica montana, madam. It usually in periodontal studies it is used as a tramal in other studies, madam. It is a chief ingredient in that medicine, madam.
So what type of study was it? Did you do a crossover study or a parallel study? What type of study was it?
It's a randomized split mouth study, madam.
Split mouth?
Yes, madam. For a surgically treated patients, madam.
Yeah, but what was the duration between both the surgeries?
We given a duration of 2 weeks, madam, in between for each surgery.
Okay. Over to you, to Dr. Kaushik.
Yes, ma'am. So which NSAIDs is considered to be, having highest anti-inflammatory property? And why did you choose aceclofenac?
Aceclofenac is considered to be a less side effective than any other NSAIDs compared to others. So I went for it aceclofenac.
But side effect is one of the components. But if you are going to compare some agents with the gold standard, then why did you choose aceclofenac and not any other NSAIDs which are having more anti-inflammatory property than aceclofenac?
This was already compared with ibuprofen, sir. So on that basis, I took aceclofenac.
Okay. So because the study was previously done, so you have done with aceclofenac.
No, sir. In that previous study, they used a tramal drug, which is a combination of so many other homeopathic drugs, sir. But in this, only that I have took the chief ingredient, arnica montana.
Okay. Okay. Thank you.
Okay. Thank you, Dr. Krishna Chaitanya.
Thanks.
We can have our next presentation by Dr. Neeruja Lambe. Dr. Nirucha, are you there? Yes, you can speak, but your voice is very feeble.
Fix your earphone properly. Your sound is not coming, doctor. It's still not audible.
Dr. Nirucha, you are not perceptible. Please kindly talk loudly.
Hello.
Hello, doctor.
Hello.
Yes. Yes, it is audible, still feeble.
Hello.
Yes, you can go ahead.
Good afternoon, everyone. My topic for today is assessment of the oral hygiene of a chronic gingivitis patient before and after scaling using a mobile-based app as a motivational tool compared with other tools, and it is a randomized control trial. Mm, uh, Microbial dental plaque is primarily responsible for inducing and progression of the periodontal disease. Hence, patient's motivational plays an important role in pursued dental competence and treatment seeking behavior. Objectives for my study was to assess and compare the oral hygiene of chronic gingivitis patients using mobile app and conventional methods before and after scaling. 90 patients of the age of 18 to 45 years were selected with a chronic generalized gingivitis and divided randomly into three groups. The 30 patients motivated by an oral hygiene instructions and a written instructions. 30 patients, the group B patients were motivated by an audiovisual aids and oral hygiene instructions. Group C patients were given a mobile dental app. After 1 month of follow-up, they have given a questionnaire was given for all the patients. Total 21 questions were asked to all the participants, out of which 6 questions were only intended for the group C patients, which was a mobile app group. After 1 month of follow-up, oral hygiene status were recorded for all the patients. The plaque index for the plaque index for group A patients were same as it was for pre-op. For group C patients, it was reduced, and gingival index and gingival plaque index and gingival bleeding index for group A patients was 42.4 before 1 month, and after 1 month it was 29.69. For a group B patient, it was 39.6 and reduced to 30.94. For a group C patient, it was 35.83 before and reduced to 26.8. In conclusion, these were the results of the study. This questionnaire was asked for the all the patients. Coming to the conclusion, results indicates that a mobile app is promoting tool to motivate and evidence-based oral hygiene to the as compared to the conventional methods. Hello.
Yeah, which was the mobile app that was used? What is
I
the name of
used
the app?
Brush DJ app. It gave the timings for brushing, like 2 minutes timer was kept for the brushing, and it will remind the patient to brush twice daily.
So what about the method of brushing?
In that app, methods of brushing were demonstrated. That was inbuilt in that app. Like persons can see, like patients can see the videos of how to brush with a correct technique.
Yeah, but there must be a particular technique that was there in the app, because each person will be using even. So did you teach any technique for the other group which was not using the mobile?
To all of them, I have taught the modified bars technique, ma'am, because they were the gingivitis patients.
Okay, over to Dr. Kaushik.
Yes, ma'am. So, so among your, clinical parameters, which among your clinical parameters, which of them showed any significant changes? Was there any significant changes between the groups?
Group which was an app group, they have showed a gingival bleeding index significantly.
The reduction in gingival bleeding index.
Reduction was good in gingival bleeding index.
And what was the questionnaire about? What were the questions that were asked to the patients?
Total 21 questions were there, sir. In that, last six questions were only for the app group patients. In that, they were asked like, is the app useful for the brushing the tooth? They got motivated. Will they recommend the same motivational tool for the other patients? Like that questions were asked.
Okay. Okay, thank you.
Thank you, sir.
Okay, thank you, Dr. Niruja. Next presentation is by Dr. Rudra K, Dr. A. Swatipriya, and Dr. A. S. Udhyaya.
Yes,
Dr.
sir.
Rudra, are you ready with the presentation?
Yes, sir.
Okay, you can proceed now.
Good afternoon, all. My poster topic is on comparison of severity of dementia and chronic periodontitis patients with and without diabetes, which is a cross-sectional study. So, introduction: dementia is a syndrome of cognitive decline with diabetes as one of the risk factor. Many studies have related periodontitis and dementia, which is due to bacteremia. This study was done to ascertain whether diabetes furthermore additionally increases the severity of dementia in chronic periodontitis patients. The aim and objective was to compare the severity of dementia in chronic periodontitis patients with and without diabetes using mini-mental status examination scale. So the methodology: patients were divided into two groups, in chronic periodontitis group and with diabetes group. Each had 100 patients who were included by inclusion criteria, and the mini-mental status examination scale used in our study was proposed by Paulstein in 1975, which is a 13-point questionnaire-based study, and the scores are given according to the questions answered by the patients. So the results we got according to statistics used is chronic periodontitis group had 60% of mild degree of dementia, whereas the diabetes group had moderate degree of dementia, indicating the severity has been increased in the diabetic group. And the statistical analysis used also have given significant results in both the MS-ME scale, and the number of teeth present, which is recorded in our study, has also given significant results. So discussion: the duplex way between dementia and periodontitis, which was related by Rizwan Nadim et al. In concordance with these results, mini-mental state examination and tooth loss was considered with cognitive decline. And the bidirectional link between diabetes and periodontitis, which is due to advanced glycation in products and pro-inflammatory mediators, explained by Robert J. Jenko and David Pollock et al. So, in concordance with these facts, in our study also had increased incidence of periodontal disease in diabetic patients. The bifacial way to diabetes and dementia is explained by risk factors like neuroinflammation, oxidative stress, mitochondrial dysfunction, which both synergistically increased the dementia and diabetes, explained by Musu et al. And Chengard et al. So with this evidence, the current study also displayed the cognitive impairment in diabetic patients. So with these results, our triology has been established, but the limitations of sample size was small and the accurate rigor of tooth loss was not known. So many follow-up studies are needed for contribution of the above results. So concluding, several literature have revealed the amalgamation between dementia and periodontitis, but this study adds up the severity of dementia and forthcoming evangelism in chronic periodontitis patients with diabetes. Hence, the trial should be treated in a well-planned manner for the healthy living of the patients.
Yes, doctor, this dementia that you said, that is there any scale that you used? What was the scale that you used to grade the dementia?
It's mini mental status examination. It was proposed by Falstead in 1975.
Can you explain the scale?
Ma'am, it is a 30-point questionnaire-based scale, ma'am, which relates, the questions is based on orientation, linguistics, and the recall memory for the patients, and the questions are related to such topics, ma'am.
So where did you check on the duration of the diabetes, like how long they had been diabetic and what type of medication they are on? Did you standardize that?
Ma'am, we have taken the diabetic who with the 5 years with diabetic, ma'am, based on the blood glucose level, HbA1c level, we have included in the study.
Yeah, that's what. So was does the duration play a role on the dementia, the duration and the medication that they are on, or how did you compare, and why? Yeah, so what have you concluded out of that?
We have concluded that diabetes, with the history of diabetes and patients who are uncontrolled with unstable diabetic conditions, the dementia chances are increased. Since this is an observational study, we couldn't meet for the exact pathophysiological mechanisms.
So this was, how long was the study conducted?
3 months.
3 months. So no neurological component was checked?
No, ma'am. Only the scale has been used.
Okay. A good presentation.
Thank you.
Okay, I mean, we can go to the next one, next topic. Thank you.
Okay, thank you, sir. Thank you, doctor, for your presentation. Our next presenter is Dr. Nageshwaran GR.
Good evening, sir. Is my voice audible, sir?
Yes, it is audible.
Okay, shall I start, sir? Yes.
Yes, yes.
Good evening, everybody. Today I'm here to present my poster on my research topic, the diode laser, the master of periodontal healing. It is hypothesized that laser exposure of root surfaces provides bactericidal as well as detoxification effects, and hence aids in smear layer removal, thereby aiding in connective tissue reattachment. So what was here in our study was to analyze the modulatory effect of diode laser of wavelength 880 nanometers on enhancing fibroblasts reattachment to root surfaces and used as an adjunct to scaling and root cleaning. What we did was we selected eating single-toothed human teeth that were sectioned longitudinally after the crowns were removed, and these root specimens were divided into 3 different groups. Group A, wherein scaling and root cleaning was performed with crazy periods number 3 and 4, and then Group B, wherein in addition to scaling and root cleaning, we exposed them to diode laser of 880 nanometers. The laser exposure was done with a frequency of up to 1 Hz, power of 0.6 watts for a duration of up to 10 seconds in a non-contact and pulsed mode. And then in Group C, wherein untreated samples, no interventions were given. All the 3 groups of samples were stored in an antiseptic media in separate vials and then transported to the laboratory, wherein quantitative analysis was performed using MTT assay. So in order to ensure that there is no loss of viability of the cells, and then there is uniform growth of the cells throughout the study period, the 4th group, Group D, under which positive controls were set up, wherein the cells were allowed to grow by themselves without adding the teeth specimens, and then the number of cells which are the cell growth was assessed quantitatively under a light microscope, and bright field images were captured on day 3 and on day 5. The number of cells were counted, and the mean count was calculated. Statistical analysis was performed using only ANOVA to compare the mean values between the groups and within the groups, and then Tukey's post-hoc test was used, and then a graphical representation was made wherein the mean number of cells was plotted against the time, and it was observed that group B, that is positive controls, there was uniform growth of the cells throughout the study period, thus ensuring that there was no loss of viability of the cells. And among the 3 study groups, it was observed that there was a cell attachment in all the 3 groups, slightly better outcomes observed in the laser treated group, that is group B. However, we are conducted this study with a limited number of samples in order to assure that fibroblast reattachment is enhanced by diode laser exposure. Studies with a larger number of samples are required. To conclude, diode laser, when used as an adjunct to scaling in root bleeding, favor fibroblast reattachment to root surfaces, and hence provides an added effect on improving the prognosis of the tooth.
Dr. Kaushik, you have any questions?
Yes, ma'am.
Yeah, please go ahead.
So you divided your study into 4 groups, right?
Actually, we had set up 3 groups, sir. The 4th group was set up by the laboratory personnel. It means only the cells were allowed to culture with themselves without adding the teeth specimens. That is a positive control.
Okay. So how many teeth did you take in each group? 18, something like that.
The number of teeth samples if we collected were 18, and then we divided each each sample was divided into 2 sections longitudinally. So 18 into 36 we got, 12 in each group.
Okay. So you saw the maximum growth of fibroblast in the laser group.
Yes, sir. All the 3 groups showed laser reattachment with slightly better outcomes in the laser treated group.
Okay. So it's a nice study. I mean, you should have. You should go ahead with a larger sample size and see what are the outcomes.
That's what we have planned, sir. That's what we have planned.
Okay. Thank you.
Thank you so much, sir.
Yeah, good presentation. So I hope you will carry on with the study.
Sure, madam. Sure. I'll go ahead.
Okay.
Thank you, Dr. Nageshwaran. We can now move on to our next presentation by Dr. Mahendra Kataria.
Hello, am I audible, sir?
Yes, you are audible.
Good afternoon, sir.
You
The
can
title
start
of my poster presentation is to evaluate. Yes, sir. To evaluate the relation between the psychological stress and periodontal health in traffic police of the Ahmedabad city, and it is a cross-sectional study. And the psychological stress is thought to play an important role in the etiology and the progression of the periodontal disease and the outcome of the treatment in individuals as a traffic police, which are tend to be under the stress are due to the hectic duty and the longer working hours. The aim of this study was to evaluate the relation between the psychological stress and the periodontal health in the traffic police out the 6 different zones of the Ahmedabad city, and the total sample size of this study is to, are 240 participants, and I divide the 40 participants for the each are different zone, and the periodontal status was assessed by the CP-18 index, and the stress was assessed by the perceived stress scale. The results out of 240 participants, 45.83% were tobacco chewers, and 35.41% were pan masala chewers, and 31.25% were smokers. And when assessed, 34.58% participants were stressed, out of which 91.25% has a participant had periodontal disease. So we can say the direct correlation was seen between the perceived stress scale and the periodontal status of the participants. When checked for the participants, both stress and periodontal disease, it was found in the individuals. The total scores were highest in the west zone, followed by the new west zone of the Ahmedabad city, and it was seen least in the south zone. The conclusion of my survey study, this stress can have a direct effect on the periodontium. The traffic police, due to their a longer duration of the duty hours, which are tend to be under higher stress, which leads them to inculcate the various deleterious habits which disturb the periodontal health.
You have assessed the psychological stress using only the questionnaire, or did you use any biomarker?
No, ma'am. Only T1 questions which are included in the perceived stress scale.
Why didn't you add some biomarker? What biomarker could you have used to evaluate the stress? Are there any biomarkers that can be used to evaluate stress, the most common biomarker?
Cortisol levels, ma'am.
Yeah. Apart from cortisol, are there any other?
Sorry, ma'am. I don't know others biomarkers.
You could have used even a salivary amylase. And how does it actually affect the stress? How does it affect the periodontium? Okay, that's fine. Good presentation. I'll ask Dr. Kaushik to ask if he...
Yes, ma'am.
Yeah.
So can you name some pioneers who have devised some models relating stress to periodontal diseases? Some pioneer scientists. The models relating stress to periodontitis.
No, sir, I don't.
Okay, so you said that 34.5% 34.5% of the population had had stress, and among them 91% had periodontal disease. So so what about the rest of the population, which were who were not stressed? Did you find any periodontal disease? The percentage of periodontal disease in those population?
As
who were not
very less individuals are stressed but not having the periodontal disease.
So you did not find a percentage, but you had a rough idea about it.
Yes, sir. Yes.
Okay, so so you should have found the percentage from that group of population as well. So it would have been easier to compare.
Yes, sir.
Okay, thank you.
Yes, sir. Thank you, sir.
Okay, thank you, Dr. Mahendra. We can have our next presentation by Dr. Danish Kindri.
Sir, am I audible?
Yes, you are audible. You can start now.
Good evening, respected faculty and my dear colleagues. Today I am presenting a poster on the topic comparison of open flap debridement versus closed flap debridement along with diode laser, a clinical radiographic split mouth study. Now, the main goal of periodontal therapy is to eliminate the pathogenic microbial species that cause or sustain the periodontal disease, halt the inflammatory process, and restore the connective tissue attachment and alveolar bone loss. Now, SRP is regarded as a gold standard of the periodontal therapy, which decreases the periodontal pathogenic bacteria, but unable to obtain a complete eradication of these microorganisms and their systemic spreading. Now, the persistence of periodontal pathogens especially the like P. gingivalis, aggregative bacteria, actinomycetum comitans, capnocytophagia, fusobacterium nucleatum, hidden in the gingival tissue, contributes to recurrent periodontitis, as it allows them to escape the host immune reaction and resist antiseptic or antibiotic treatment. So we will try to find out which one's better, whether we need to rely on conventional open flap debridement along with SRP, or there is something magical about this diode laser, which with its minimum invasiveness can give us promising and favorable results. So 5 patients between the age of 20 to 50 of either gender having a probing depth of more than 4 mm were selected for randomized split mouth study. So as in this case, mandibular arch was selected for an open flap debridement. So after anesthetizing the area, intraclavicular incisions were placed, flap was reflected, and granulation tissue was removed, and the root surface was thoroughly scaled and planed, followed by the placement of the interrupted suture. Then, inspired from the article published by Ginali et al. In the year 2012, a combined PAPD approach was incorporated for the maxillary arch after SRP. So day 1 over here represents the phase 2 treatment after SRP. So the fiber tip was placed at the depth of the pocket minus 1 mm to avoid any undue contact with the epithelial attachment at the base of the pocket, and the fiber tip was moved at a speed of 2.5 mm per second in order to avoid any undue gingival tissue damage. And the diode laser worked at a principle of hot tip technique, as because of its low tissue penetration, it causes minimum invasive damage to the underlying lamina propria. Then after that, on next clinical session, photodynamic therapy was introduced at the same wavelength, that is 810 nanometer, as we did in case of photoablation. So only difference between the two was the power mode. Photoablation was done at 1 watt power, rather than PDT was done at 100 milliwatt power. Then a dye named indocyanine green was introduced into the gingival sulcus with the help of 27 gauge needle. Then after 60 seconds, laser was irradiated with the help of fiber tip and was moved circumferentially around the tooth for 1 minute. So periodontal parameters were reevaluated after 3 months, just like we did at the baseline. So as we can see, there was a significant improvement in all the periodontal parameters. So not only we can conclude that it can be used as an adjunct to the open flap debridement, but it can also be used as an alternative to the open flap debridement. Not only periodontal parameters, even in the terms of radiographs, we can clearly see that the radiograph of group 2 after the laser therapy, there was a significant improvement in the radiographs because of the suspected biostimulatory effect.
Hands up.
Ma'am, do you have any questions?
Yeah, you're saying basically your treatment was a photodynamic therapy, isn't it?
Ma'am, a combined treatment inspired from the article from Ginali et al. In the year 2012, a combined PAPD approach was used to treat the patients of chronic periodontitis. First of all, we used the photoablation mode, and then after a week, we used
no, the thing is, you're using so many modalities of of treatment. See, first you're saying it's a diode, then you say it is combined with photodynamic. Okay, fine. Photodynamic involves diode will be there, a low-level laser you'll be using, and the dye. Okay, so that is you should be clear about that and why you have used it as a split mouth. Why did you prefer to do a split mouth? And
in order to eliminate the intersubject variability, like as we know that moreover, with the help of split mouth study, we can even restrict our cases to a minimum level and get equivalent results with low number of studies.
Yeah, but then how did you randomize? What was your method of randomization?
Ma'am, the maxillary arch was randomly selected in case of, and the maxillary or mandibular arch was randomly selected in all the different patients. So it wasn't like a compulsion that we have to do like photodynamic therapy and photoablation in cases of maxillary arch only. It was a randomized approach.
No, means what method? How did you decide that this maxilla, it's this side of the maxilla is going for photodynamic and the other one is going for conventional? How did you?
Ma'am, it was a lottery method.
Lottery method. Okay. Fine. Then how did it? How did you say that it affected the radiographic parameter? How did it help in the radiographic parameter?
Ma'am, the low level lasers work at a wavelength of 635 nanometer to 930 nanometer. So what low level laser does, it works on the principle of biostimulation. So according to anti-Schu's law, so lower the stimulus, more the positive the response you will get from the tissues.
Fine. What other dyes could you, what are the other dyes that are there that can be used for the photodynamic?
Ma'am, toluidine blue, chlorine 6, methylene blue, curcumin, and e-chlorine, and so on.
Can they be used in medically compromised people like diabetic patients?
Yes, ma'am. It's a safe drug. It works at the principle of activation of the diode laser, in which on activation, the reactive oxygen species are generated, which specifically targets the microorganisms like the hidden ones, P. gingivalis, Tenirella forsythia, Treponema dendricola, Capnocytophagia, aggregative actinium components. There are so many.
Okay, good. Over to Dr. Kaushik.
No, ma'am, it's okay. No more questions, and very well presented. Danish. So thank you.
Thank you, Dr. Danish. It was really a well presentation. We can now move on to our next presenter by Dr. Jocelyn Kaur.
Good evening, everyone. Am I audible?
Yes, you
Am
are
I
audible.
audible?
Yes, yes.
Okay. Today's topic of discussion is depression, which is considered to be a silent culprit in the development of the periodontal diseases. As we know that initiation and propagation of the periodontal disease is mainly through the dysbiosis of the commensal oral microbiota, which then interact with the host immune system, leading to gingival inflammation and periodontal breakdown. But there can be certain modifiers in this which called as a risk factor. Among them are the diabetes, cardiovascular diseases, and the stress. The stress or the depression, they can modulate the activity mainly by the two ways, by the modification of the patient's oral hygiene habits as well as the modification of the hypothalamus pituitary axis. When we compared two groups, systemically and periodontally healthy patients with the patients suffering from the chronic moderate periodontitis, the two parameters were taken for the periodontal parameters, the oral hygiene index and the pocket probing depth. And to assess the depression, we took the Beck's inventory depression questionnaire. The study revealed that the cases, the subjects who were having the periodontitis, who were depressed, they were having the significantly high pocket probing depth as well as the OHIS index, and the Beck's depression inventory score was more in them. The probable result was because when there is a stress, there is an activation of the hypothalamus pituitary acid, due to which there is a release of the glucocorticoids, mainly cortisol, which cause the depression in the immune system, as well as it causes the decrease in the recruitment of the inflammatory cells at the site of inflammation, decrease in the circulatory number of them, as well as decrease in their function, the chemotaxis, the phagocytosis. Also, there is a modification of the patient's oral hygiene habits. The patient tend to neglect their oral hygiene. The brushing and the mouth usage frequency, as observed in the study, was also less. This is mainly due to because the patients who are depressed, they have lack of initiation and they tend to neglect their oral hygiene activities. Apart from them, patient, they may also develop the neglectful habits, like they can be intensification of the smoking, alcohol abuse, and they can be effect from the depression medication. The smoking and the alcohol abuse, they not only alter the immunity, but smoking also has effect on the gingival microvasculature, on the fibroblast activity. And in case of the alcoholism, it can cause the dehydration, can induce the xerostomia, and which can be further exacerbated if the patient is having the antidepressant medication, due to which there can be excessive accumulation of the plaque. There can be an excessive accumulation of the plaque and biofilm, and this which can again patient neglect to eliminate. These studies, they are in favor with the certain studies, like Genko et al. In 1999, he gave models to evaluate the stress. Then there was a study by the Rosania in 2009, the study by Friedman and Goss in 2000 in 1993, and Linden GJ in 1996. They compared the occupational stress with the periodontal parameters. Then there are various studies which support the that the patient they neglect the oral hygiene, like Jim Carvin study, and they showed that the patient, mostly the depressed patient, they mostly neglect their oral hygiene habits.
Ma'am, sir, you can go with the question answer.
Depression, how did you say the person is depressed, or what? Yeah, what is the scale used? How did you measure the case, and is it in a particular group?
Ma'am, we use the back inventory depression questionnaire, according to which we have 21 questions, and from them the rating is decided. If the patient is having at least 17 score, then he is called to be the depressed. If the patient scores from 1 to 10, then there can be mild moderate disturbances of the mood, which are quite acceptable. If the patient is having more than 17, from 17 to 20, that is a borderline depression. From above 20 to 30, there is an extreme depression. From 30 to 40, there is a severe depression.
So did you see it in a particular group, or how did you study this?
Ma'am, we took the two groups. One were the pedontally and systemically healthy patients, and the other patients included the patients of the chronic moderate periodontitis. And we excluded all other conditions like which could affect the mode of the periodontitis, like diabetes, hyperthyroidism, hypertension, osteoporosis, or any patient who had undergone the periodontal therapy. And in them, we took analysis of depression, and we found that as the severity of the depression was increasing, the grade of the periodontitis was increasing in them.
So what you meant is the OPD patients are the ones that you have taken into consideration, the normal patients who are walking into your department?
Yes, ma'am.
Yeah, so then like how will you say whether it is apart from the scale, is there anything that can say that it is different from sadness that they are experiencing, whether it is depression or is it sadness?
Ma'am, there were certain patients who had some major life events or the major life activities they have undergone, due to which like they can be in a financial crisis, they can be any personal crisis, or they can be suffering from there can be some students who can be suffering from academic stress. All this stress, even if it's not a complete depression, which is a major depressive episode, even the stress is activating the same hypothalamic pituitary axis, due to which it can increase the severity of the periodontitis.
Yeah, but there might be other cofactors which lead to the periodontitis. It's not only depression. So how did you try to exclude those?
Ma'am, we excluded the other conditions which can modify the pathogenesis. There can be other systemic conditions there can be osteoporosis, or there can be hypertension, hypothyroid, all those such conditions which could modify the effect, they were excluded.
Fine. Dr. Kaushik?
Yes, ma'am. So have you come across any studies assessing the effect of antidepressants on periodontitis?
So yes, there was a recently studied which was published in Journal of Indian Society of Pedontology. According to them, if patients they are given the antidepressant, we can control, because there is a bidirectional relationship between the periodontitis and depression. If the patient is suffering from depression and he developed the periodontitis, then it can increase the depression of the patient. From the psychological isolation, patients suffer, like example from the tooth loss or the halitosis. So if we give them the antidepressant, we can control the depression, and which could more, because it will decrease the inflammatory markers, so it can decrease the severity of the periodontitis.
Okay. But this bidirectional relationship has not been established till yet. But
Yes, sir.
they have shown some initial studies. Okay.
Yes, sir.
Okay, thank you.
Thank you, sir.
Thank you, Dr. Jocelyn. We can have our next presentation now by Dr. Nitish J. Kanoi.
Good afternoon. Topic for my poster presentation is comparative evaluation of clinical efficacy of tetracycline fibers and diode laser as an adjunct to scaling and root planing in treatment of periodontitis. Introduction is the conventional method of scaling and root planing is a gold standard procedure for periodontitis. Bacteria invading the periodontal connective tissue cannot be eliminated by the SRP alone. To disinfect the entire periodontal pocket and to achieve maximum gingival healing, laser therapy or local drug delivery are successfully used as an adjunct to SRP. Aim of my study is to compare the efficacy of tetracycline fibers and diode laser as an adjunct to scaling and root planing in treatment of periodontitis. This was a randomized single-blind split-mouth clinical trial. Sample of 10 patients having at least one site in opposing quadrants with the probing pocket depth of more than equal to 5 mm. After randomization, the sites were allocated into two groups, that is SRP plus tetracycline group and laser group, that is SRP plus diode laser. Then all the treatment procedures was performed by a single operator, whereas the sulcus bleeding index, probing pocket depth and the relative clinical attachment measurement was performed by the blinded assessor at baseline and 1 month interval post operatively. After the statistical analysis was done, intergroup comparison was done by the pair t-test and intergroup comparison was done by the independent t-test. The following picture shows the tetracycline fiber and the diode laser application. After thorough scaling and the root planing, the baseline PPD and the RCal was measured with UNC 15 probe. Then tetracycline fiber application was done. After 1 month of patient follow-up, PPD and the RCal was again measured and it showed that there is reduction in the PPD and gain in the RCal. Similarly, in the diode laser application, baseline PPD and the RCal was measured. Then diode laser application was done and 1 month PPD and the RCal was measured and showed reduction of PPD and the RCal gain. Coming to the results, when compared to the baseline, there is highly significant difference was found in PPD and the RCal at 1 month interval post-operatively for both the groups, but no significant difference was observed between the groups in terms of the PPD reduction and the RCal gain at 1 month. Also, sulcus bleeding in sulcus bleeding index, there is a highly significant difference was observed at 1 month post-operatively. So these conclude that the current evidence suggests that the both the application of diode laser and the tetracycline fibers equally effective in improving the periodontal status. Thank you.
So here also you have just evaluated just the clinical parameters, and yeah, you have only the clinical parameters were used to compare the two. Is it?
Yes, ma'am.
You have used only the clinical parameters to compare both aspects of your study. Could you have used you have used only clinical parameters? Are there any other parameters that you could have used?
Ma'am, I have used only probing pocket depth, relative clinical attachment level, and a sulcus beating index.
Yeah, don't you think you should have used something else also? What is the action of doxycycline on the periodontium?
It doxycycline.
Okay, you use tetracycline fibers. What is the effect of it?
Side effects.
No. How does it improve the parameter? What is there any effect of it on the periodontitis?
Yes, ma'am. It having the anti-inflammatory effect. It act on the collagen fibers. So
okay, over to Dr. Kaushik.
Yes. I mean, I'll give you a hint regarding ma'am's question. So you told about collagen fibrils. I mean, the tetracycline action has the action on collagen fibrils.
Yes, sir.
So is there any enzyme which acts on collagen which can be inhibited by tetracycline?
It is aggregative actor actinomycetum commitans.
Any enzyme which acts
Any
on collagen?
enzyme, sorry.
Okay, so find out about it. And
Okay,
thank you.
Okay, thank you, Dr. Nitisha. We can now move on to the last presentation of this session by Dr. Sukanya Mishra.
Hello.
Hello, you can go ahead.
Yeah, good. Sir, this is not my presentation.
Okay, this is Danish Kindre's tech team.
Yes.
Anya, if you have the presentation, please share.
Okay, sir. Just a second, sir. Is it visible, sir?
Yes.
Good morning, everyone. Good afternoon, everyone. I'll be presenting a research poster on the topic fractal analysis and its feasibility to detect chronic periodontitis. So coming to the introduction, periodontitis is introduced as an inflammatory disease characterized by bone and soft tissue loss. Although there are several radiographic methods to characterize periodontitis, till now no method has been introduced for quantification of the trabecular bone present. So fractal analysis is used as a mathematical tool to investigate the complex structural pattern of the alveolar bone texture. So coming to the objective in this study, fractal analysis is examined for its feasibility to detect trabecular structure of interdental bone in panoramic radiographs of patients with periodontitis. Moving on towards the materials and methods, a retrospective study was conducted with 15 OPGs in patients with chronic periodontitis, and they were classified as mild, moderate, and severe periodontitis according to the percentage of bone loss calculated using an absolute method in the tooth with maximum amount of bone loss. A rectangular region of interest was selected, as we can see in the first image over here. And then the image was the region of interest was then blurred. And then the first and the second image was then subtracted as seen in the third image, which was then inverted to see only the marrow spaces. The binarization of the image was done so that other obstructions could have been deleted. And then the skeletonization of the trabecular structure was done to see only the trabecular bone present. And these all things were done using a ImageJ software. So in the results, we can see a correlation analysis was done to find out the relation between the FD values, that is the fractal dimension values, with the percentage of bone loss. And it could be seen a strong negative relation was present. That is, when the percentage of bone loss decreased, when the percentage of bone loss increased, there was a decrease in the fractal dimension values. So coming to the discussion, Shrout et al. In 1998 could not find any significant use of fractal dimension to compare the healthy and moderate periodontitis patient population using pixel dilation method, while Khajavi et al. In 2017 found a significant difference when fractal dimension was used to detect primary stages of periodontitis using box counting method. So coming to the conclusion, fractal dimension analysis is strongly correlated with periodontal bone loss and can be used to determine the stage of chronic periodontitis. Therefore, further research should be carried out on a large scale to investigate the intra-examiner reliability and sensitivity. Thank you.
What exactly did you mean by fractal analysis?
Ma'am, actually, when it is actually when an object is zoomed to a different level, we can see that the complexity of the structure increases. For example, if we are zooming in the bone structure, we will find that the complexity is increased. But we can also find that this, in the studies, it has been shown that this increased complexity is self-similar, although not exactly similar, but it is self-similar to the zoomed out image. So fractal analysis is to see the trabecular, or you can see the convolutions in between the zoomed images. We can see all the complexity. We can measure the complexities when we are zooming in the image. So yeah, fractal abstraction is seen. Yeah.
So is it do you have a particular software for it?
Yes, ma'am. It's image analysis is it is used. There are various plugins used in image analysis. It is a free software available in website. It can be used for many things like digital subtraction, as we are already doing it is an advanced technique in radiographic technique to see the periodontitis. So many calculations can be done, and there also FD values can be calculated, but the processing of image, pre-processing of image is required. Yes, ma'am.
So basically you take a radiograph and then you analyze using this software.
Yes, ma'am. Ma'am, actually, in a radiograph, it would be more better if we can go for CBCTs, because 3D structure can be seen and more better values can be evaluated.
Okay, so basically you go in for something like a CBCT and then you use
Yes,
this.
we can go for any radiograph, ma'am. If you are going for a study, a similar type of radiograph can be used, but CBCT is the best one till now.
Okay.
Yes, ma'am.
Fine. Good study. Over to you,
Yes,
Kaushik, Dr. Kaushik.
So you said about CBCT. Can you see any trabecular patterns in CBCT?
No, sir. Actually, the basic thing is whatever the fractal analysis, what we are doing, if we are taking the any image, any radiographic image, it is differentiating between the marrow spaces and the skeleton images. So the trabecular structure can be taken out when we are using fractal dimension. The complexity of the trabecular structure, the skeleton or the skeletonization of the trabecular structure can be done using this software, sir.
Okay, so you have taken a digital digital orthopantomograph or normal?
Digital, sir, because we can take the normal one, but if we digitize it, there will be some issues because different cameras have a different megapixels. So we can go for the digital image that has already been taken. We can take out from the radiographic. We can talk to that person and we can get the digital image. So that would be a better option. Yes, sir. The clarity will be good.
Okay, thank you.
Thank you, sir.
Thank you, Dr. Shukanya. It was a good presentation.
Thank you, sir.
With this, we came to the end of the 7th session. I express my gratitude to Dr. Sheila Kumar Gujari ma'am and Dr. Kaushik Patnaik sir for being the chairperson of this session.
Thank you, team ISP, and a very thank you to ma'am. It was amazing to chair this session with you, and I also got to learn a lot of things with you.
Thank you. I am very happy to meet you. This is the
Thank you.
first time we are having any interaction. Hope we have in future. And yes, thank
Sure.
you to the ISP for giving us this opportunity. Thank you.
Thank you,
Thanks for
ma'am.
the organizers. Thank you once
Thank you,
again.
ma'am. Thank you,
Bye.
sir. A gentle reminder, ma'am and sir, to send the evaluation sheet as soon as possible, ma'am, because the validity function is at 5 p.m.
Yeah, sure. Of course.
Thank you, ma'am.
Okay,
Thank you, sir.
Bye.
We can now start our 8th session. I may introduce the chairperson of the session. Is Dr. Manoj Kumar. He is the reader from Institute of Dental Science, Bhubaneswar, Odisha. Along with him, he is Dr. Saurabh Panda. He is professor of Institute of Dental Science, Bhubaneswar, Odisha. Welcome, sir. Hello, Manoj sir, Saurabh sir, welcome, sir.
Thank you. We can start.
Yes, sir. So we can start with the session. Our first presenter is Dr. Mahavish Khan. Can we have his slide?
Yes. Am I audible to everyone?
Yes, you can start now.
Yeah. Yes, a very good evening to all of you. Today's the topic of presentation is a short study done to evaluate and compare the efficacy of tetracycline fiber and dyed laser in management of chronic periodontitis. It was a clinical and a microbiological study. So the background behind selecting this topic for a study is that the laser is less invasive and provide less discomfort to the patient, and also the bactericidal and detoxifying effect of the diode laser during non-surgical periodontal therapy has been documented so far. Also, laser can advise better tissue ablation with strong bactericidal and detoxifying effects. And moving the tetracycline has a bacteriostatic effect and has proven effective against a gram positive as well as gram negative anaerobic microflora associated with periodontitis. So moving on to the aim and objective of the study is to evaluate the effect of dyed laser decontamination followed by the placement of tetracycline fiber as an adjunct in the management of chronic periodontitis. Moving on to the materials and method, the inclusion criteria were the mild to moderate periodontitis of a patient with age group of 20 to 50 years and the pocket depth 4 to 7 mm and clinical attachment level less than 4 mm. The exclusion criteria was the patient who are systemically ill and was at antibiotic for last 6 months. It was a randomized plate mouth study conducted on 15 patients. The test group the diode laser decontamination was done by using the diode laser of wavelength from 810 to 980 nanometer wavelength. The fibers were moved apical to coronal direction for 20 seconds into the pocket and followed by the placement of tetracycline fiber. In control group, only the placement of tetracycline fiber was done. So the clinical parameter were assessed before, at baseline, and after 3 months were the plaque index, gingival index, probing pocket depth, and clinical attachment levels. Simultaneously, the microbiological analysis was also done for colony forming units. So these are the images showing the clinical parameter, the clinical photographs and the microbiological images. So that at baseline, the intraoperative, how the laser were used, and then the placement of the tetracycline fiber, also the 1 month and 3 month clinical pictures, follow-up pictures. So the result we found was both groups demonstrated a statistically significant improvement in parameters from baseline to 3 months, and also at 3 months, no statistically significant difference were found in between the test and the control group. This suggesting that adjunctive use of laser did not seem to have any added effects. So moving on to the discussion part, there has been various studies has been done to evaluate the substantiation of the tetracycline fiber as a local drug delivery agent against the positive and negative bacteria, and likewise the laser has also been evaluated. So this the results of the study done by were in accordance with a study done by the Duque et al. And the Mortis et al., which have shown which have not shown any significant improvement by laser application. Okay.
Sir, you can start with question and answer.
Yes. Dr. Mahavish.
Yes, sir.
Am I audible? Yes.
Yes, sir.
What gingival index and plaque index did you use?
The gingival and plaque index given as given by low and thinnness and those.
So you use the thinnness and low.
Yes, sir.
For the plaque index?
Low and thinnness, sir.
Plaque index is low and thinnness. Or
Yes,
thinnness
sir.
and low?
Sir,
is it thinnness and low or lower thinnness?
sir.
Anyways, did you use any cyanoacrylate gel
No.
to for sealing the pocket after you place the tetracycline fibers?
No, sir.
Do you think that without sealing it, will the tetracycline fiber be contained inside the pocket?
Sir, I would have used it, but I have not used it, sir. But yeah, it has to be used in order to maintain the tetracycline fibers into the pocket.
Yes. Can you tell me the role of tetracycline fibers?
Yes,
Why
sir,
have
sure.
you used? What is the rationale?
So basically, these fibers they have anti-inflammatory actions. They have collagenase inhibition action, and they inhibit the bone resorption. And also, their ability is to promote the attachment of the fibroblast to the root surface. So, and moreover, the concentration is also higher when used as a local drug delivery agent, sir. So that's why I've used tetracycline fibers, sir.
Okay, thank you. Over to Dr. Manoj.
Okay, thank you, Dr. Mahesh. Thank you.
Yeah, thank you so much, sir. Yeah.
Okay, thank you, Dr. Mahavish. We can now move on to our next presentation by Dr. Manjari Ante.
Hello, am I audible?
Yes, you are audible. You can start now.
Good afternoon, everyone. My presentation topic is a questionnaire study on evaluation of oral hygiene awareness among dental students. Coming to the introduction, the prevention of oral disease is the most acknowledged and efficient method of ensuring oral health. Dentists are the most common sources of receiving oral health information. To redirect the focus of oral health professionals towards effective preventive interventions and to enable them to motivate their parents and to adopt healthy behaviors, and special educational programs need to be integrated into UG training and made available to established clinicians as required. Dental students, the future leaders in oral health care, have a significant role to play in public oral health education and its promotion. Dental students in general have been found to have positive oral health attitude, but their own oral health behavior must improve if they are to serve as positive models for their patients, families, and friends. Previous studies on dental students, which mostly measured on comparison of first and advanced years of education, showed that final year dental students had significant improvements in oral hygiene practices, attitudes, and behavior. So, the aim of this study is to compare oral health knowledge, attitude, and self care practice behavior among dental students. A questionnaire was prepared regarding oral health attitude and behavior. 150 questionnaires were responded by the dental students, and the inclusion criteria included 75 preclinical and 75 clinical students. Chi-square test was used to compare oral health attitude and behavior of preclinical and clinical students. P less than 0.05 is considered statistically significant. No significant differences were observed between preclinical and clinical students regarding the following questions. That is the main purpose of toothbrushing, meaning of dental plaque, effect of retention of sweet food on teeth, etc. Statistically significant results were seen for attitude questions. Coming to the discussion part, as a major part of their role in oral healthcare provision, dentists are considered experts in the field of oral health education and promotion. The first step in establishing a positive oral health habit is to provide significant knowledge to patients and to raise their awareness regarding the ways to prevent oral health diseases. The results of present study indicate that percentage score for oral health knowledge, attitude, and behavior of clinical students were significantly higher than that of preclinical students. All study participants were dental students, thereby reducing the probability of bias related to misconception and errors in interpretation of concepts that exist in studies using self-administered questionnaire. So we conclude that the findings of present study highlights that the students had rather low oral health awareness in the beginning of their dental education. Thank you.
Thank you, Dr. Manjari.
So I'm not audible.
Yes, you are.
Dr. Manjari, can you tell me, did you validate your question?
Yes, sir.
Did you validate? Did you validate
Yes, yes.
your question? Do you know
Yes,
what
sir.
is validation means? Do you know what validation means?
No, sorry, sir.
Have you validated your questionnaire? The questionnaire you used in the study to
Yes,
carry
yes.
out the analysis, did you
Yes, sir.
validate it? How did you validate?
So three questionnaires were distributed. First was the knowledge questions, second the attitude based questions, and third the behavior questions.
Okay.
Yes.
So this is not the procedure of validation. Or have you used already a validated questionnaire?
No, sir.
I don't think you're getting it. You
Yes,
should read
yes.
about the validation of questionnaire.
Yes, yes.
Over to Dr. Manoj.
Okay.
Yes, Dr. Manjari. Okay,
Yes.
so based on your study, so what do you think can be done to improve the awareness among first and second year BD students? According to your study, they have less awareness, right?
Yes, sir. Yes, sir.
So what do you think can be done
So
to make them more aware?
mostly clinical subjects with such as perios and all. I think it must be included from UG during the UG training, and more awareness is needed according to that.
No, but see, since once the students have entered BDS, they will be aware about it, right? So since
Yes,
your
yes.
results tell that they did not have that much awareness as compared to the clinical participants.
Yes,
So
sir.
can you do something in the curriculum or something?
Yes, sir. Actually, there are limitations for my study that screening of intraoral clinical status was not done.
Okay.
And the tendency towards socially desirable response cannot be completely excluded, especially when using these self-assessment tools.
Okay. Thank you, Dr. Manjari.
Yes. Okay. Thank you.
Okay, thank you, Doctor.
Yes.
We can have now our next presentation by Dr. Meera M. Nair.
Good evening, respected juries. The topic of my presentation is a trick of flight. Hello?
Yes, yes, you can go ahead. You are audible.
Hello?
Yes, doctor, you are audible. You can go ahead.
Okay. Thank you, sir. A trick of light, a randomized control track evaluating the photodynamic therapy in fixed orthodontic patients. The aim of the study is to evaluate the antimicrobial and anti-inflammatory effect of curcumin and toluidine glue-mediated photodynamic antimicrobial chemotherapy on dental plaque patients as on plaque accumulation as an adjunct to scaling and root planing in adolescents undergoing fixed orthodontic treatments. The inclusion criteria is the patients included were under the age of 12 to 18 years. The gingival index score and plaque index score should be more than 1.1, and the probing depth should be less than 3 mm. These were my armamentariums. And coming to the clinical parameters, I've evaluated the plaque index and the gingival index. Now, the patients were randomly allocated into 3 groups. That is group 1, that is ultrasonic scaling with PDT, that is using the toluidine glue or dye. Group 2 is ultrasonic with PDT, that is with curcumin, and group 3 is ultrasonic scaling only. So the photodynamic therapy was given at baseline and at 15 days. So these were the 3 groups in which the clinical parameters were evaluated at baseline and at 30 days. And then microbiological analysis was done for each groups in baseline and 30 days. The subgingival plaque was collected before taking clinical measurements at each of the 2 specified time periods, that is at baseline and at 30 days. Then the results were evaluated. On seeing the results, we can see that on intra-group comparison, the results were statistically significant in all the 3 parameters, that is the plaque index, gingival index, and the microbial level. And on the intergroup comparison, we can see that results were not statistically significant. So coming to the discussion, all the three modalities showed significant improvement in the clinical parameters, but group 2 showed slightly higher reduction in the microbiological results at 30 days, though it was not statistically significant. Similar results have been evaluated by Condros et al. And Abalan et al. In 2018. Coming to the conclusion, it can be concluded that photodynamic therapy acts as an adjunct to ultrasonic scaling and can be used in, and it can reduce the bacterial recolonization in orthodontic patients. Thank you, sir.
Okay, Dr. Meera.
Yes, sir.
A nice presentation. Okay, I just
Right,
wanted
thank
to ask you two questions. First, how did you collect the plaque sample?
So the plaque samples were collected before taking the clinical measurements at 2 time intervals, that is at baseline and at 30 days. And the samples were placed in 1 ml of phosphate, that is PBS solution. And then the medium which I used in this study was trypticase soya agar broth. And then it was vortex for 10 seconds and a series of 10-fold dilution was done under anaerobic condition.
And what method was used for plaque sample collection? Hello?
Hello, yes, sir.
What method was used for plaque sample collection?
So subgingival plaque sample was collected with the help of curette.
Curette, okay. And second question, apart from toluidine glue, can you use any other agent for photodynamic therapy?
Yes, there are different types of photosensitizers which we can use. These are, that is coming into the tricycline dyes, we have acridine, orange and riboflavin. Coming to the tetrapyrols, we have porphyrins and chlorophyll. Coming to the curcumins, we have xanthophylls and etc. And then again we have the generations of photosensitizers.
You are not audible, Meera, properly. There is some disturbance at your end.
Second generation and third generation. So in that.
Okay, okay, fine. Thank you, Meera.
Yeah, thank you, Meera. Question. Nice presentation.
Okay, thank you, Dr. Meera. We can now move on to our next presentation by Dr. Ankita Garg.
Good evening, sir. Am I audible?
Yes, you are audible. You can carry on.
Good evening, everyone. Today I'm going to present my poster on pinhole surgical technique. That's a new innovation for the treatment of the marginal tissue recession. As we all know, dental aesthetic is one of the major concerns of patients these days. Dr. John Chow introduced a new minimal invasive technique that's called as Chow pinhole surgical technique, or also known as pinhole gum rejuvenation technique, that will give immediate cosmetic results to the patients. It's a scalpel-free, suture-free, graft-free, minimal invasive procedure for correction of the gingival recession. The main objective of this technique is to cover the exposed root surface and thus saving the tooth from further recession and the bone loss. This technique is mainly indicated in cases of localized gingival recession, basically mirrors grade 1 and grade 2 recessions. This technique is also indicated in the patients who complains of sensitivity but without having very active periodontal disease or gingival inflammation. Methodology for this technique, if a patient comes with a recession, localized recession, let's say in the canine, so we just made, after administration of the local anesthesia, we made a pinhole entry point into the mucogingival fold, and the specialized instruments are inserted through this entry point and loosen the fibrous tissue from the bone. Once the passive mobilization is achieved, we will simply glide the instrument and the gingival tissue into the coronal direction. After that, we will insert the collagen strips to the same entry point in the subgingival space till the interdental papilla and the facial surface. This will be done till the full thickness is achieved. So basically, this collagen strips will help in the wound stabilization during the healing for the root coverage procedure, as well as they will act as self-retentive coronal position. So in step 5, we can see the healing after the 24 hours. In step 6, we can see the healing after 1 month, and we can see excellent healing in step 7 after the 6 months. So main benefit or the basic advantage of this technique is that the multiple truth can be treated just in one sitting. And since there is no incision, no sutures is needed and no need to take the donor tissue also. So the post-operative recovery and healing will be faster as compared to the other techniques. But since every technique has its own pros and cons, so this technique is also contraindicated in advanced bone loss cases where there is minimal attached gingiva or the thin gingival biotype, or in the patients who are immunocompromised or smokers. So we can conclude here that pinhole surgical technique is a very promising technique for the treatment of the multiple marginal tissue recession with the minimal patient discomfort and the maximal aesthetic outcomes. It's a good alternative with the other traditional method that are earlier used for the marginal tissue recession. To know more about the technique, the further studies with longer follow-ups are still required. Thank you.
Thank you, Dr. Ankita. Ankita, is it a case report, what you were presenting?
No, sir. It's just I'm trying to explain the methodology of this technique to these pictures.
Okay. The case which you have shown in your poster is not your own?
No, sir. It's my senior's case, and I have assisted in this case.
Okay. Do you know what instrument has been used?
Yes, sir.
Okay.
Sir,
Can
this
you
is
explain those instruments?
Yes, sir. So we made the entry point to the urban interdental knife, and so then this elevator is transmucosal papillary elevator.
Is there a specific elevator?
Yes, sir. This is transmucosal papillary elevator. It's a contra-angle instrument that can easily get into the tissue, and we can then expand the gingival tissue and then further slide the tissue into the coronal direction.
So how much of recession coverage can be achieved by this pinhole technique?
So according to the studies, the results were good, and so we also got 90% root coverage was there. Till 6 months, when we recalled the patient, then it was theirs.
So what all difficulties did you face while doing this pinhole surgical technique?
So there was chances of gingival tear, first of all, that we feel like there was a little bit if the
sensitive.
Yes, it is technique sensitive.
Okay. Thank you.
Thank you, sir.
Over to you.
Okay, thank you. Dr. Ankita, good presentation. I wanted to ask you, what do you think is the advantage of this technique over a coronally repositioned flap, since it is a slight modification of that? So what do you think is the advantage over that?
The coronally advanced flap?
Yes. So you're placing
the
margin. Yeah, please go ahead.
In coronally advanced flap, we give the vertical incisions also. So that will hamper the lateral vascular supply. So somehow it will affect the healing. In this technique, we will not give the vertical incision. So the healing will be faster.
Anything else? Correct. This is correct. Anything else?
Sir, in this, and so one more thing, we'll give incision in the coronal advanced flap. We'll give the circular incision also. So, sir, in this technique, there is no incision and no placement of sutures. So, sir, we are saving the patient time also, and the patient comfort level will be also better with this technique.
And secondly, the vestibule will not be compromised in this technique. In coronary reposition flap, the vestibule becomes shallower, right?
Yes, sir.
Okay, thank you. Thank you, Ankita.
Thank you, sir.
Thank you, Dr. Ankita. We can now move on to our next presentation by Dr. Vedika Halan.
Good evening, respected judges. My topic for the poster is comparative evaluation of the tensile strengths of polytetrafluoroethylene, black silk, and nylon sutures and in vitro study. So starting with the introduction, the primary function of the sutures is to oppose the wound edges of the periodontal flap, and tensile strength is one of the characteristics that needs to be maintained because the suture material tends to lose its initial strength of 70 to 80% during its immersion in the saline solution. So the objective of the study was to evaluate the tensile strength of PTFE, nylon and black silk sutures, and to compare the intergroup comparison of the tensile strength. So after the approval of the internal ethical committee, the I had taken 3 sutures, PTFE of the company Golnet, nylon of the company Ethicon, black silk of the company Ethelon. And to standardize it, I have taken it 50 USP caliper sutures. So a 60 centimeter long suture material was taken. It was divided into 4 groups, 15 centimeter long each, according to the immersion time in the artificial saliva. That is and the tensile strengths were checked at pre-immersion, post-immersion after 3 days, at 7 days, and at 14 days. The tensile strengths were checked using material testing machine Instron. So as you can see, the result showed, the graph shows the tensile strength of the material in megapascal. So the green bar shows the tensile strength of PTFE, pink shows for black silk, and blue shows for nylon. So as you can see, the tensile strength of PTFE is higher compared to the nylon and black silk sutures and is maintained throughout. So according to coming to the discussion, according to the results, PTFE and nylon had better dimensional stability than black silk due to less fluid absorption, which affects its tensile strength. So PTFE, when comparing PTFE and nylon, both show dimensional stability when immersed in artificial saliva, but PTFE shows greater strength as it is hydrophobic compared to nylon. These results does not give a ranking on what material is better, but gives a better option in choosing which material is better according to the surgery that needs to be done. The limitation of the study is like more clinical research is required. I would like to conclude that the work showed that when comparing the in vitro tensile strength of PTFE, nylon, and black silk sutures, there was no statistical significant difference. However, the individual comparison showed that PTFE sutures maintain its dimensional stability against the tensile forces, which allows the material to be considered as an alternative with respect to its availability and cost. Thank you.
Okay, Dr. Vedika, it was a good study. I wanted to ask you, so according to your study, or in general, which suture material out of these 3 would you prefer for a GBR as in implantology, and why?
The PTFE would be preferred because it will maintain the soft tissue for soft tissue approximation around the implant site for a longer period of time.
Why?
So because the tensile strength won't be affected as the material is hydrophobic, the saliva in the mouth won't affect the tensile strength. So the chances of loosening of the knot or breakage of the suture material will be less compared to the others.
Okay, that is any other reason? Any advantage of PTFE compared to other 2?
So it's natural, like it has other properties like it is non-sticky, monofilament.
Yes, that was since it is a monofilament, it is preferred because the chances of infection will be less as compared to a multifilament, right? Okay, thank you, Vedika.
Thank you, sir.
Over to you, Dr. Saurav.
Yeah, thank you, Vedika. It was a nice study, at least of a clinical importance. Thank you.
Thank you, sir.
Okay, thank you, Dr. Vedika. We can now move on to our next presentation by Dr. Sayali.
Yes. Good evening, sir. The study of my today's poster presentation is the comparative evaluation of efficacy of Appium graveolens L and the chlorhexidine gluconate mouthwash in the treatment of gingivitis, a randomized controlled clinical trial. As a gingival inflammation is a polymicrobial infection that has been treated utilizing a various mechanical and chemical plaque control agent. Among all this treatment, due to the unwanted side effect and the toxicities, the tilt toward the herbal therapy is again going to a momentum. Appium graveolens L is an easily available natural product which is well known as its anti-inflammatory, antimicrobial, and antioxidant activity. This study aim at evaluating the effectiveness of Appium graveolens L mouthwash in comparison with the commercially available chlorhexidine mouthwash. The inclusion criteria will be a systemically healthy patient with the age range of 25 to 50 years, dentition with more than 20 teeth, no severe periodontal problem, no removable prosthesis or orthoband patients. The exclusion criteria will be persons allergic to any mouthwash compound and history of tobacco smoking, pan intake or anything, and any oral lesions. The patients were randomly allocated into the three groups with a in the first group I have done all the group I have done scaling. In the group 1, Appium graveolens L mouthwash was given to the 10 patient. In group 2, scaling and chlorhexidine mouthwash given, which is 0.2%, and in group 3 only placebo mouthwash with distilled water was given. The parameters assessed will be at the baseline, 14th day and the 21st day, and the parameters will be modified gingival index by Loben et al., Pingley-Hen plaque index and modified by Tursky, and gingival bleeding index. The result of all the three groups shows the significant reduction in the gingival plaque and the bleeding score following the scaling. However, chlorhexidine group shows comparatively better reduction of the above score than the Appium graveolens, and the Appium graveolens which shows term better reduction than the placebo group, which is showing the statistically significant result. Coming to the conclusion, Appium graveolens L is a natural product which is cost effective, easily available, and has a minimal side effect. Adjunctive use of Appium graveolens mouthwash seems to have a promising role in the treatment of gingivitis. Thank you, sir.
Thank you. Can you tell me what is the purification process of this APM granulose or whatever celery you have used for mouthwash?
Yes, sir. First, I have taken it from the markets, and then the leaves were washed thoroughly under the running water to remove all the adhering particles and all thing. Then we have dried it, dried the pieces and grounded into the coarse in the powder form, sir, by using a grounder, and stored in a well-closed container for the further use. Then we have done the taken 200 milligram of extract in a sterile beaker and mixed with the water, so 100 ml, and the beaker is placed on the hot plate for the magnetic stirrer at 60 degree to dissolve the extract in the solvent. When the homologous solution was obtained, we mixed it in the 900 ml of distilled water to make the final volume of 1000 ml. And we done the maceration for the 3 days, and we filtered by using a filter paper, sir. On third day, we poured it into the bottles, sir.
Whether this product has been used earlier in or has been researched, or this is the first of its kind study?
No, sir. In vitro studies are there, sir. And one in vitro study where they use in the toothpaste form, sir. They found good result with this, sir.
So this is the first time you are using as a clinical study as a mouthwash?
Yes, sir. In a clinical study as a mouthwash.
Fine. Thank you.
Yes, sir. Thank you, sir.
Dr. Monas.
Okay, Dr. Sally, it was a good presentation. I
Thank you,
just wanted to ask you, since you have taken only the clinical parameters, right?
Yes, sir.
So how do you justify the role of celery? Because could you have taken something else to justify? Because even after scaling and root planing, you will have resolution of the symptoms. So how do you justify its role? Could you have done something else along with the clinical parameters?
Actually, I have taken the control group, sir, where I use just a distilled water, sir. So in that patient, the results are superior with the Appium graveolens mouthwash, sir, rather than the distilled water.
Superior as in?
As in the clinical inflammation was reduced in this patient.
It was not reduced in the patient in where you did not use this?
The results are found very better, sir, in less time. Like I have followed for 21 days, sir. In 14th day, the Appium graveolens mouthwash patient are showing the good results on 14th day only, rather than.
Yeah, that is fine. I just wanted to ask, could you have done something else which you could have strengthened your study more? You could have done a microbiological analysis as well, right?
Yeah, yes, sir. Yes, sir.
Is it not?
Yes, sir. Yes.
That could have strengthened your study. But anyhow, it was a very good study. Thank you.
Yes, sir. Thank you, sir. Thank you.
Yeah.
Thank you so much, Dr. Sayali.
Thank you, sir. Thank you.
We can now move on to our next presentation by Dr. Prerna.
Good evening, sir. Sir, am I audible?
Yes, you are audible. You can go.
Good evening, respected judges. The topic of my poster presentation is third generation barrier membrane as a gingival dressing for the treatment of gingival pigmentation, a clinical and a histological study. The aim of the study was to compare clinically and histologically the efficacy of platelet-rich fibrin and alone and tetracycline incorporated platelet-rich fibrin on wound healing after depigmentation procedures. The inclusion criteria of the study was patients having Dummett score classification class 2, patients who were concerned about their aesthetic appearance, patients willing for informed consent for the study protocol. Clinical and histological parameters which were evaluated were visual analog scale for pain, healing index given by Landry et al., and histological analysis healing given by Schaefer's et al. Institutional ethical committee criteria was taken from the institutional ethical committee. In this study, split mouth study, total of 10 patients were divided into 2 groups. After laser pigmentation, on one group, tetracycline incorporated PRF was used as a gingival dressing. On another group, only PRF was used as a gingival dressing. PRF was made according to the protocol 300 RPM for 10 minutes. Whereas tetracycline incorporated PRF was made by adding 8 mg/ml of tetracycline to the fresh blood sample, and then the similar protocol was followed. This is the preoperative picture. This is immediately post-operative. Then this is the picture in which control group. This is the picture in which the tetracycline was placed. On 5th day, visual analog scale and healing index was checked, and scalpel biopsy for histological analysis was taken. Now coming to the results. Statistically, there was no difference in VAS score for pain between both the groups, whereas when healing index was compared, test group showed better results. On histological analysis, patients in PRF group showed reportedly moderate healing, whereas tetracycline showed well-organized healing. Now coming to the discussion, according to Dohan et al., provides a thrombin-enriched structure that is favorable for the migration and entrapment of cells and other soluble molecules that play a critical role in regeneration. According to Kobayashi et al., with additional benefits were seen in PRF with antibiotics like epithelialization and release of growth factors. Devnath and Dahiya et al. Conducted a similar study where they reported similar scores and results in terms of VAS scores and healing index. Coming to the conclusion, the application of PRF or tetracycline incorporated PRF can be considered to protect the raw wound area of the depigmented sites. However, tetracycline incorporated PRF group showed faster healing. Thank you, sir.
Okay, Dr. Prerna.
Yes, sir.
Can you tell me how you incorporated tetracycline into PRF?
So the tetracycline was incorporated 500.
How did you use the tetracycline? Like, was it in a capsular form or?
So tetracycline which was available in capsule form was mixed in 100 ml of distilled water. Then the quantity 8 mg per ml was obtained, and that was added in flush blood sample, and then the centrifugation was done at 300 RPM for 10 minutes. 3000 RPM for 10 minutes.
3000 RPM. Okay. Fine. Thank you. Over to Dr. Manoj.
Yeah, Dr. Prerna, it was a good presentation.
Thank you, sir.
In just addition to what Dr. Saurav asked, so do you have any fixed protocol for this addition of tetracycline to PRF? Have you followed any protocol, standard protocol?
Yes, sir. There was a study conducted by Cheng et al. In 2009. They have used similar quantity of tetracycline in barrier membranes. That quantity we have also only used. But in 2019, Polak et al. Also considered a study in which they have given the quantity. We have followed the same procedure.
Okay, and it can be used for all procedures or only for depigmentation?
Sir, actually, this is the first study in which tetracycline antibiotic incorporated PRF has been used for depigmentation, but there are various other studies where they have checked soft tissue healing after various other flap surgeries, and it have provided good results.
Okay. Okay. Thank you, Prerna. Thank you.
Thank you.
Okay,
Thank you, Dr. Prerna. Tech team, can we now move on to our next presentation?
Just 1 second. Ashish.
Yes, sir. Yes, sir.
Just tell the presenters not to keep the video on when they are for Q&A.
Yes, sir. Yes, sir. I am hinting them to on their video.
Yeah.
Yes,
please
sir.
do that. Yeah.
Yes, sir. Yes.
Good afternoon. Am I audible, sir? Hello.
Yes, you are audible. You can start now.
Okay, good afternoon, respected judges. The topic of my poster, it is effects of ozonated olive oil and laser photobiomodulation on healing of gingival depigmented wounds, which is a randomized did-not clinical short study. Photobiomodulation using diode laser, it is regarded an effective modality for tissue repair and control of pain. And ozone, owing to its biocompatibility, healing, and antimicrobial properties, its use in dentistry is becoming popular as well. So therefore, the aim of this study was carried out to compare and evaluate healing of gingival depigmented wounds using ozonated oil and photobiomodulation. In the inclusion criteria, systemically healthy patients exhibiting bilateral gingival pigmentation on the anterior maxilla and mandibular anterior, they were included in this study. Now coming to the method, first laser depigmentation was done on all the patients using diode laser, which is the BioLase Epic X with a wavelength of 940 nanometer. And after the depigmentation procedure was done, then the sites were randomly divided into two halves. So on one half, ozonated oil was applied for 30 seconds, which is group 1. And on the other side, laser photobiomodulation was done using the laser in a defocus and non-contact mode using the curved tip using the curved tip which comes with the laser, and the power was set to 1 watt, and the photobiomodulation was introduced for 5 minutes. Then this is group 2. So this procedure, it was done immediately post-operative on the 3rd day and as well as on the 7th day. And the clinical parameters, which was visual analog scale for pain and healing index according to Landry et al., they were evaluated on the 3rd day, 7th day, and 15th day. So the results obtained was that statistical analysis showed better healing index in group 1 as compared to group 2, and on the 3rd day compared to group 2 only on the 3rd day, but it was comparable in both groups on the 7th as well as 15th day. And no statistical significant difference was observed in VAS between the two groups during the follow-up periods. Therefore, in conclusion, we have concluded that both the treatment modality, they were ozonated oil, they promote the initial wound healing as compared to photobiomodulation, and that both treatment modalities, they have the same efficacy in controlling the pain. Thank you.
Okay.
Yeah,
Doctor.
you can speak.
Yeah, no, Tangma, it was a good presentation. I wanted to ask
Thank
you,
sir.
You have used ozonated olive oil, right?
Yes, sir.
So what are the other oils which have been used before, and why do you think olive oil is better or similar to other oils which have been used before?
Sir, the benefits of using ozonated olive oil is that in certain studies they have found that this because of its availability and low cost first and foremost, and also in various studies they have found that this ozone oil when it comes in contact with the human blood, it led to an increase in the release of cytokines, increased release in cytokines, as well as some growth factors like the transforming growth factor beta, and also in reactivating the antioxidant system, which are important in during the healing period.
Okay, thank you, Dr. Tangma. Over to you, Dr. Saurav.
What was the frequency of application for this ozonated oil and photobiomodulation?
Sir, this treatment modality, it was given immediately post-operative after doing the laser gingivectomy, laser depigmentation. Then the patient were recalled on the 3rd day and on the 7th day. So on the 3rd day, 3 times.
Just had one application.
One application per appointment. So yes, one time.
Okay. Thank you.
Thank you.
Thank you so much, Doctor. Tim, we can move on to our next presentation by Dr. Pavitra.
Yes, sir. Am I audible, sir?
Yes, you are audible.
Good evening, everyone. I'm Dr. Pavitra, and I would like to share with all of you a little bit about needleless anesthesia and the use of it for the non-surgical treatment of periodontitis, that is scaling and root cleaning. I was interested in doing this because the fear of needles, or the needle phobia, or also known as the blenophobia, is amongst the top 10 phobias in the world, due to which the patient develops anxiety or apprehension towards the dental treatment, and basically it carries a negative impact on patient psychology. Though the periodontal disease itself is not a painful disease, but the first line of treatment, that is scaling and root cleaning, is a painful process for few patients. So to make the procedure comfortable for the patient and also for the dentist to do deliver his treatment more efficiently, local anesthesia is commonly used either in the form of infiltration anesthesia or nerve block with the help of classical needle injection. So, jet injector was pioneered by Hinkson and collaborators as early as 1947 for administration of insulin for diabetic patients to improve their compliance. Basically, it works on a principle of pressure dynamics. It consists of a high pressure device that propels a fluid drug through a fine orifice. At a higher pressure, the fluid pierces the epithelium and the underlying connective tissue without the use of needles. So in this study, my primary objective of the study was to evaluate the pain experienced by the patient during administration of anesthesia and during the root cleaning procedure, and to compare it with the classical needle injection. And as well as my secondary objective was to evaluate the duration of onset of anesthesia when the anesthesia was administered with the help of jet injector, and to compare it with the needleless needle injection, classical needle injection. So I have done a split mouth study. In this, I have taken 15 patients based on the age group of 18 to 70 years, and those who had VAS score of more than 30 mm, so that I have chosen only a pain sensitive patient, and teeth which have 5 to 10 mm of pocket depth. And the selected teeth I have divided randomly, categorized into either group 1 or group 2. In group 1, I have administered the anesthesia with the help of jet injector, that is Injex, and in the group 2, I have administered the anesthesia with the help of needle injection. So my results are as follows. We can see that the VAS score, which is during the administration of anesthesia, was less in case of group 1 and it was more in case of group 2. However, the VAS score during the root cleaning procedure, it was almost the same in both the groups. It was not statistically significant. Coming to the onset of anesthesia, it was less or it was faster in group 1 when compared to group 2. So statistically significant results were obtained for onset of anesthesia as well as VAS score during the administration of anesthesia. So I would like to conclude by saying that this needleless jet injector, it shows promise, and it has to be studied in further studies with a larger sample size and for other surgical procedures of periodontal therapy. Thank you.
Yes, thank you. Can you tell me, can you give a block with this Injex, or it is not possible?
No, sir. Only till now, infiltration only has been achieved, sir, not block. Yes.
So, what anesthetic agent did you use? Lidocaine?
Lidocaine only, sir.
Okay. Okay. Thank you.
Thank you.
Yeah, Pavitra, it was a good study. So
Thank you,
as
sir.
Dr. Saurabh asked, because it has not been tried for blocks, so its application is limited to scaling and root cleaning. We cannot use it for more aggressive surgery,
any
I guess.
procedures which can use an infiltration anesthesia, we can use this, sir.
Okay. Okay. Thank you, Pavitra. It was a good presentation.
Thank you, sir.
Thank you, Dr. Pavitra. We can now move on to our next presentation by Dr. Ayushi Sharma.
So my poster is not.
Tech team, can we have some help here?
So this is not my complete poster.
You can download it and then play it. Okay. Tech team, I think we can skip this now. We can come to Ayushi later.
Yeah, Ayushi, please keep your presentation ready with you. You have to share your screen. Okay.
Yes, yes. We will get
All
back
right,
to
sir.
her.
All right.
Next, we should proceed with Dr. Aradhana Sharma, if she is ready.
Yes, sir, I'm ready.
Yes, you can. You are up now.
Okay, sir. The topic of my poster, good evening, everybody. The topic of my poster is gingival tissue response following placement of different periodontal dressing materials after periodontal flap surgery. Now, we all know that the sequelae of periodontal surgery is commonly pain, swelling, inflammation, and bleeding. So, therefore, it is necessary some kind of protection is required over the traumatized tissue, and so we offer periodontal dressings or packs over that to cover the wound from postoperative irritation, trauma, any kind of food stagnation or salivary contamination. Now, the aims and objectives of my study is to compare and evaluate gingival tissue response following placement of different periodontal dressing materials after periodontal flap procedure. Now, the inclusion criteria included 20 to 55 years of either sex, systemically healthy patients, and a pocket depth of more than or equal to 5 in all four quadrants. A split mouth study design was taken, and the exclusion criteria included smokers and tobacco chewers were excluded, pregnant and lactating women were excluded. Now there were four groups in my study. The group since it was a split mouth study, so the four quadrants were assigned in only one patient, and in first quadrant, flap surgery was done, followed by application of Copac, and similarly in second quadrant after flap surgery, Barricade, a visible light curing agent was used over the flap post-operatively, and then in third quadrant, flap surgery plus curcumin gel was applied over the wound, and similarly in the fourth group, sutures alone were placed. Now, all the clinical parameters were wound healing index, plaque index, modified circular bleeding index, plaque under dressing, that was plaque retention factor, visual analog scale, and visual response were checked, that were tissue edema and tissue color. Follow-up was done at day 7 and 14. So in each group, there was a significant change in all the clinical parameters at day 7 and day 14. And the wound healing index showed that all the groups significant improvement was seen in group in wound healing index at day 7 and day 14. Similarly, in plaque index, Copac and sutures showed significant plaque accumulation, and both the other groups then were having non-significant results. And then the curcumin gel was regarded as the best alternative after post-operative dressing, post-operative flaps. And my study concluded that non-eugenol dressing seemed to retain more plaque on its undersurface than light cure dressing, and curcumin gel was best because it was having anti-inflammatory and more antioxidant, anti-inflammatory, and good clinical results. But there was not any kind of influence on the healing outcome in all the other groups, and therefore the light cure dressing in curcumin gel was the best. Thank you.
Thank you, Dr. Aradhana. Can you tell me how did you apply this curcumin gel? Did you have any base to apply it, or it was just a gel which is applied on the surface and left off?
Sir, the gel was, the brand name was Kionix gel, and 1 gram of gel was there, and the patient was asked to apply it himself or herself only.
How much
And there was no base, it was applied over the flap.
So it is basically an opaque concept by giving gel application.
Yes, sir.
Okay. Thank you.
Okay.
Welcome.
Okay, Dr. Radhana, it was a good presentation. So as Dr. Salah asked, so since the gel has to be applied by the patient himself or herself, don't you think it will be a little tedious for it to reach the posterior most areas? Did you notice that? Suppose it is the third molar, is it easy for the patient to apply in the third molar area if you're doing a quadrant?
Sir, I agree that some kind of bias can be seen when we tell patients to do that, because some of the patients may skip that. So This is a limitation, one of them.
But according to your study, this was the best among all the 4 facts.
Yes, sir. This one and barricade was also up to the mark as compared to Copac.
Okay, so this curcumin gel, is it hydrophobic or hydrophilic? Any idea?
Sir, basically it is hydrophobic.
Okay, so it will. So when the patient came for
It
follow-up,
has.
Yeah, you can carry on. Carry on.
Sir, because this gel is since this gel is having less bioadhesive property, but still it has properties like anti-inflammatory, because the mechanism of action of this gel includes the inhibition of prostaglandins, which result into COX-2 inhibitors. They are inhibited here, and so that is why there is no kind of inflammation or tissue edema in cases of this gel.
Okay, thank you, Ratna. Thank you.
Radhana,
Okay,
can you
thank you.
gel as a periodontal dressing?
Sir, there are certain studies by Anita and
the main function of a periodontal dressing is to give this physical barrier. The curcumin gel is not providing the physical barrier.
Yes, sir, I agree with this, but sir, to make this study more enhanced, so I used a gel as a kind of dressing material, because various studies have been done. Even chlorhexidine gel has been used as a dressing material in some of the studies. So for that purpose.
Okay.
Thank you, sir.
Okay, thank you, Dr. Aradhana.
Okay, sir. Thank you.
We can have our next presentation.
Dr. Ayushi, please share your PPT. And then Dr. Gurpreet, please keep ready your presentation with you.
Dr. Ayushi, are you ready now?
Yes, sir. Just sharing my screen.
Yes.
Sir, is it visible?
Yes, it is visible and you are audible. You can carry on now.
Good evening, jury members. The topic of my poster presentation today is alendronate, a wonder gel in the treatment of intravoni defects. So the aim of my study was to clinically and radiographically evaluate the osteogenic potential of nanocrystalline hydroxyapatite plus beta tricalcium phosphate, that is Cybograph plus, alone or in combination with 1% alendronate gel in the treatment of intravoni defects, a clinico-radiographic study. So the inclusion criteria for my study was systemically healthy subjects aged 25 to 60 years old, patients having intravoni defects with probing depth of more than or equals to 5 millimeter, and subjects who were willing to comply and sign the informed consent form. So the clinical and radiographic parameters were as follows: the Tureski-Gilmore-Glickman modification of Quigley-Hinn-Plaque index, gingival index, pocket probing depth, relative clinical attachment level, and in the radiographic parameters, linear bone growth, percentage bone fill, change in alveolar crest height. These were the armamentarium, the cybograph, and the in the bone vial there is alendronate gel with the bone graft. In both the groups, as you can see, there is the first figure is the radiographs which are at baseline, then at 3 months and 6 months. Then the first figure shows reflection of full thickness flap in both test and control group. Then the placement of graft in the defect. In the test group, the graft was mixed with alendronate gel, which was formulated in the pharmacy department of my college.
and then the sutures were placed. Coming on to the results, there was a mean reduction in pocket probing depth, and relative clinical attachment level value was found to be significantly higher in the test group. And the linear bone growth and the post-operative percentage bone fill values were significantly higher between the test and control group from baseline to 6 months. Coming on to the discussion, in accordance with my results, Veena et al. In 2010 found a statistically significant difference in the percentage fill of original defect at the end of 6 months in favor of the alendronate gel group when compared to the placebo gel group. And similar results were concluded by Kumar et al. In 2014, Gupta et al. In 2018, Shiokant et al. In 2018, and Sharma et al. In 2012. When assessing the effect of alendronate along with SRP, they found greater reduction in pocket probing depth in the alendronate gel group. In conclusion, I would like to say that application of 1% alendronate gel is a promising and a beneficial adjuvant for the treatment of intrabony defects during surgical periodontal therapy. Thank you.
Okay, Dr. Ayushi, it was a good presentation. So what is the role of alendronate here?
Sir, alendronate gel is basically a bisphosphonate, a nitrogen-containing bisphosphonate. And so the mechanism of action is that it inhibits the osteoclast activity. And sir, it also inhibits the mevalonate pathway. So the proteins, it inhibits the prenylation of the proteins which are required by the osteoclasts for the ruffled border behavior, which then enhances their activity. So it inhibits those proteins in the mevalonate pathway.
Okay, and you have used cybograph, right?
Cybograph, yes, sir.
Any reason for selecting that graph?
Sir, we've used nanocrystalline cybograph is nanocrystalline hydroxyapatite and beta tricalcium phosphate. So, sir, the main advantage of this graft is because of the small particle size and increased surface area. So, there is rapid the substitution of vital bone of this graft. And so, secondly, because of the resorbing properties, sir, the beta tricalcium phosphate resorbs a bit slower than the hydroxyapatite, so it acts as a scaffold.
Okay, thank you, Dr.
Thank you, sir.
Thank you.
Over to you, Dr. Saurav.
It was a great presentation, IUC. Thank you. Proceed with the next poster presentation.
Yes, sir. Yes, sir. Okay, okay, Dr. Ayushi, it was a good presentation. We can now move on to the next presentation by Dr. Gurpreet Kaur.
Good evening, teachers. Good evening, everyone. Am I audible?
Yes, you are audible. You can carry on.
Thank you, sir. So, topic of my presentation is determination of the thickness of the palatal mucosa. As we know that there are various palatal surgeries are going on. Before performing any palatal surgery, a thorough knowledge of the anatomy of the palate and its underlying structures are very important, because lack of the knowledge of such structure may land up to you into the severe problems like invasion of the GP artery, etc. So the aim here is to determine the thickness of the palatal mucosa associated with the age and gender by using bone sounding technique. So I chose total of 24 patients. Inclusion criteria were the younger age group consisting of the 12 subjects, older age group consisting of 12 subjects, and the subjects with healthy periodontal tissues with complete dentition in the upper jaw and without third molar. And inclusion criteria were history of surgery in the palatal or tigrosterism, subjects with previous history or the presence of any disease of the palate. They are pregnant and lactating women were not included, smokers were not included, and the subjects with tooth malpositions were not included in the study. No, the procedure. First of all, I took alginate impression of all the participants, and stents were prepared. And over the stents, I have prepared several holes, like it is presented, like line A presented gingival margin, line B present 3 mm from the gingival margin, and the line C and D is 1/4 and half of the distance between the B and the P respectively. And the line B, C, D runs parallel to line A. These all markings were done over the cast, and later on, following these anatomic features, I transfer my that stent into the patient's mouth, and using the gential violet pencil, I mark the several points over the patient. Before performing any procedure, I have anesthetized the area completely using the local anesthesia. And concluding all the results, I put to discussion that the bone sounding technique is a direct clinical measurement using periodontal probe was completely employed in the study. The thickness of the palatal mucosa in the subjects of the age ranging between 16 to 54 range, it was seen like 2.5 to 3.7 mm. And the mucosal thickness was thinner in younger subjects as compared to the older subjects. It was between 2 to 4.5 mm, which is adequate for harvesting the graft in the younger age group. So the overall thickness of the palatal mucosa increased from the canine to second molar and further away from the gingival margin. The minimum mucosal thickness was obtained at the line D, second molar, because the probe may enter have penetrated into the soft palatal of the region. Mucosal thickness was observed to was more in the male patient as compared to the female patient. So with this, I concluded that the younger patient had a thinner mucosa than the older, and the canine and premolar areas appear to be the most appropriate donor site for the grafting procedure. My presentation is over, sir.
Yes. Thank you. It was a nice presentation.
Thank you, sir.
But I have some concerns. Like you
Yes,
have
sir.
used the clinical bone sounding method to determine the thickness of palatal mucosa.
Sorry, sir.
But yeah, you have used the bone sounding, the clinical method. Can you
Yes,
use
sir.
like there are so many more accurate and reliable options nowadays available, like use
Yes.
of ultrasound or use of CBCT to determine this palatal mucosal thickness. So
Yeah.
what reason do you give of choosing bone sounding as one of your modality?
So first reason is bone sounding is very easily available in my clinic, and so second thing, it is cost effective. So there is no need of more expenses for the patient. So it is friendly even. So no doubt there are.
Don't you think the accuracy is compromised with bone sounding?
No, sir. If it is done with the proper knowledge, then it is proving much better in various procedures even.
Okay. So what did you do to standardize this bone sounding technique?
So.
How did you standardize the measurements?
Yes, sir.
How did you standardize the measurements? Do you know what is standardization? No?
Yes, sir.
Am I audible?
Yes, sir.
Am I audible?
Yes, sir.
Yeah. Do you know what is standardization?
Yes, sir.
Okay,
Using the
anyways,
standard
over to
methods.
Dr. Manoj.
Okay, fine. Okay. Thank you. Thank you for your presentation.
Thank you, sir.
Thank you. Thank you.
All the best.
Thank you, Dr. Guptajit, for your presentation. With this, we are now on the end of the session and then end of the presentation show. From the on the behalf of ISP PG Convention and the scientific committee, I extend my deep gratitude to Dr. Manoj Kumar sir and Dr. Saurabh Panda sir for being the chairperson of this session.
Thank you, and we would like to take this opportunity again to thank the ISP and organizing committee for giving us this opportunity, and the sessions were very well conducted. Thank you.
Yeah, the sessions were really well conducted and it was smooth, and we got to learn from so many posters, new techniques, and what the students from all India are doing for their research.
Yeah, it was a learning experience for all of us, I guess.
Lovely meeting. Thank you.
Thank you so much, sir. And a gentle reminder to submit the evaluation sheet as soon as possible.
Yes, we'll do that.
Yes, sir. Thank you so much, sir.
We can log out?
Yes, sir. Yes, sir.
We'll submit the evaluation sheet. Thank you. Thank you.
Yes, sir. Yeah. Thank you, sir. I also extend my thanks to the tech team of Vama College. Thank you so much. Can we leave now?
Bye everyone. We are closing this meeting. Thank you. Good night.